Buenos días todos. Estamos el día de hoy celebrando y concluyendo el mes de herencia hispana. Estamos extremadamente felices de que nos vengan aquí con nosotros, con Cayenne Wellness Center, estén en el día de hoy en una emocionante día donde vamos a tener un numeroso miembros, eh, presentadores, moderadores, que son parte de nuestra comunidad. Es muy importante tomar en cuenta que el día de hoy vamos a tener a gente hablando en español, gente hablando en inglés, y es muy importante que tomen nota, porque mucha información que se dará durante el día es para ustedes, es para su uso, y estamos felices que todos nuestros miembros de la comunidad estén presentes. Como siempre, Cayenne Wellness Center está emocionado por el día de hoy y también está muy emocionado de comunicar que este no será ni el primero ni el último de los seminarios que estaremos haciendo. Esperamos en un futuro incrementar y crecer con nuestra comunidad que habla español. Muchas gracias. Dr. Raleigh.
Thank you, Mary, for that wonderful welcome. I'm so proud. Um, this is Mary. She introduced herself. She's our program manager, and it's such a delight to have her. Welcome, everyone, to our second annual Hispanic Heritage Sickle Cell Disease Educational Seminar. I'm so glad that we're here. 2 years now, right? And so we're focusing on our voice. Last time it was our story. We're focusing on our voice. And so the voices of those with sickle cell disease who are Spanish speaking that oftentimes might not feel as if they're heard. And so we hear you, and this is for you in terms of why we're doing this. We're responding, and so welcome you all. So no matter where you're coming in from, welcome, welcome, welcome. And so we are live streaming on different platforms. And if you happen to be in Zoom, I'm sure that you've already been told that you can listen to this in either English or in Spanish. And so just by touching a little global, looks like a little globe, and then from there, you'll pick the language that you want to be able to hear this for the entire time. So be with us throughout the day till about 4 p.m. And so we have so much in store for you. And there's a lot going on in the sickle cell community. And we wanted to just make sure that we touched upon that in this particular seminar. And so we are going to be talking about data. We are going to talk about, of course, you have to always have Sickle Cell 101. That's the crux, I believe, of any seminar. And then also how people are living with sickle cell disease globally in terms of where they may be coming from. Because again, this is a global disease. Despite what you may think or what you may have heard, it is a global disease affecting people from all over the world. We are going to have some fun, so there'll be an opportunity for you all to engage and have fun and learn in that particular way. And then, of course, we have to talk about sickle cell trait because we couldn't get here, those with living with sickle cell disease, unless both of our parents have had sickle cell trait. So, of course, we're going to have information on sickle cell trait. And then the other thing, too, is that there's a lot of, I encourage people to read, whether it's articles or actually just books written by sickle cell warriors, written by caregivers that can actually share with you in a fun way the facts about sickle cell disease. And then finally, we'll be ending with an open discussion. And so we're thankful that you're here. I want to say a few things about Cayenne Wellness Center. We've been here since the year 2000. We're dedicated to taking care of those persons living with sickle cell disease, particularly in California. We're known in this arena with respect to the education like this that we actually do. We have other things like Author's Corner. We also do advocacy, and we also have various initiatives that you may be privy to and that will be implemented shortly. So some of those things are in April, We actually implemented our mental health and wellness initiative. And so, what that means is that we recognize that mental health is important. And so, the community has been sharing that with us. So, as of April 1st, we launched an initiative that basically, if you live in California and you have sickle cell disease, you have access to free mental health. So, free counseling, free health coaching, free holistic consultation, and spiritual counseling. These things are free to our community based upon writing of grants that we continue to do to be able to support that. We also have another initiative about to come out on sickle cell trait. And so we all know that newborn screening is, across the U.S. However, what actually happens after the parents receive that letter? So our goal over the next 5 years, and we need ambassadors to do this. And so if you have sickle cell trait, you need to give us a call and/or email us. We're going to be looking for ambassadors, but our goal over the next 5 years is to be able to let everyone know what is your trait status. And we're going to be starting in middle schools, high schools, and in colleges across California. And so, if you happen to be residing in California and you want to be to assist us, there's an opportunity for you to do so. We also are going to be doing what we're calling a March on Hospitals. That should be coming out fairly soon, too. And this is just saying that enough is enough, and it's about time that we share with hospitals the right way to take care of persons living with sickle cell disease with evidence based care. So that'll be coming out as well. So I think the best thing for you to do is just follow us. Follow us and look at those things that we're doing. Find out what speaks to you, and we're always looking for volunteers. We just completed it's called the 14th annual, but it's been 16 years that we've done our educational seminar. This year was 3 days in September. And so it was phenomenal. And it was our first hybrid. And so and we're going to keep on doing that. And again, we're always looking for folks who are wanting to share their voice and their talent to be able to assist those in our community. So once again, thank you for joining us for our second annual. We're going to keep doing this. You let us know what it is that you would like to know more about, and we're going to implement that for our third annual. Thank you so much for joining us from wherever you are. And it would be great for you to actually type in the chat or wherever, whatever platform that you are on. We want to know where you're coming in from. Let us know how far reaching our outreach has been, and let us know, give us your name and where you're coming from in terms of your city, state, and country. All right, thank you so much. So I'm going to turn it back to Mary, and then we'll go to our agenda, which is a welcome. Mary?
Muchas gracias, Dr. Raleigh. Estamos muy contentos de comenzar este día con todos ustedes. Cualquier cosa que necesiten, por favor, para todos aquellos que hablan español, un pequeño recordatorio, como la doctora lo mencionó, en todo caso que hablas español y necesitas la interpretación, en Zoom vas a ver un pequeño mundito que dice Global, ahí vas a hacer clic y vas a encontrar el idioma donde vas a poder escuchar la interpretación de todo lo que pasa, ya sea en inglés o en español. Entonces, muchísimas gracias e inauguramos el día con mucha emoción. Ahora vamos a estar presentando a nuestros dos moderadores del día, que es Nilda Navedo y Servio Astacio.
Thank you. So at this time, we're going to welcome, let's see if we have perhaps Nilda and Servio to be able to bring on. All right. Our beautiful co-host. And so we're going to turn this over to you all, and we want you to do the welcome. Thank you so much.
Mm-hmm. Hi, good morning, Carolyn, Dr. Rowley, and Mary. Thank you for this opportunity. I am extremely overjoyed as it is a seminar and it is linking Latin community, especially as today is, we continue till October 15th, the last day of Hispanic heritage, but we always carry it in our hearts. Estoy agradecida. Primeramente, perdón, mi nombre es Nilda Navedo. Yo estoy agradecida por Cayenne Wellness. Pienso que la voz latina es presente, pero no estamos en la luz de abogacía. Yo soy nacida aquí en los Estados Unidos y soy de padre puertorriqueño y madre dominicana. Tengo anemia falciforme, soy SS con hemoglobina F, que es todavía producido en mi hemoglobina. Entonces, yo por la pandemia ayudó mucho a conectar los latinos. Uno ha tenido grupos que han hecho en Facebook y en WhatsApp y ha comunicado los pacientes, no solo los pacientes, pero como en nuestra cultura, toditos somos familia. He sido un área donde nos pudimos comunicar y darle ayuda y también conciencia a lo que es la enfermedad. Yo tengo 45 años y sé que cuando uno tiene una crianza que es falsémica es algo que da mucho miedo porque no es reconocida, todavía es una enfermedad que la llaman una enfermedad huérfana. Y pienso que son seminarios así que le va a dar luz a nosotros decir nuestras historias. Y estoy muy contenta que en el día de hoy hay secciones donde van a tener educación, van a tener un panel global donde uno va a aprender cómo uno ha manejado su enfermedad. Y de verdad no puedo decir la emoción que siento porque estoy muy alegre de que muchas personas van a ver las caras de las personas que son falsémicas, pero que vivimos en silencio. Y pienso que es muy importante uno compartir lo que es no solo la alegría, pero las penas que uno ha pasado. Y estoy también contenta que estoy con Servio, que también vamos a ser los moderadores de este evento. Y entonces te introduzco al señor Servio y pasamos este día y en comunicación y a ver las cosas que aprendemos con los presentadores. Gracias.
Hi, good morning, everyone. My name is Servio Estacio, and I'm currently co-moderating this event with Nilda Navedo, and I am very appreciative of Cayenne Wellness for always taking initiative to educate people from all different type of backgrounds, from an individual background, and also from a professional and or educational background as far as sickle cell anemia is concerned. With that being said, I do have also sickle cell anemia. I have the genotype SS, and I was born in the Dominican Republic. Both of my parents they had the sickle cell trait, and I ended up having the sickle cell disease. With that being said, my parents did migrate to the United States so they can find some sort of treatment for me. And the first place that they ended up going to was Pennsylvania. And 25 years later, I'm here. I'm working with everybody. I'm working with Cayenne Wellness. I'm working with Nilda in order to go ahead and educate and making sure that everybody knows how to identify, sickle cell anemia, the first steps, and, where to find treatment, and knowing that there's always somebody that is available for you for help or for advice, or, in case you need any information as far as treatment for sickle cell anemia. With that being said, I just give the microphone back to Nilda so we can go on with the event.
Thank you, Servio. Believed we will now have, and we're running good on time, we now have going to share with you the data that will be presented by Jacqueline Valle, and she will discuss sickle cell disease among the Latinx in the USA. And not sure if it's known, but also to know how much around the globe. Ahora le voy a presentar a Jacqueline Valle, que también ella va a discutir lo que es anemia falciforme entre la comunidad latina, no solo en los Estados Unidos, pero también en global, en el área global. Pues le presento a la señora Jacqueline Valles.
LA is a research scientist with Tracking California's sickle cell data collection program. She has extensive experience in health surveillance, data management, analysis, and quality assurance activities in both local and international settings. She currently works on developing data linkage processes and analyses. She is interested in health disparities and highlighting inequities through data. Welcome to Data, Sickle Cell Disease Among Latinx in the USA, part of the second annual Hispanic Heritage Sickle Cell Disease Seminar.
Good morning, everyone. I hope you can all see me. I believe my slides should be showing, so can someone confirm that you can see my slides, or should I be presenting them myself? I don't see. Okay, I will share my slides because I am not hearing confirmation that you guys can see them. So thank you to the moderators for inviting me to speak with you guys all today. It's really honored to be invited back a second year. And thank you to Nilda and Sergio for their wonderful welcome. I can't wait to kind of share with you some of the data that we have. So I'm going to wait till I get confirmation that you guys can see. Great.
I don't see them on there yet. If you want, have you already selected to present them?
I can go ahead and present them from my side, no problem. Let's make sure that they are up. Sorry, all. I sent those. Share screen. Apologies, everyone, for this. We're trying to pull them up right now. Okay. Here we go. Okay, do you guys see them now?
Not yet, no. So you would need to click present and then click slides and then move.
I believe it says it's processing. So I'm just going to give you guys a little bit of background about the program that I work with. So as they mentioned, I work with the Sickle Cell Data Collection Program. We conduct state-based surveillance for sickle cell disease. Oh, great. I can see my slides. Excellent. In California, we are funded from the Centers for Disease Control, and they recently, in the last couple of years, have gotten more funding so that we've expanded surveillance to 11 states. So that's great news because that means there's going to be better data coming out of multiple states nationwide, which I think is going to be really important as we kind of go into in a second. So we'll just went over that. So what does that mean that we do state-based surveillance? So what that means is we, in collaboration with a variety of partners and community-based organizations, including Cayenne Wellness, really work to gather and link a variety of sources of data from hospitalization, newborn screening, clinic data, kind of any type of healthcare utilization to be able to identify everyone living with sickle cell disease in California and be able to follow them over time. This approach of like longitudinal looking at people over time and population base allows us the opportunity to kind of look at areas for improvement and policies and programs that really could improve the lives of those living with sickle cell disease. So now to get into kind of some of the numbers. So you may have seen this number before. It's cited in a variety of papers. I cite it all the time in my own paper. It's on, I think I've seen it in every single paper that I've ever read that looks at sickle cell disease and ethnicity in the United States. So now I'm presenting this because I want to go a little bit deeper into where this number comes from. So this number actually comes from a 2010 publication. So that looked at data from 2005 through 2007. So it's fairly old data, and they looked at states all across the United States, looked at their newborn screening data to kind of estimate how many people in the United States with sickle cell disease were Hispanic, Latino. And so you can see it's 1 out of every 16,000 births could be identified as Hispanic Latino. And that varies between the East and the West Coast of the United States. As you can imagine, on the East Coast, that number is a lot. It's 1 for every 1,000, I believe. So they did provide that paper, that study did look at every single state. So they did provide some estimates for every state based on the population that lived in that state and what they found in their newborn screening data. So for California, they estimated that about 5% of people with sickle cell disease were Latino. I'll come back to this number a little bit later, but you know, all of these numbers, we know there's been a lot of changes in the population across the states. So we know these are probably very, you know, underreported, but it's kind of right now the best that we have nationally. So looking at that same data, that slide looks a little bit smashed a little bit. I wanted to see what were the, you know, across all the states, looked at the states that had the highest estimated proportion of people with sickle cell disease that were Latino. And you can see some of them are, you can't see the names, but like the highest one, 31%, is Utah. And then next is New Mexico. I think Wyoming is up there. And so although they may have the highest estimated proportion of people with sickle cell disease, they really are only talking about a handful of people in some cases. So when we looked at the actually estimated number of people with sickle cell disease who are Latino, you could see, you know, Texas, Florida, California, and New York are kind of up at the top, contributing the most number of people there. And so for California, it says it's about 281. We know this is at least half of what we found within our data. So there was those national estimates that were based on other estimates. So that's kind of rough guesses. But there's been a couple states that really looked at their own data in detail to be able to get more accurate numbers. And I'll share some of those numbers with you. So the formatting got a little messed up. But in New York City, they looked at all of their newborn screening records from 2000 to 2008, so like a 9-year period, and they found it was about 12% of babies born in New York City in sickle cell disease were born to Hispanic Latino mothers. In Michigan, they found about 2%, and this is over a larger time period, but still I don't think it varied very much during that time. Babies born in Michigan with sickle cell disease were born to Hispanic Latina mothers. I think and although they produced this number, they didn't really look at other factors like utilization or any other outcomes. This was really just providing some basic numbers of their population. So we're hoping in future years we'll be able to get a little bit more details. So in California, we recently looked at our data to see what we could find about the Latinx population in California with sickle cell disease. And we did two things. One is we looked at all of the people that we've been able to identify in California, and we saw who was alive and in California during 2016 to 2018, so a 3-year period. And we classified them as either Hispanic Latino or not Hispanic Latino based on what data we had. So either newborn screening records or healthcare utilization, Medicaid data, just the most frequently reported race, ethnicity. We also looked at our newborn screening records over this 18-year period and did the same there to try to get a sense of the prevalence, so how many people in California currently identify as Hispanic Latino with sickle cell disease, as well as an incidence, so the number of new births of people with sickle cell disease that were Hispanic Latino. So what we found in our data was that 7% of people with sickle cell disease identify as Hispanic Latino. That 7% is a little bit higher than what they had initially estimated, but it's about double the number of people, and that's probably due to the fact that our population continues to grow. We also saw that the Latino population is significantly younger, and that is not surprising because we found that in California, the Latino population is significantly younger than the general population, so this isn't too surprising. But it is interesting to note that a higher proportion of them are under 20 years of age compared to the non-Latino population. I think this is really key for program planning and kind of looking at where resources can be devoted in terms of like helping with school attendance or language or any other things that could really help the transition from pediatric to adulthood care. We also looked at, and I'm sorry that some of these numbers are really hard to see, emergency department utilization. So we looked at that 3-year period and saw how many times did they have to seek care in the emergency department. And we compared the two groups, and we saw in the Latino population, they went average of about 4 times over that 3-year period. And in the non-Latino population, it was closer to 7. It's a pretty big difference. This is just our first attempt at looking at this data, so we really are interested in kind of potential reasons why that is the case. We saw this pattern kind of across pediatric and adults, but it was most pronounced when we just looked at both groups. So I think it'd be interesting in discussions or Q&A if anyone has ideas. Is it an access to care issue? Is it just lower clinical outcomes, that maybe they have better outcomes at that? We're just not really sure. So that's kind of our next step, is really to look into what could potentially causing this difference. There's also a higher proportion of people within the Latino population that had 0 emergency department encounters over that 3-year period. You can't see that number, but it's 36% compared to about 26% in the non-Latino population. When we looked at the newborn screening records, this is over an 18-year period, we saw that about 11% of newborns born with sickle cell disease were born to Latino mothers, and they were less likely to have the milder genotype SC. So you can see that kind of pretty big difference, and more likely to have some of the other variants. We know that severity really is kind of implicated in just poorer outcomes. So I think it's really important to kind of figure out what's going on here, and if this is a pattern that's just in our data, and how we can use kind of this information to better adjust care. So kind of a recap on all of this is that, we have a lot of state and national estimates that are available, but they were last updated in 2010. That's quite a long time ago, especially because they use data all the way back from 2005. So that's just to say that I don't think we have a really good picture of the situation in the United States about how many people with sickle cell disease identify as Hispanic Latino, and what that means in terms of the care that they're receiving, the programs that are available to them. And a few states have analyzed their newborn screening data, but it's only a few. And so we're hoping, as more sickle cell disease surveillance states start coming up, that they'll be able to look at their data and just contribute to that. But a couple of things that have come up, and maybe people have thoughts on this, is, there's often missing race and ethnicity information within the data. So how do we deal with that? And then also just a disagreement on how to classify multi-race identification. Is it important to just identify Hispanic Latino regardless of race, or is it important to look at it wholly as a multi-race? So it's kind of an interesting issue that keeps coming up as to kind of barriers to some states wanting to report sickle cell disease by race ethnicity. So I think that's just something to keep in mind as we're trying to push for more states to really look at their data a little bit closer. And now I am kind of available for any questions that people have. I don't have anything on the global. I think I mentioned to, I think, Mary and Carol, Dr. Rowley, that I work primarily in the state-based sickle cell program, so I don't think I'm really qualified to speak on the whole global issue. But I am available for questions now if anyone has any.
Please.
Hi, Dr. Rowley.
Hi. So I was saying that our moderators need to be back on as well,
Great.
Nilda and Servio. But I actually do have some questions, and Nilda and Servio will actually monitor the chat for any other questions. But I have several questions.
Here I am.
So here's the deal with newborn screening. We do know that in 2006, all of the states, including Puerto Rico, everybody had newborn screening by that time. So it's interesting when you speak about numbers from even before then, because everyone, like New Hampshire, some of the other states, South Dakota, they didn't actually get on till much later.
Right.
So a couple of things. With California, you mentioned between the year 2000 and 2017, but in California, ours didn't actually occur until, well, I think ours was 1990. Yeah. 1990. So what does that look like when you all are reporting a time frame? But we know that certain states didn't start officially have a newborn screening program. Where are those numbers coming from?
It's a great question. So for California, we did start newborn screening before that 2006 period, but so those national numbers that had state specific estimates are estimated. That's it. They like pooled whatever data they had. They said, okay, look, this is the population in this state. We're going to guess that this is what it might look like. And that's why I mention it as in it's a very old data set and they are estimates of estimates. But to date, we don't have anything better for all the states. And I'll also add for newborn screening, all states have it now, but they are not mandated to do anything with that data besides report it back to the parents. So only New York City and a couple other states have really looked at their data to look at trends, to look at what's happening, to look at what's changed. And even within our own state, like it's not always easy to get that data. Like it is a battle every year to be able to access. So it's kind of it's a rich data source that I wish we could do more with, especially for all states, but it is a challenge.
And I want to ask one more question before maybe Nilda and Servio have a question too, but I want to ask another one. And it's more of I mentioned this to you before. So it is so important to know, you mentioned in terms of emergency room that it tends to be less. And so I am curious, why is it less in terms of the Latino population going to the emergency room? So I can only imagine, these are only supposings, that it's already a challenge for those who aren't Latino to go in. And so I even just wonder, is it more about really attempting to take care of it at home? Or is it because of the trauma that tends to ensue with going in and not being believed, particularly being Hispanic and not being believed? And in some of these places, like you said, Arizona, Texas had the highest number. I'm just curious. A lot of times people don't believe them because they do still think that it's a Black disease. So, do you guys have any ideas about the reason for the not going to the ER?
No, because we're not allowed to contact patients, so it's all just what people kind of like you're just mentioning some of these ideas, and those are the one that keeps coming up is that they often would rather not go into the ED because they have to re-explain some of the same reasons that you kind of mentioned. So that would be something we would hope to partner with someone to maybe look into that can kind of look into the patient side of things, because I think that's where we're going to find that out. So I don't know if anyone on the chat or on the meeting has any thoughts about what could potentially be those causes.
So I will add, even as an adult, emergency department is not the priority when I get into a sickle cell crisis. In my childhood, I can remember up to 3 times being admitted. There was a lot of enduring pain at home. And I endured pain till the age of 19. And that is when I was introduced to IV pain medication. But prior to the age of 19, my family, a hospital was not a thought when I had pain. It was only done when I had surgeries. So my first surgery was gallbladder. I needed my first exchange transfusion when I was 7. So I can pinpoint those admissions. But other than that, all of my crises were treated at home. And I believe it does occur culturally. I believe there's the holistic approach that is done. So when you speak to me on pain, I probably have a lot of commonalities with the older generation of sickle cell, where it's your green rubbing alcohol, your camphor. Till this day, I have a cup of glass in my room, my nightstand, and it has camphor tablets because they say it's good for your your respiratory. And hospital is seen as terminal. It is expensive as well. And then in the US, you also have migration too that doesn't have medical care. Mm-hmm. And you have individuals that have come into the United States and they ask, where can I find such medication? And they believe probably medication, narcotics are sold in a store the way it is in their country, and it's not. So they don't have the resources to see a physician. I believe that's one. But for the American born, I have family member that the hospital is when it is the extremity to say a life threatening.
Right.
And for us, we had a death in the family. So that every time hospital comes in is it can equal something close to death, not a management of the
Right.
illness.
Mhm.
Yeah, and I would ask, I'm not sure what Servio's experience with ER.
Well, my experiences with ER, as far as like the misconception about sickle cell anemia and how sickle cell anemia is diagnosed within certain classes of people. Because of course it is a misunderstanding that not that it basically it's a misunderstanding as far as like people believe that there's no such thing as a Latino person with sickle cell anemia because maybe they haven't seen it, or even Asians, for instance. And the biggest frustration that I have, of course, is the constant having to, repeat myself when you're having one of those sickle cell crises, because, I would think that you have some sort of system where, they communicate and, in your chart, they have notes and things like that. But it's always having to repeat the same thing. And sometimes you just don't feel like talking. And also, at the first stages of going to the ER, sometimes you need to go dress a certain way, or you need to present yourself a certain way, even though you don't feel like it, or the extra work to do that um, inflicts more pain towards you. But in order to be able to get the medications in a timely manner that you need, the narcotics, as you mentioned. So for the most part, yeah, that is I've learned how to manage it. I learned how to deal with it because I've come to realize that it's a widespread issue. Um, but hopefully we all, that's what we're working on, and we all hope for that to be a thing of the past. But yes, I have learned how to, to some extent deal with it and even manage it.
Thank you, Silvio and Nilda, for that. I think it looks like Curtis says there's a question from the Zoom. So I want to make sure I get to Curtis if you want to share that question.
Good morning, everybody. Can you hear me?
Yes.
My name is Lathan Singleton. I actually have a question. How is the transition period from pediatric care to adult care? I understand, the ER is hard for all of us for sure. The transition part is extremely hard. And I can only imagine when, unfortunately, there is a face on a disease that makes it even harder. So can you guys articulate how that transition went and how you guys are doing?
I would, if I may, hi Lathan. I'm glad that we can work together again. As far as the transition period, my dad was always very good at maintaining, maintaining my care as far as seeing a hematologist is concerned, and all other type of specialists. And I promise you, I have never seen any better doctors in my life, aside from the people that I met when I was in pediatric, when during pediatric care. But when I became an adult, it's kind of like I have to let go of you, and basically you have to figure things out on your own. And that was actually difficult, and it actually took me many years, from when I turned 18 to when I turned 25, for me to find somebody, for me to find a doctor that I'm actually happy with, that I'm actually comfortable with, and I can actually compare him to a pediatric as far as like knowledge, care, treatment is concerned. So yeah, that was quite a difficult process as far as like the transition process. But now, it took a few years, but now I consider myself to be in a very good spot, and I'm actually being treated by one of the best hematologists rated in the country.
Mhm. Hi. As for me, yes, I had the same as Sergio said. My mother is very dove into all things sickle cell, as many parents are. It's it's an instinct to protect and be ahead of your child's thoughts. We learned a lot from my pediatrician was Dr. Doris Weathers. And Dr. Weathers was a great teacher beside being a physician. And she taught the communication. So with her advice, we led into hematology. And then when I moved to the South, we looked into hematology oncology physicians as I moved to a area where sickle cell is not truly, it's not a popular illness to deal with. I'm in Charlotte, North Carolina, and now they have a hospital that has sickle cell programs. But at the beginning, it was seeking the hematologist. And as Sergio stated prior, with both going to the ER and physicians, till this day, a person will say, I did not know sickle cell runs in Hispanic. So we don't, the faces aren't shown, but the illness is there. And for transitioning, it is many persons depending also on internal medicine if they do not have the hematologist. So there are many sickle cell patients that I know, and their physician is not a hematologist. It's their primary physician that is caring for them. And yes, it eliminates that hematology background, but that's the physician that manages their health and probably sends the orders if they are in admission.
Thank you, Nilda. We do have time for one more question. I do see a question in the chat, and this is from Dr. Beverly. In the Latino community, are individuals with sickle cell disease more likely to be Afro-Latina? And I think this is a question for Jacqueline.
Yeah, so from what we know, the only state that looked at it and actually got like country of origin or where the mother was born or parents were born was New York City, and is what they found in New York City. But New York City is a different population than California, so we haven't been able to look that closely to our data about if they are primarily Afro-Latino. But we know we have more population from Central America and Mexico than we do from some of the Caribbean side. So I think it'll be more to know. But in New York City, that is the case.
And from Shira, we have the misinformation of this disease, sickle cell disease, seems to be the forefront for all ethnicities in the medical field. How do we change that narrative of misinformation going forward? And I think this is probably for both of our moderators, as well as Jacqueline. And that will be our last question. Hey, let's start with Nilda.
For me, I think the narrative it's in dire need of a change. So Spain, I have a lot of persons that are Spain, Argentinian, and when you hear them speak of sickle cell, in their country, it's very similar. It's listed as or known as a Black disease. And I think that's where the language has to be changed. I think that will change tremendously with sickle cell, because it is an illness that also runs with Italians, Europeans, Jewish, and I believe for me, that's the way to change the narrative of sickle cell. Yes, it's predominantly Black. However, it is so much multicultures that come from Africa. In a sense, we say, we are all African deep down in our roots, but it is not simply a race. It has no color. And I believe that is the way to change sickle cell. Because like I mentioned, 45 and still you have the question, you have the explanation. And there are cultures, biracial cultures, and sickle cell, the gene, it's important to know that this gene can either be thalassemia, might not be known just as sickle cell, but it has different names. And with being Hispanic, that is also a large confusion with us. We have too many different names to sickle cell. So it's very hard to make the focus into one name. One area knows it as one. I was born and raised to know it as anemia falciforme. South America is depranositis or cyclemia. So those different terms also make it very difficult to say it is that one disease, and it is a disease that can carry through all depending on the gene.
So it sounds like, and then I'll turn it to you, Servio. Part of this narrative is to have health literacy infographics that are in Spanish, that instead of just saying sickle cell, noting what other countries are also calling it, like you just said. The information, facts are facts, but to be able to at least maybe the title of it be those names that are recognizable and to show the different faces of sickle cell. Thanks, Nilda. Sergio, question?
Well, the way that I considered it, that I thought about it was, as far as misinformation and culture, just culture misappropriation and things like that. I've really thought about it in my own experience, in the jobs that I've had. Towards the end of the year, we've always had to do some sort of ethics course. And maybe this is something, because I have no knowledge of the medical field, but maybe this is something that can be implemented. And if it already exists, this is something that can also be included, some sort of ethical course on, individualized ethical course on sickle cell anemia, because I'm sure that there's ethical courses. But there's different types of ethics that could be applied to different medical conditions. Because every single medical condition has their own unique misinformation, misunderstandings, and their own unique conceptions. So that's actually, as far as the medical field is concerned, where it seems to be the nature of your question. That's a good place to start, and some sort of end of year ethical certification training.
I like that. I mentioned earlier that Mrs. Ohini Frimpong used those same words in terms of moral and ethics when she did her talk at SCDAA. So I see how that can actually tie in. And we're going to end this with Jacqueline, if you want to tackle that question, and then we'll move on to the next session.
Great. I mean, I don't think I have anything more to add. I agree with Servio's suggestion. I think it really starts with making it core to kind of some of the training that happens within the medical field, and just the more data and information we could get out there, I think the easier it'll be to kind of confront this issue. And thank you all again for inviting me here.
No, thank you. Seriously, you're our data go-to person, okay? And we want to be able to collaborate and do some things. So everyone, thank you so much. And of course, we're always going to have the latest data. So we're hoping that next year, when you're sharing, that there actually might be some other things that are happening, or maybe we can even talk about what we can actually do, all of us, to be able to aid and assist you all in collecting that data. So thank you for this particular session. And so everyone, you're going to give us about 2 minutes, and and then we're going to start our next session, which is sickle cell disease, the basics. And this will also include FDA-approved therapies by our one and only Dr. Keith Carollo. So I want to give you guys 2 minutes to be able to stretch and to breathe and to hydrate while we bring on our next guest. And we'll start at 9:50, which is about 1 minute from now. So thank you so much. So we'll play some getting down music while we do our transition. Thank you. right. So thank you. So again, this is my one and only, this is my brother, my friend, Dr. Keith Carollo. And so Dr. Keith, I think there's an intro and then take it away. So glad that you're here on a Saturday. Thank you.
Okay, hello everybody. Thanks for attending the meeting this morning. My name's Keith Carollo. I'm a pediatrician, so the little presentation I'm going to give you is kind of towards that direction. I've been a pediatrician for over 30 years. I was a nurse before that, so I've been in healthcare for at least 40 years plus. My last 20 years, half of that time, I took care of children at Children's Hospital in Oakland, and left there about a few, I don't know, 7 years ago, 6 years ago. And I've been fortunate enough to work with Carolyn and Cayenne Wellness, which has been an amazing experience for me. And I really thank them for inviting me to speak to you today.
All right, so Dr. Keith, they're going to cue up your intro and then you'll be able to go on with your presentation. Thank you.
Is a retired pediatrician who holds a degree in biology from San Francisco State University, a degree in nursing from the UCSF School of Nursing, and an MD degree from Case Western Reserve School of Medicine. Dr. Carollo practiced as an RN for approximately 10 years in pediatric oncology and intensive care in the Bay Area and during medical school at Rainbow Baby and Children's Hospital in Cleveland, Ohio. He served as the director of Pediatric Sickle Cell Program at UCSF Benioff Children's Hospital in Oakland for 20 years, on the FDA Blood Advisory Committee for 2 years, and initiated and directed the Clinical Affairs Program at UCSF Benioff Children's Hospital for 17 years. He currently consults for community-based organizations and other advocacy projects. Welcome to Sickle Cell Disease, the Basics, part of the second annual Hispanic Heritage Sickle Cell Disease Educational Seminar.
Well, that was nice. Okay. Do I put up my, there we go. That's what I wanted to see. Okay. So this is going to be a very information-packed discussion or presentation. So I kind of apologize for that, but in the time I have, I want to cover a lot of stuff. So let's get started. I have a disclaimer. I don't receive compensation from anybody. This presentation is my opinion only, and may not be shared by other doctors, actually. And recommendations that I have are just may not correspond to current practice, but do not constitute any kind of recommendations. This presentation is for information only. So what we're going to do is we're going to cover some basic information about sickle cell disease, and then we're going to go into a few of the more common problems with sickle cell disease: pain, infection, acute chest syndrome, cerebral vascular disease, and anemia. And then we're going to talk about some other common complications of sickle cell disease more briefly, and then sickle cell disease and blood transfusion, the new therapies, and then we'll finish up with the transition to adult care. So sickle cell disease is different for everyone, So even siblings who have the same parents can have completely different experiences with their sickle cell disease. There's a large population of sickle cell patients in Brazil. There are just an explosion of publications from Brazil, and certainly all the data that's from Brazil is Hispanic patients, but the findings are thought to generalize to the entire sickle cell disease population. There's really no biological difference between people who have sickle cell disease. As far as I know, there's never been any literature on comparing the experience of sickle cell disease between American Blacks and American Hispanics and South American Hispanics. So that information is not really available. So as you just heard in the previous discussion, sickle cell disease occurs about 1 every 16,000 Hispanic births. This was from 2007, so this says 12% of newborns in California have sickle cell disease. It sounds like that's a little less now. Sickle cell anemia is very common in African Americans. 1 in 375 African Americans have sickle cell disease, and sickle cell trait is very common. 1 in 13 African Americans have sickle cell trait. But in Hispanics born in California, it's about 1% or so. Sickle cell disease, though, is not one disease. Everybody talks about sickle cell disease, but you really don't know what they're talking about because there's many kinds of different sickle cell disease. So there's hemoglobin SS, which is called sickle cell anemia. Hemoglobin SC, that people sometimes call SC disease. There's hemoglobin S thalassemia. There are 2 kinds of thalassemia. One, a type of thalassemia where you make no hemoglobin from one gene, as that's called S beta 0. And that is equivalent to SS because you can see the only type of hemoglobin that individual has is S. And then there's S beta plus. So some thalassemia mutations do not completely eliminate the production of normal hemoglobin, hemoglobin A. And so that's a variable kind of a diagnosis, and it can be very, very severe, or it can be less severe. There are hundreds of variants of hemoglobin. Hemoglobin has a lot of mutations, but there's about a dozen or so, maybe less, that are variants that, when combined with hemoglobin X, actually cause some degree of sickle cell disease. And then there are all kinds of traits for each one of these. There's sickle cell trait, hemoglobin C trait, thalassemia trait, and then variant traits. And these in California, at least, are all picked up by newborn screening. So the inheritance is all the same for all these diseases. This is called the autosomal recessive disease. So you see on the right there, you've got 2 individuals who have sickle cell S trait, and for every pregnancy, there's a predictability of the chances of having a child with sickle cell disease, which is 25%. You also have a 25% chance of having a child without sickle cell disease and a 50% chance of having a child with sickle cell trait with every pregnancy. But this is sort of statistics or chance. So you could easily have 3 children with sickle cell disease in a row, or 3 children with normal hemoglobin in a row, and then a child with sickle cell disease. So you can't really predict what's going to happen there. It's all by chance. You can have pre-implantation. You can have diagnosis through amniocentesis and stuff like that, but the probability is always going to be the same. And you can see that if you look at sickle cell disease in California, there's way more people in Southern California who have sickle cell disease than even when you combine Northern California and Central California. So most people with sickle cell disease in California live in Southern California. And worldwide, so it's sickle cell disease is directly related to whether or not malaria exists in an area. So you can see on the top half of this, there you see Africa, and goes into India and up into the northern area. But sickle cell disease is most common in Africa, in the West Africa, where on the lower picture, the darker the red, the more likely it is there's a hemoglobin S disease appears there. And you can see in India, there's people with sickle cell disease, as well as in the Middle East. In the Pacific area, thalassemia is more common than sickle cell disease. And you can see the different areas where sickle cell disease occurs. And then we've gone through this part about the incidence of sickle cell disease. So what is sickle cell disease? Sickle cell disease is an inherited blood disorder of hemoglobin. It's caused by a single base pair change, which is the smallest change you can make in a DNA, and results in polymerization or clumping of the hemoglobin molecules under conditions of low oxygen. So in that picture there, where it says normal hemoglobin, hemoglobin is made out of 4 different molecules, 2 beta and 2 alpha, and they don't interact with each other much inside the red cell. They pick up oxygen in the lungs and release it into the tissues. But in sickle cell disease, well, just back up. So when hemoglobin has oxygen, it does not sickle because it's in one particular shape. When it releases the oxygen, it actually changes the shape of the molecule. So in sickle cell disease, that allows polymerization or clumped hemoglobin, these long strands of hemoglobin, which distort the cell from an oxygenated, normal-looking cell to a sickle cell. And because of this, it stretches the membrane. It actually turns the membrane inside out. There are consequences to that, and it activates cellular elements of the blood, and as well as the lining of the vessels, and it can cause blood vessel occlusion by this kind of stickiness. All the cellular elements stick to each other, and they stick to the lining of the vessels. There's also, when this happens, it weakens the membrane, and there's hemolysis. The red cells break down and they release hemoglobin into the circulation. So red cells from someone who has sickle cell disease last a couple of weeks, whereas normally they should be like 120 days. So the lifespan of a red cell for people with sickle cell disease is extremely short. And this is just some pictures just to give you an idea of what's going on. So this is a red cell on the left, and you can see those little strands are the polymerized hemoglobin. Below that, you can see what that looks like. Those are all hemoglobin molecules stuck together. And then on the other side, it just goes through that scenario where you have deoxygenation and polymerization. So there's 2 things that happen with sickle cell disease. There's hemolysis, or the red cell breaking down and releasing hemoglobin. And then that's on the left side. And then on the right side, there's the stickiness, that the cells stick to the walls of the vessels and each other. And there are different problems associated with this. So with the hemolysis, pulmonary hypertension, leg ulcers, priapism, and stroke are associated with that. But with the other events, there's pain episodes, acute chest syndrome, and bone problems. Of course, this all happens together, but you can separate out those 2 different you can associate them with different problems. So sickle cell disease is a chronic, unpredictable disease. It requires specialized care from knowledgeable providers. The severity is determined by the type of sickle cell disease and other unknown factors. That's why siblings can have different experiences with sickle cell disease, even though they're very similar, because they have the same parents. So what can providers do for people with sickle cell disease? They can provide consistent, good medical care with a medical home model. That means you always see the same doctor, you always go to the same practice, and everybody knows who you are. They know what your problems are. They know what your medical history is. They also, providers need to follow guidelines. There are guidelines to take care of people with sickle cell disease, and they're published by the American Society of Hematology and by the NHLBI, the National Heart, Lung, and Blood Institute. So these are available, and they've been available since the 80s, actually. But recently, in 2014 and 2022, the American Society of Hematology and NHLBI have published extensive guidelines. And the other thing you need to do if you're taking care of people with sickle cell disease, which is a little controversial, but pediatricians like to screen for things. So screening for complications and intervene before they become severe. Newborn screening and screening for stroke are two examples of early screening and intervention. So these are some of the complications of sickle cell disease. It's not a complete list, but it's enough, all I could fit on the slide. So infection and sepsis, which can be fatal, treated with antibiotics. Lungs have your pulmonary system, the lungs have a lot of problems. Asthma is more common in sickle cell disease than other people. Acute chest syndrome is unique to sickle cell disease, and it can be fatal. Restrictive lung disease is something that happens to your lungs over time, where the tissue of the lungs get scarred, and you have what you can call it, restrictive lung disease. And these have treatments, but restrictive lung disease is really hard to treat. The central nervous system, there's stroke, which is a cerebral vascular accident. It can be prevented, it can be predicted and prevented with transcranial Doppler screening in children and adolescents up to 16. Chronic blood transfusions and medications. In the past, it was fatal. You can have severe anemia requiring transfusion. Pain is really debilitating, but it now can be decreased with medical therapy that we'll talk about at the end. You have bone disease that causes a lot of disability, and a progressive renal disease that in some people, not everybody, but in some people can lead to actually renal failure and the need for dialysis. So let's talk about pain. First of all, there's no biomarkers for pain. The doctor in the emergency room can't tell you, oh, I looked at your labs and you don't look like you're having pain to me. That is not possible. The way you know someone's having pain is they tell you they're having pain. And a lot of people with sickle cell, they don't look like they're having pain because they're stoic. So pain is not always sickle cell vaso-occlusion. Pain is the most common presenting symptom in sickle cell disease, but it may not be specifically associated with sickle cell disease. Sickle cell disease causes bone infarcts or damage to bone. So somebody coming in complaining of hip pain or leg pain, that may be from avascular necrosis. In very extremely rare events, the bone infarcts damage the bone marrow, which contains fat and all the cellular elements of the blood, and the fat gets released into the circulation, and it's catastrophic. It's extremely rare, but these are things the doctor needs to be thinking about when they see you with pain. You can have a splenic infarct, biliary obstruction. If you have abdominal pain, maybe you have a gallstone, or you have an obstructed duct. You have nerve compression from swelling. Acute abdominal pain could be surgical. How do you know the person coming in complaining about sickle cell disease doesn't have appendicitis or some other intestinal problem, or even testicular torsion? Chest pain, it could be pneumonia, acute chest syndrome, a pulmonary emboli, or in an older person with risk factors, it could even be a heart attack. Intracranial or headache with vomiting, and the worst headache I've ever had in my life, that could be an intracranial hemorrhage. And these are medical problems that need to be treated that are different than treating pain. But frequently, there's no obvious cause for pain. It involves tissue damage and inflammation. The musculoskeletal system and abdominal pain are common. Headache is common in all ages in people who have sickle cell disease. And some people have pain almost on a daily basis. And they don't go to, like we just heard, a lot of people don't go to the emergency room. They treat themselves at home. This is what a pain episode, this was data that was collected by interviewing many, many people who have sickle cell disease. And you can see that a pain episode starts and in about 24, 48 hours, the pain just escalates. It just gets unbearable. That lasts for about 4, 5, 6 days, and then it slowly goes down in the next 4 or 5 days. So somebody who has a pain episode could be in pain or disabled for 2 weeks. That's a long time. But this is just generalized. Pain episodes are different for everybody. Some pain episodes are shorter, some pain episodes are longer. Also depends on where the pain is, of course. So acute versus chronic pain. So severe acute pain is usually self-limiting. Opioids, nonsteroidal anti-inflammatory medications like ibuprofen, ketorolac is helpful with the pain. You know, I've never had sickle cell pain because I don't have sickle cell, but my impression is these medications don't really stop the pain, they just make it more bearable. Chronic pain is common and it's relatively constant or always constant pain. Pain, if you have frequent pain episodes, that actually leads to changes in the function of the nervous system. The way your body transmits pain from where the injury is up to your brain, where you appreciate pain, is actually affected by how much pain you have. And even opioids, they also change the way you experience pain. So chronic pain is extremely complicated, and opioids are not particularly effective if you have chronic pain. Other medications, there are some central nervous system acting medications like anti-seizure medications, anti-anxiety medications that can be more helpful with chronic pain, as well as other methods, and it can be really disabling. So pain management in the emergency room, this is a big issue. We were just heard about it, and there are standards of care that apply to people with sickle cell disease who come to the emergency room with pain, and it should be seen as an emergency. So within 30 minutes to 60 minutes, when you arrive, you should be in a room and have, by 60 minutes for sure, and have received your first dose of pain medication. That's probably not what most people experience, but that's the standard of care. Your pain should be evaluated every 30 minutes, and if it's not better, if you're still having a lot of pain and you feel like the pain medication wasn't enough, then you should be given more pain medication to relieve the pain, to make you as comfortable as possible. Kind of on the patient, though, or the person with sickle cell, is a pain plan. So your primary care health provider, if you have one, should provide you with a pain plan to be used by the treating doctor in the emergency room. They don't always, they may not honor that, but at least it gives you something to give to the ED doctor to say, hey, this is the way, I get this much Dilaudid every whatever to treat my pain. Unlikely, but there is something called patient-controlled analgesia, PCA. It's hooked up to an IV, and you push a button, and you get a predetermined amount of pain medication, and that can be used sometimes in an ED, but always it should always be used inpatient. And when you get discharged, either from the ED or from the hospital, you should have opioid prescription plus a plan to wean off your opioids. If you just stop suddenly after you've been in the hospital for a week or so, you are going to have withdrawal and be really sick. So fever may be the only sign of severe infection in sickle cell disease. And there may be no other symptoms, only fever. So in the 80s, a penicillin study showed that life-threatening infections were decreased by 85% in infants who are at high risk for infection with sickle cell disease. And this is why newborn screening is so important. You have to know that a child has sickle cell disease before you can start penicillin, and you can be aware that this baby is at high risk for infection. The penicillin started by 2 months, and the doses increased at 3 years and given until the child is at least 5 years of age. Penicillin can be continued after 5 years. This is something that's discussed with the person the parent and the pediatrician for splenectomy and history of severe infections. Usually it's not continued beyond, say, about 10 years or so. And because by that time you're fully immunized, etc. Infection but infection remains a cause of morbidity and mortality throughout the lifespan. So no matter how old you are, you're still susceptible to infections, and fever should be taken seriously, and you should see a doctor if you have a fever and you don't feel very well. So why is this anyway? So as we talked, the spleen in sickle cell disease becomes damaged by the sickle cells. The sickling happens within the spleen. The spleen is an organ on the left side of your body, and it filters all the blood, and it removes damaged red blood cells. It has a lot of immune cells in there, and it helps you fight infections. Without the spleen, if you have a surgical splenectomy, you're at high risk for certain types of infections by what are called encapsulated bacteria. So you can see this here. 14% of babies 6 months of age do not have what's called functional asplenia. Their spleen does not work. By the time you're 5, 95% of children do not have splenic function. So they're at risk for severe life-threatening infections. And infections in hemoglobin SS, because of this, they're twice as common in babies, 3 times as common in preschoolers, and then in school-age kids, they're 5 times as common. So my experience has been that the children who get into the most trouble, and unfortunately most of the kids I saw who died from infections were in this age range, 5 to 9 and above. Immunization can be life-threatening or life-saving. The infections are life-saving. The immunizations are the infections are life-threatening. The immunizations are life-saving. Anyway, pneumococcal vaccine is everybody should be immunized with pneumococcal vaccine. And meningococcus, or meningococcal meningitis, is the disease. That's something you can discuss with your physician about when you should have that. But both of these are encapsulated bacteria, and they're people with sickle cell disease are at high risk for these infections, for severe sequelae to those infections. So acute chest syndrome can't be distinguished from pneumonia on a chest x-ray. So if the chest x-ray is abnormal, you assume if the person has sickle cell, you assume it's acute chest, but there's no special difference between this pneumonia right here, the normal lung is black and that white area is pneumonia, or if the person has sickle cell disease, that's acute chest syndrome. It's caused by sickling that we talked about, an occlusion of vessels in the lungs. And the interesting thing about the lungs is when oxygen transport stops in an area of the lung stops sending blood there, and that causes more sickling because the oxygen level goes down. And so you can have both lungs look white, just like that one area. It's the second most common reason for hospitalization, serious for all types of people who have sickle cell disease, and accounts for about 25% of deaths. And because it's it's not always super severe, but it can be so severe, it's a risk factor for stroke as well. The incidence is 3 times more common in children because they get a lot of respiratory diseases, but usually it's less severe in children. It's increased with a history of asthma and allergy. And of course, it's increased if you have a history of acute chest syndrome, because you probably have these risk factors. So if somebody's had acute chest syndrome, has allergies or asthma, those people, with chest pain are more likely to have acute chest syndrome with sickle cell disease. In adults and adolescents, the initial complaint is usually chest pain with fever, cough, rapid breathing, and findings on, not always, but usually findings when you listen to the chest. A chest X-ray will reveal that it looked a small area of pneumonia, which is likely to get much bigger. And it may require blood transfusions because sometimes there's so much sickling in the lung, your hemoglobin goes down and you need to be transfused, and you can end up in intensive care unit. But interestingly, bacterial infections in this group are uncommon with sickle cell acute chest syndrome, which shows you that this is really a vaso-occlusion rather than infection. Cerebral vascular disease is terrible. It used to occur a lot more than I would have liked it to have occurred. And on the left side there, you can see the white areas are a brand new stroke in this person with sickle cell disease, and those little black areas up there are old stroke. And on the right side, you see an image of all the vessels. And what you can see is on the right side of that image, there's a lot of vessels kind of tangled up in the on the right side, and there are very few vessels on the left side, because if you look down below, you'll see there is a large vessel, the internal carotid, on the right side, but that vessel is missing on the left side. It's secluded. So this is the way stroke used to occur in people with sickle cell disease, and it's the general, usual, progression of hemolysis. Everything sticking to the size of the cells. Vessel gets smaller and smaller. And eventually there's also the coagulation systems involved, and pretty soon it just gets occluded. And this can happen in large vessels for some reason in the brain that doesn't necessarily happen in other parts of the body. And the vessels permanently narrowed during this process. So the incidence of stroke used to be 8%. The STOP study, it's much, much less. It used to be increased between the ages of 6 and 9, and the risk increased at about 1% per year until you were in your late teens. The incidence of subclinical or silent stroke, so these are really tiny little infarcts in the smaller vessels, and that can be somewhere between 17 to 25 or higher percent, maybe about 35%. Back in the day, when I started taking care of people with sickle cell disease, stroke accounted for 12% of the deaths in children before the age of 20. So this doesn't happen anymore. It shouldn't. So what is transcranial Doppler screening for stroke? So this is one of the most amazing studies ever, but it's equivalent to the penicillin study that stopped deaths in babies with sickle cell disease. So your screening for a stroke begins about 2 or 3 years of age and goes on until you're 16, because that's when the stroke risk is the highest. And what happens is, this is a Doppler, it's a ultrasound, and it's looking for the velocity of the blood going through these vessels. So if you think about it, if you are watering the lawn, you step on the hose, all of a sudden you can hear that water going through the area that you made narrow. And so the water's still going through there, but it's very narrow, and you're taking a large volume of blood, putting it through a small diameter space, and that increases the velocity. So the transcranial Doppler screening screens for increases in the how fast the blood is going through the vessels in the brain. And down here, the little girl below, she must be 30 by now, but she was one of my patients when I was practicing. And so this is what it looks like when for the technician. You can see it's these peaks are the peaks on the left are very high, they're lower on the right, and the image down below, you can see if you look very closely, there's an arrow on the right side that there's a black area, and that's where there's decreased blood flow. It's not stopped, it's just decreased. If it was stopped, you would get no velocity whatsoever. And then there's on the right, there's different velocities for normal, conditional, and abnormal. If you're abnormal, it's repeated, and then you start blood transfusions to prevent you from having a stroke. So the protocol for stroke prevention and sickle cell disease now this is very relatively recent. 1 year of chronic blood transfusions every single month to keep your hemoglobin, your sickle hemoglobin low, 30% or less. After a year, if you have no visible stroke on MRI or no symptoms of stroke and your cerebral vascular disease is stable or it's non-existent, you can you start hydroxyurea, and they start decreasing the frequency of the blood transfusions over about 6 months. And at the end of 6 months, you're off of blood transfusions, you're on hydroxyurea. I haven't read of any studies of what happens, years from then if somebody decides to stop their hydroxyurea. I don't know if their stroke risk increases after that. But once you're completely weaned off, stable transcranial Doppler and MRI, and then you're on hydroxyurea therapy, which is huge. The difference between taking medicine every day and having to come in to get a blood transfusion is pretty life-changing. So there are strokes and silent strokes. A stroke is a large vessel occlusion. People who have those kinds of events, they have paralysis, severe neurocognitive decline, or they can have severe neurocognitive or intellectual problems. They have problems in sequencing, which is called visual spatial impairment. They can have impaired memory, poor impulse control, psychological problems, and other focal neurological problems. Silent stroke are these little teeny strokes that I talked about. They're very small, less than 1/8 of an inch, maybe 1/16 of an inch across or so. But they're frequently, there's more than one, there's a lot. And actually people my age probably have some silent infarcts as well. It causes learning disabilities. It may be mild to severe depending on the location and the number of these small infarcts. So in children, if they're having problems in school, they need to have neuropsychological testing, which looks at their performance and finds whether or not there's any weaknesses. They should have an individual educational plan, and in some cases, maybe even special education to help them in specific areas that they're having problems with. It's been advocated that people with silent stroke receive transfusions like for a large stroke, but that recommendation isn't always followed because transfusions there's a lot of problems with transfusions. And silent infarcts, there's a wide range of what happens after a silent infarct. So clinical strokes now should be uncommon. There are still strokes because some pediatricians neglect to have TCD done for their children, and so some kids still have strokes, but it's uncommon. There was a article in the New York Times about 2 sisters who had strokes because their pediatrician never did the TCDs, even after the first child had a stroke. So If with a stroke, you get a red cell exchange transfusion, we'll talk about that later, to really reduce the hemoglobin low, keep the percent hemoglobin S low, keep the hemoglobin high. You do imaging, neurological evaluation, and then you start monthly transfusions forever. Once you've had a stroke, you can never stop transfusions, because if you do, you will have another stroke. But even monthly transfusions, keeping your S low, does not completely prevent strokes. There are still strokes in individuals who are on chronic transfusions to prevent strokes. So strokes are awful and they're really hard to treat. So the best thing is to make sure they don't happen. Anemia. So splenic sequestration and parvovirus infections are common causes for anemia in people with sickle cell disease. Usually happens in children. Like I said, I'm a pediatrician. So the spleen is the spleen that filters all your blood is an organ up there in the left side of your body. It's very expansile. It can get very, very big. And in a small child, 6 to 18 months of age, the spleen can get so big that it really decreases their hemoglobin significantly, and it's life-threatening. And it can happen over several hours. So parents who have kids with sickle cell disease should know where the spleen is, how to feel it, what it feels like. You don't have to check it every day, but once in a while. And to make sure that you don't feel it and it's not changing if you can. This is treated with blood transfusions, and if it's progressive or severe, actually a splenectomy to prevent it from happening again. As I mentioned, by 5, most people with sickle cell disease don't have a functioning spleen, so having a splenectomy is not good. It's life-saving, but it doesn't really, to me personally, it doesn't really affect your prognosis with sickle cell disease. So in SS, about 15% of kids have, between the ages of 6 and 36 months, have splenic sequestration. It's much less common in SC, about 5%, and the people are much older, 2 years to 17 years. It can even occur in adulthood. The average age is about 9 years old for SC to have splenic sequestration, and there's not data on other types of sickle cell disease. It frequently reoccurs about half the time, and about a third of the time a splenectomy is required. Severe anemia can also be caused by this virus called parvovirus. It causes Fifth's disease, which is a rash. It's really common. A lot of kids get it. It's transmissible, so a kid in school with sickle cell disease can get this from another kid. It doesn't affect you if you don't have sickle cell disease. It infects the bone marrow and the red blood cell precursors, or the parts of the bone marrow, the progenitor cells that make red cells, and it turns them off. So you can think about it. If you have sickle cell SS, your hemoglobin, your red cells only last for 2 weeks, and if you turn it off for 5 or 10 days, that's severe. You can have really severe anemia. It doesn't happen as fast as splenic sequestration, but over a period of 5 or 10 days, you can get really anemic with this infection, and even maybe require a blood transfusion. Another way that severe anemia can occur is caused by an antibody response and hemolysis, or blood breakdown, from transfused red cells, and that's called alloimmunization. It occurs a couple of weeks after a transfusion. It can be diagnosed with laboratory studies, but it can be prevented by using what's called phenotypically matched red blood cells. And this little picture over here in Philadelphia, they actually have, the Red Cross actually has a program to identify people who would be good donors for sickle cell disease, and they phenotypically match that blood so that the blood is more extensively matched to the patient, which prevents this problem. Other complications of sickle cell disease. We'll go into those right now. So pulmonary hypertension is high blood pressure in the lungs, and it can be diagnosed with a cardiac echocardiogram, but the sort of gold standard is cardiac catheterization. And when you do that, about 10% of adults will have pulmonary hypertension. You get shortness of breath, you fatigue, and eventually, because the right side of your heart pumps the blood through your lungs, you end up having right heart failure. Pulmonary hypertension is really hard to diagnose, and it's usually not screened unless people have symptoms. But if you could anticipate this, you could maybe start treatment a little bit earlier. Other kinds of cardiovascular disease can also occur in adults due to chronic anemia or iron overload. Iron overload from transfusions poisons your heart, and chronic anemia causes the heart to work harder. So the left side of your heart gets affected by that. Gallstones are pretty common in sickle cell disease. You have pain on the right side of your abdomen under the diaphragm. You can do an ultrasound to find these gallstones or bilirubin stones, or the liver in the process of processing the hemoglobin that's released from your red cells. This is a byproduct of that. Occasionally, these stones will migrate out of the gallbladder into the common bile duct, and this is really serious. This can cause major liver damage. So sometimes people will do a cholecystectomy or remove the gallbladder in order to prevent this from happening. If it does happen, there actually are ways to go down and pull these stones out of this common bile duct. Renal disease is common in sickle cell disease. There's a lot of issues that involving the kidneys with sickle cell disease, and actually sickle cell trait as well. But there's a decreased ability to concentrate the urine. There's some other problems, including hematuria and what's called papillary necrosis, or you can have sickling in the cell, which causes a lot of bleeding. You can see blood in your urine. Hematuria means blood in the urine, but frequently it's microscopic, so you can't see anything. But if you do a urinalysis, you can find out that there's blood in your urine. It occurs about 20% of all people with hemoglobin SS have progressive renal disease, and in pediatric patients, it starts about 4.5% of children already have some degree of renal disease. Risk factors for severe renal disease are, low hemoglobin, anemia, protein in your urine that shouldn't be there, blood in the urine, and a low fetal hemoglobin. So fetal hemoglobin prevents sickling, and the lower it is, the more sickling you can have. It can result in renal failure in some adults and go on to require dialysis. Priapism is common in men, about 40%. This is an unwanted, very painful erection, and it can also occur in children, but not as commonly, and usually there's no permanent problems. In young adults and men, it's a reoccurring problem, and the outcome may not be good. So this requires a urologist and a lot of therapy, medical therapy, and preventative measures. And the outcome it's difficult to treat. But impotence happens in about 60% of men who have this reoccurring. Avascular necrosis is damage to the joints. Necrosis means cell death. So cell death in the hip is called avascular necrosis of the hip. It's common in adolescents. Beta 0 thalassemia, SS, with alpha thalassemia. If you have another kind of a mutation that increases your hemoglobin and seems to increase the incidence of hip disease. The progression is unpredictable. You have a lot of pain from this. In some children, and I had one child who had AVN and it resolved. They were under 10. It happens in all types of sickle cell disease. I had a patient with hemoglobin S beta 0 or beta plus thalassemia, the type of sickle cell with the least amount of complications. Before this little guy was a teenager, he had AVN. So it's a very unpredictable complication. Core decompression, where they take it's a procedure where they try to increase the circulation in the hip. So they drill, it's done under anesthesia. They drill a hole into your hip bone, and then that increases as the bone fills up that hole, it increases the circulation, and pain goes away pretty dramatically in some people once they have a core decompression, but it doesn't generally decrease the progression of the hip problem. And physical therapy has the same effect. It will, just doing physical therapy, no surgery, it will make the hip pain less, but it doesn't prevent the progression of the AVN. And you can have AVN in your shoulders, your knees, wherever there's a joint that you use frequently, especially weight-bearing joints like your knees and your hips. So here's a person with sickle cell disease. AVN is staged by 1 through 6. And the decision for a hip replacement depends on how much pain the individual is having and the degree of their disability. So some people put off surgery, which I don't think that there's nothing wrong with that, for years until they really have a lot of problems with their hip disease, and then they decide to get a hip replacement. And this is you can see that white is the hip prosthesis on the right side of this individual. And it doesn't matter how long you wait. The hip replacement can be done in any stage. I've been told by orthopedic surgeons, any stage of sickle cell disease. Eventually the hip becomes fused and then you don't have pain, but you can't move your hip. And you can see this person has had one hip replacement over here, and this head of this femur is not round. So this person's having a lot of pain over here, and at some point will probably require another hip replacement. The other thing with this that happens is, you can see this is supposed to be a round kind of a ball, but as it collapses, you get leg length in discrepancy, where the affected leg is shorter than the other leg that's not affected, and this can actually be corrected when you do a hip replacement. Retinopathy or eye disease is common in sickle cell disease, especially SC. They have a higher hemoglobin, and that contributes to this. About 30% of people with SC, as young as 12, have this sickling in the back of the eye, where the vessels become occluded, and those vessels in the back of the eye start proliferating, like you can see in that picture below the eyeball there. And they're trying to increase the oxygen in the back of the eye to protect your vision, but they're floating around. They're called sea fanning, and they're very friable. So if they get occluded and start bleeding, you can have blood clots. You can't see them necessarily, and there's no pain or anything involved in this. So you have to see an ophthalmologist annually, at least, just to make sure this isn't going on, especially if you have any vision problems. But anyway, it will pull the retina off the back of the eye, and that can cause blindness if it's not, if there's no therapy. And the incidence in beta 0 thal is 14%, and hemoglobin SS is 3%. Hyphema is blood in the anterior chamber of your eye. That part in the picture above, there's a little space in front of that blue thing that's the lens. And if you get hit with some object and it bleeds into that area, you can actually see it when you look at somebody's eye. They have a little, you can see the blood in the front of the eye. That's an emergency. It's equally serious in all sickle hemoglobin types, including trait. And if it need to be seen by an ophthalmologist, and if it's not treated or doesn't go away by itself, then you can have increased pressure in your eye, glaucoma, and that can cause blindness as well. Skin ulceration is about 25% of hemoglobin SS and S beta 0 patients. It's predominantly male. It's increased with age, decreased hemoglobin, and if you have alpha thalassemia. But you can see in the picture, this individual has a small area of skin ulceration. It's very deep, takes a long time to heal. It's really hard to treat, but the skin never goes back to normal, so it can reoccur up to 75% of the time, and they can be very, very big, and they're really difficult to treat. You have to go to a skin specialist with different kinds of dressings, and there's a lot that goes into it, and it takes a long time to heal. It's very, very painful. So let's talk about transfusions a little bit. Most people with sickle cell disease have at least 1 or 2 transfusions during their lifetime. This is what I was talking about, an exchange transfusion. This is an old machine. The new machines are much, much smaller than this, and you don't get to see all the pumps and everything that are moving the blood around. But the way an exchange transfusion works is you need to have 2 IVs. This young lady has an IV in each arm. One of the IVs at the same time, one IV is removing her blood and the other IV is putting the blood back into her, the donated blood. And so that means you're not accumulating iron, because you're taking out blood which contains iron, that's part of the hemoglobin, and you're putting in the transfused blood. It also means that if you have a high, if your hemoglobin is really high, you can still reduce the amount of sickle cell because you're taking out blood and adding, replacing that. In an instance without this, you're limited, because if there's not a lot of anemia, say when someone has acute chest syndrome, then you can't really give a lot of blood, or during a stroke, you can't give as much blood to lower that hemoglobin S, because the hemoglobin is so high to begin with, and you don't want to transfuse over about a hemoglobin of 11 or 12, because that actually can cause a stroke in SS. So this is one way to get that S down without, and it can be done chronically. Some people have this chronically, and the iron overload is less in those people. So alloimmunization, we talked about this, and there's the little tag there. These functional proteins on the outside of the red cells, they can cause an immune reaction if you're not typed for those. And African Americans are more likely to be negative for some of the common antigens, so they're more likely to make these antibodies. And if you don't have phenotypically matched blood, the incidence of alloimmunization, or these immune responses to blood transfusion, is really high. And once you make an antibody, it doesn't go away. So the more antibodies you make, the more and more difficult it is for you to find donors, and the less donors you have. And some people have to go I had a patient who got his blood from the New York Rare Blood Donor Program, and his blood had to be shipped from somewhere in the United States. The New York Blood Donor Program is national, and they know where all these rare donors are. And so if he needed a transfusion, I had to call them. They would call somebody in North Carolina or something, and that person would go to the hospital to donate blood for my patient. So iron overload, it happens to everybody who has transfusions. Transfusions bypass the body's ability to regulate iron. There's a lot of iron in blood because the iron is required to help transport oxygen. And iron cannot be removed from your body very well unless you use something called an iron chelator, and iron can damage your heart, your pancreas, and your other organs. So if you've had over 10 plus transfusions in your life, you should be checked for iron overload, because that's about the number of transfusions it takes to start seeing your iron level go up. And oral iron chelators are the only way to protect yourself. They have to be taken every single day, but they're effective in removing iron from your body. So you can see this is just a real quick slide. So in '88, 30% of people with sickle cell disease became olive immunized. That's, a third of the patients who you had a 1 in 3 chance of getting an antibody every time you got transfused, and that went down to 1% in 2000 because of this phenotyping, and now it's that low or less maybe. So new therapies. So there's finally some multiple therapies for sickle cell disease. This has been a long time coming. Hydroxyurea was the first, safe and effective treatment for sickle cell disease. It was developed in the 80s, but wasn't really FDA approved until the late 80s, early 90s. And what hydroxyurea does is it increases fetal hemoglobin. Fetal hemoglobin is the kind of hemoglobin you had when you were in utero before you were born and for months later after you were born, and it doesn't sickle. Only adult hemoglobin sickles. So when you're a baby and you're inside your mom, you got to get your oxygen from your mother's circulation, and so there's a special hemoglobin that has a high affinity for oxygen that pulls it from your mom and helps the baby develop. That fetal hemoglobin that gene is always around, and hydroxyurea activates that gene, and you start making fetal hemoglobin, which decreases polymerization, has some other effects, but the ultimate thing is it decreases symptoms of sickle cell disease. It's an oral medication taken once or twice a day, depending on who's prescribing it, usually twice, but in kids. And it can decrease the side effect. The major side effect people worry about is one, cancer, because it is a anti-cancer drug back in the day and still used for some cancers today. It does not cause cancer. It's been used since the 80s, and there's no increase in cancer in people who have sickle cell disease who take hydroxyurea. That's absolutely for sure. And so it's a safe medication. What it does do, though, is it affects rapidly dividing cells, so it can decrease sperm counts in males, but it does not cause sterility. Even if your sperm count is decreased while you're on hydroxyurea, you can still father a child, although that's not recommended because hydroxyurea has other effects that nobody's sure about. So to be on the safe side, if you're a woman or a male on hydroxyurea, you shouldn't have children. You should stop the hydroxyurea, and then if you want to have a child, and that's something you talk to your doctor about, all that kind of stuff. So it's not permanent. Once you stop the hydroxyurea, everything goes back to normal. But in the same vein, men who have sickle cell disease, they have infarcts everywhere in your body where there's blood. So their sperm count is a little bit lower than people who don't have sickle cell disease. And in women, their reproductive age is a little shortened because the sickle cell affects your ovary and your ability to have children. So voxelotor, called Oxbryta, is one of the new therapies. It's an oral drug. And what it does is, at the beginning, I told you that the hemoglobin changes its shape when it becomes oxygenated. So on the right side, that little, looks like spaghetti, that little thing, that's the way it looks, the way hemoglobin looks when it's oxygenated, and it's different than when it's deoxygenated, the one on the left. And so Oxbryta prevents sickling by keeping some of the hemoglobin, not all of it, but some of it in the oxygenated shape. So if it's in that shape, then it's not going to polymerize. You're going to have less hemolysis. Your hemoglobin in the studies, the hemoglobin went up about 1 to 1.5 grams. I'm not aware that there's been another study. There could have been, but I'm not aware of another study that showed that this increase in hemoglobin, decrease in hemolysis, decreased pain, or other symptoms of sickle cell disease, but it should. But it just hasn't been shown in a study that I know about. But increasing your hemoglobin with sickle cell disease is beneficial. And this is something you need to talk to your physician about, whether this is the right medication for you, because if your hemoglobin's already really high, which is unlikely, but then this might not be the drug for you. Crizolizumab, Acavito, is another drug. This is an IV drug that's given about once a month, and it prevents the stickiness of the cellular elements and the lining of the blood vessels by blocking something called P-selectin, which is one of those molecules that makes everything really sticky. And it decreases pain for sure, but in the study, the people could take this medication while they were taking hydroxyurea. So it seems to be safe with hydroxyurea. And there were not enough episodes of acute chest syndrome to know whether or not Acavito by itself would prevent acute chest syndrome. L-glutamine, or Endari, is another medication. It's actually an amino acid called L-glutamine, and it's needed to make antioxidant molecules. L-glutamine is low in people with sickle cell disease. And if you wonder what oxygenation or oxidative stress is, there you've got a tomato, and that's what happens. It destroys or damages cells. This is a bone marrow transplant with HLA matched siblings, is FDA approved, or it's the standard of care. And here, this little guy, his donor here, and he had a bone marrow transplant. This young man came up from Central America because he was so sick. We did a lot of stuff to him. He remained sick, but his mom had a little baby girl, and he got a transplant. He was cured of sickle cell disease, and he's probably in his 20s by now. There are 3 types of gene therapy: gene insertion, gene editing, and gene silencing. So gene insertion is they take a virus that is not the HIV virus at all, but it uses some of the machinery, and it inserts the RNA or DNA into your cell, which is used to make hemoglobin. So it indiscriminately, you collect the stem cells and you transform them with this virus, and then it makes hemoglobin. Gene editing is more specific, so it only affects the hemoglobin gene. This is the CRISPR-Cas9, removes the hemoglobin gene, the S gene, and puts in a normal hemoglobin gene. So then you make normal hemoglobin. Gene silencing is used, same thing, CRISPR, to turn off the gene that has decreased your fetal hemoglobin and increases your fetal hemoglobin to levels higher than what you would get with hydroxyurea. Comprehensive care is really important in sickle cell disease. You have to have continuity. It's kind of what we talked about. Services for all ages, including adolescents, adults. Pediatric care is pretty good. Adult care is really poor, particularly in California, actually. And then there's a couple slides on transition. So after transition, this is that gray line right there. You can see everything just starts getting worse. The red line is pain. The blue line is, or the red line is all complications. The blue line is pain. You can see that blue dotted line. All of a sudden, people stop getting transfused. Hydroxyurea doesn't change too much, but the consequence of this is bad. So this is the mortality. So the higher the line is, the more people, the more frequent death is. And this red line just shows you this is the age of transition. You can see deaths just take off like crazy. And this is because there's no medical care. And you go to the emergency room doctor wants to treat one thing, your pain or whatever. Then they you know, you're done with him or her, and you just don't get care. And you can see this in this is from the CDC, and you can see this. This isn't why they did this, but this is the ages of people with sickle cell disease in the state of California. Well, this is 20 to 29, and this is 30 to 39. What happened to all these people? What happened to them? They died, probably. So this is huge. It's really it's life-threatening. This has to change. It just has to change. So that's the end of my talk. I'm sorry to end on a bad note, but there we go. Okay. Okay, I don't hear you, Carolyn.
You're ending on a contemplative note, and so let's see if there are any questions. I actually want to start. I get to do that. And just two. Well, one is a comment on Dr. Keith talked about ED care. And that came from Jeffrey Glassberg's article, which is excellent, excellent, excellent. And I encourage everyone to read the article. It has exactly what Dr. Keith laid out. You should be seen within the first 60 minutes. Thereafter, checked on every 30 minutes. And it's an excellent article. The question that I have, though, is you mentioned that there are some parents who do not want TCD. Why is that? I understand why some physicians may not do it and they need to be educated, but why would parents refuse TCD? You mentioned that.
Well, I don't think, you have to know what a TCD is, and you have to be educated. And if the doctor doesn't tell you about it or doesn't explain it, you may not realize the implications of getting a TCD. But it's something and it's all the way up to the age of 16 annually. So it prevents strokes. Strokes, like I said, are really terrible. And I was practicing way before TCDs, and I can tell you it was awful. That's the only word I can think of.
Well, Dr. Keith, as always, thank you. This was great. This was phenomenal. We don't see any questions in the chat. They seem to always come a little bit later. And so I do want to thank you. We're looking at our agenda. And so at this time, we are going to show, it is a video that we did called I Am. And so we're going to show the Spanish version right now. And then after that, we'll do we'll have a short randomizer for a prize and take a quick little break. And then we'll be back at 11:15. But right now, we're going to show the I Am video in Spanish. Thank you.
Querida yo joven, así como tu cabello desafía la gravedad y tu piel absorbe los rayos solares, eres increíble. Eres sumamente fuerte y despiertas el cambio solo por existir. Ya eres lo que estás esforzándote por conseguir. la aprobación que intentas obtener, el título que buscas ganar. Eres eso. Algunas personas solo te verán en fases. Te juzgarán por tus cuartos, mitades y crecientes. Pero no dejes que eso te distraiga. Incluso en todas sus fases, la luna sigue entera, así que nunca olvides quién eres. Tu identidad es cósmica, astral, divina, celestial, estelar y privilegiada por la naturaleza. Eres eso. Cuando intenten colocarte etiquetas falsas, malinterpretarte y ensuciar tu nombre, mantente firme en tu identidad y diles: yo soy. La anemia drepanocítica es un grupo de trastornos hereditarios de los glóbulos rojos que afectan la hemoglobina, proteína que transporta el oxígeno en el cuerpo. Los glóbulos rojos son flexibles, redondos, discoidales y circulan fácilmente por los vasos sanguíneos. Si se padece anemia drepanocítica, los glóbulos rojos tienen forma de hoz o lunas crecientes. Las células rígidas y adherentes pueden atascarse en pequeños vasos sanguíneos y retrasar o bloquear flujo sanguíneo y oxígeno a varias partes del cuerpo. Esa obstrucción puede provocar problemas graves como accidentes cerebrovasculares, problemas oculares, infecciones y episodios de dolor, las crisis de dolor. Septiembre es el mes nacional de concientización. Aproximadamente 100,000 personas en Estados Unidos viven con esta enfermedad. El 19 de junio es el Día Mundial. La anemia drepanocítica sigue siendo un importante problema mundial en salud pública. Es una causa importante de muerte en bebés y niños del mundo en desarrollo, sobre todo en África subsahariana e India. Hay alrededor del 50 al 90% de bebés nacidos con la enfermedad morirán antes de cumplir 5 años. Para el 2050 es esperado un aumento de alrededor del 30% a nivel mundial.
All right, thank you. Thank you. And so we'll show that same I am in English a little bit later. Did want to acknowledge there were a couple of comments. So an excellent comment from Carla who says sometimes people's insurance don't cover the cost of a patient's TCD, and that's a shame. That's devastating, actually. Something that can actually prevent future strokes by just knowing how things are going and continuing whether or not to continue transfusion or not. That's a shame. Shira says, Dr. Keith, I always learn something new. Thank you. Me too. All right. So what we're going to do right now is, so for those of you who have gone on and you went on to the Zoom, that means that we actually have your name. So your name is now being entered into a randomizer. And so For the first prize, the first prize that we're actually going to be handing out is a $50 gift card. And so what you need to do, if you aren't already on Zoom, if you're live stream, if you're seeing us live stream, say Facebook Live or Twitter or what have you, which is great, as long as we know, as long as Mary knows, and your name is part of the Zoom. I think that's what how we get your name. Then you're part of the randomizer. So we're going to start that now, and so um, the team will just have to let me know once that starts, and then who the winner is. And so we will need your, we'll get your name. All right, there we go. So the randomizer is going, and these are based upon persons who I believe are in Zoom, and they'll verify whether or not the person is also on. Oh, cool. All right, Lathan. So we'll reach out to you and get your information. So you're our first winner. Thank you. Appreciate you being on. And Lathan was also part of our 3-day seminar in September as one of our young folks with sickle cell disease. All right, so we're going to just take a few minute break for about 3 minutes. We'll get back on, and next up we have our global patient panel, and that one's going to be with our wonderful and beautiful moderators. Nilda and Servio will be back. So just give us about 4 minutes and we'll be back, and enjoy the music. Thank you. All right, everyone, welcome back. Hope you had time to stretch and move and hydrate. And so far, so good for our second annual Hispanic Heritage Sickle Cell Disease Educational Seminar. Welcome. And our theme this time is Our Voice. So far, we've actually learned some data with the SCDC. Jacqueline did a great job. And then we got into some basics with Dr. Keith Carollo. And so now it's time to look at how sickle cell warriors around the globe are managing their sickle cell disease. So we're going to bring back our two moderators, Nilda and Servio, as well as our panelist. And so I'm actually going to turn it over to the moderators. And then you also may want to bring in the panelists as well. I understand that there's someone from Argentina, Silvia Lucero, and someone from Brazil, Tamidas Arahul. And from Colombia, Florencia Maria. And so I'm going to turn this over to our co-moderators, Nelda and Servio. Thank you.
Hi, thank you, Dr. Rowley. This week we had the pleasure of speaking with individuals that represented the global panel. Sylvia is a mother, which her son had transitioned at the age of 24 with sickle cell. And we have Veronica is from Argentina, and she has a sickle cell S with the sickle cell SD, which was the first time I heard of SD. A young lady, Tamira, is from Brazil, born in Brazil, lives in Argentina. And we also have Florencia, which is Colombian. So it was great to have different stories. And I believe in the sickle cell community, we all can see that we all have similarities to our health. We may have different complications, but there's a similarity to the way we have had our upbringing and possibly treating our pain episodes and complications. But there are stories of inspiration, especially for Mrs. Sylvia, which started a group after 3 years of mourning for her son, which I find very admirable. And she holds a group in Argentina. And Veronica is a mother, so that is her strength, is her daughter. So it was a pleasure to speak to them, as hopefully you will see in the video when we had the conversation with all three individuals. And then my mother was part of the panel as well. She shared my upbringing with sickle cell and her being a mom and not having the support that we now have with social media, where persons can ask questions and have focus groups and learn what they can do for their children with this illness, as it was very different for her, not knowing and not having a community of which to know by. And I think that also holds the reason why possibly we didn't have the support groups to know in regards to hospitalizations and treating sickle cell at that time as well. Yes, I believe you would be presenting the video of the panelists.
So for our tech team, if you can do the video, and then I guess bring everybody back. Nilda and Servio will take from there as well. So if we can show the video.
As a patient advocate for persons with sickle cell anemia, and a member of the Patient Engagement and Education Subcommittee at ASH Research Collaborative. She is focused on meeting persons living with sickle cell disease, as well as highlighting the role and responsibilities inherent in being a carrier of the sickle cell trait. She has connected internationally with hematologists, patients, organizations, and learned both Western and holistic methods of treatment. She emphasizes the importance of nutrition and daily affirmations for living a healthy lifestyle with a chronic illness. Her goal as an advocate is to provide the medical information important to warriors and their caregivers, unite the SCD community, and raise awareness of the disease in general. She is joined today by Sylvia Lucero, Tamira Sarajo, Veronica Hornos, and Florencia Maria. Welcome to Communicate, the global patient panel for how we manage our disease. Part of the second annual Hispanic Heritage Sickle Cell Disease Educational Seminar.
Okay, so we're waiting for the next recording.
Nilda Navedo. Soy paciente de la anemia falciforme, tengo 45 años de edad y tengo SS con persistente fetal. Lo que significa es que la médula mía todavía produce el gen F, que es el gen que uno tiene hacia su niñez, y después viene a su hemoglobina adulta. La médula mía todavía produce un 20% de la hemoglobina F, y eso ha ayudado a no tener muchas admisiones al hospital, muchas crisis, pero sí sufro dolores al diario con la enfermedad. Y ahora le paso a mi madre, que es Carmen.
Bueno, buenas noches. Mi nombre es Carmen Navedo. Soy la madre de Nilda Navedo, que es paciente y lleva la enfermedad porque mi esposo tiene el rasgo y yo tengo el rasgo, y por eso ella salió con la anemia falciforme. Cuando Nilda nació, yo tengo que decir la ventaja, porque se supo de una vez que ya ella venía con esa enfermedad. Ella nació en la ciudad de Nueva York. En Nueva York, desde que nacen, le hacen ese examen y ya el doctor me lo dijo. Inmediatamente yo me fui a la casa con Nilda. A mí me llevaron a un seminario psicológico porque ellos me dijeron que mi vida iba a cambiar por completo. Porque hay muchas veces que el niño está bien, en la mañana le puede dar un dolor, hay que internarlo. Yo tuve 3 ocasiones que íbamos de viaje. Todo estaba preparado. Cuando ya íbamos, que al otro día todo el mundo ilusionado, Nilda comenzó con un dolor, ya se paró, ya los nervios míos me dijeron no, ya yo llevé a mi hija, le dieron su medicina, ya el viaje se paró. Y ahí es que ellos dicen que la vida comienza a cambiarle a los padres, porque es que esta enfermedad no dice ni predice cuándo va a doler. Eso aparece de la noche a la mañana. Pueden estar muy contentos, pueden estar activos y ahí llega el dolor. Pero básicamente yo en realidad cuando ella era pequeña no había tanta internamiento ni tanto desesperación. Yo creo que Nilda ahora después de que nos mudamos aquí a las Carolinas y trabajó 18 años conmigo, le daban sus dolores, pero ella se lo atendía. Entonces, últimamente, que después como de los 25, ¿verdad?
Yo duermo mucho.
Ella comenzó que le tuvieron que hacer los hombros, las caderas. Vino un trastorno del vaso, de la vesícula, y tuvieron que sacarle la vesícula. El vaso se le escondió, mas nunca los doctores lo han encontrado. Que en realidad eso es una cosa porque no tuvo esa operación. Pero en realidad, como madre, yo he sufrido mucho, no le digo que no, ha tenido internamientos que hemos pasado un mes en el hospital. A la misma vez, ella me relajaba porque la terapia mía era irme a trabajar. Entonces nosotros teníamos un team. Mi mamá cuando estaba viva vivía conmigo y claro, atendía todo el tiempo a Nilda. Después que mi mamá murió, ella vive con su hermana, con sus sobrinos que viven aquí con ella. Entonces, cada vez que Nilda tenía un internamiento, nosotros trabajábamos, como dice el americano, en team. Todos, no, yo iba a mi trabajo, mi esposo entraba, mi esposo salía, entraba la hermana, dormía. El caso es que lo único que Nilda tiene es que nunca se queda sola en los hospitales. Siempre hay un familiar con ella. Pero hasta la fecha yo digo que es una enfermedad fuerte, es una enfermedad muy dura y como madre creo que el apoyo familiar es muy importante para los falsémicos, al que tiene esta enfermedad. Yo creo que eso ayuda bastante. Bueno.
También como esto es un panel de personas que somos a nivel mundial latino, yo soy de descendencia dominicana y puertorriqueño. Mi mamá es de Santo Domingo y mi padre es puertorriqueño. Como mi madre comenzó la conversación, cuando ustedes dejen saber su nombre, ustedes puedan comenzar el historial de la enfermedad, si desean, o lo compartimos en lo que tenemos toda la conversación sobre el tema de la anemia falciforme. Pues lo pasaría a usted, señora Silvia.
Bueno, buenas noches. Mi nombre es Silvia Lucero. Vivo en Buenos Aires, Argentina. Y yo tengo el gen de la drepanocitosis, pero no he desarrollado la enfermedad. Soy mamá de Franco. Este es mi hijo. Que a los 3 años, mi único hijo, que a los 3 años le detectaron la enfermedad. Habíamos hecho un viaje, yo tengo mi familia en otra provincia, en Mendoza, habíamos ido para allá, hizo fiebre Frankie, y al otro día lo llevo al médico y bueno, el médico me decía, bueno, debe ser la sexta enfermedad, no le daba bolilla. Entonces yo le dije, no, doctor, ¿y por qué no hacemos análisis? No sé, esas cosas que tenemos el sexto sentido de las madres. Bueno, me dice, hagamos el análisis. Bueno, ahí en el análisis saltaron algunas células que para él no eran tan normales, digamos. Entonces me dice, mira, seguramente Franco tiene anemia del Mediterráneo porque mi marido tiene la talasemia minor. Sus abuelos son de Italia y de ahí él heredó esta anemia. Entonces el médico dice, Franco debe tener eso, pero por las dudas te derivo al hematólogo para ver qué dice. Bueno, el hematólogo lo estudió a Frankie, llevó bastante tiempo los estudios y después nos terminó diciendo que nos tenía que estudiar a nosotros también. Entonces estudió al papá, a la mamá, a los abuelos por ambas ramas y después terminó diciéndonos, bueno, mira, Franco tiene una anemia perniciosa que se llama drepanocitosis o anemia falciforme y bueno, nos dio la explicación de las cosas que no iba a poder hacer, esto de que no pueden hacer mucha actividad física, que iba a sufrir algunas crisis de dolor. Bueno, más o menos nos dio una explicación de lo que era la enfermedad. Yo no entendí nada, yo pensé que Frankie, no sé, como que tenía leucemia, pensé, y que se iba a morir. La verdad que ese fue mi pensamiento. Después, bueno, empecé a indagar sobre la enfermedad, preguntarle más a los médicos. Bueno, ahí aprendí lo que era esta enfermedad. Y bueno, Frankie tuvo sus recaídas, sus internaciones, le hicieron distintos tratamientos. Primero le dieron inyecciones de eritropoyetina, que eso va para los riñones, para ver que los riñones hicieran, tengo entendido que era para que dieran más hemoglobina fetal. Por un tiempo anduvo bien, pero después era como que lo mismo. Y después le daban ácido fólico, por supuesto. En las internaciones, bueno, le daban morfina, que cuando Franco tenía 5 añitos, la primera vez que le pusieron morfina, cuando me dijeron a mí, ay, yo caí en una crisis terrible de nervio, porque digo, para mí la morfina se le daban a los soldados cuando venían de la guerra o a la gente que tenía cáncer. ¿Cómo se lo iban a dar a un niño de 5 años? Bueno, el médico me explicó que en bajas dosis al niño no le iba a hacer daño. Bueno, fue todo un proceso de aprendizaje con esta enfermedad. Frankie, la verdad es que tuvo una vida normal en primaria, secundaria, llegó a la universidad, llegó a hacer 3er año de medicina, él quería ser médico del dolor y no sufrió necrosis, tampoco tenía bancos de hierro en sus órganos. En algún momento le dieron la hidroxiurea, ya de grande, se le quisieron dar a los 10 años, pero acá no estaba aprobada en niños todavía y nosotros no aceptamos que se la dieran. Porque, bueno, no haber, yo decía, no, mi hijo no es un conejito de India, si no estaba aprobado en niños, y le pregunté al director de hematología del Hospital Posadas, que es pediatra, y me dijo, yo le fui muy clara, doctor, si fuera su hijo, ¿usted se la daría? Y entonces me dijo, no. Entonces listo, ya está, y nosotros tomamos la decisión, no se la dimos, y Franco vino a tomar la hidroxiurea a los 18 años recién, o sea, ya era mayor. Así que bueno, como comenté, Frankie hizo una vida normal, le puso pasión a toda su vida, no dejó de hacer nada, llegó a ser bombista en una murga también, hizo campamentos en el colegio, hizo todo lo que quiso. Pero bueno, a sus 22 años, un día se descompone, él mismo pidió que lo lleváramos al hospital porque se sentía con mucho dolor, lo llevamos al hospital y bueno, y de un día para el otro fallece. A sus 22 años, producto de esta enfermedad, no supieron los médicos si había sido algo a nivel pulmones, a nivel del corazón. Bueno, imagínense, terrible dolor. Nosotros no tuvimos más hijos porque los médicos nos asustaron, digamos, nos dijeron, si ustedes tienen más chicos, van a tener probablemente el mismo problema. Entonces, bueno, no tuvimos más hijos y bueno, a base de que yo transité la enfermedad de Frankie sola, porque después de unos años vengo a conocer, la primera persona que conozco a Vero, que está acá presente, y a su hermano, con la enfermedad. Y después, bueno, fui conociendo a algunas otras personas, pero en general, la verdad es que al principio yo lo transité sola. Yo me comunicaba con las chicas de Costa Rica, con la fundación de allá, y ellas me iban orientando, me iban explicando también lo de la enfermedad, yo le hacía muchas preguntas a ellas, porque acá los médicos no conocen prácticamente esta enfermedad, porque acá es considerada una enfermedad rara o poco frecuente. Es muy baja la incidencia que hay en la población, entonces son pocos los pacientes. Entonces los médicos no tienen experiencia, ese es el problema. Entonces, por ahí llega una persona con una crisis de dolor terrible y no quieren darle morfina, por ejemplo. Ese es un gran problema que tenemos acá en Argentina. Entonces, bueno, en base a eso, a que yo la pasé tan mal y sola, dije, bueno, voy a armar un grupo. Yo sabía que acá en Argentina no había ningún grupo. Entonces, me invitan un día desde Costa Rica, la chica de la fundación de allá, me dijo, Silvia, ¿querés hacer vos parte de la campaña como si en nombre de Argentina y hacer un homenaje a Frankie? Bueno, contar la historia, sí, le dije yo. Bueno, así que fue así, la primera vez que empecé con esto, hice la historia de Frankie, ella la publicó y de ahí quedó como que, bueno, como que era la representante de acá de Argentina. Así que armé el grupo de WhatsApp, que ahí me ayudó Vero, que está acá presente, pero yo no sabía ni armar ni un grupo de WhatsApp. Y después con otra amiga, que también ya está en el cielo, me ayudó a armar la página de Facebook Y bueno, así como nace, como digo yo, drepanocitosis, anemia falciforme argentina, somos ya varios padres y pacientes en el chat que nos acompañamos, nos damos ánimos, difundimos la enfermedad. Y bueno, cuando a alguien le falta, por ejemplo, hidroxiurea, algunos hospitales acá no los está entregando a las obras sociales, hay problema a veces para que la entreguen, es una droga cara. Entonces, bueno, si alguna mamá, por ejemplo, hace poco una mamá de Mendoza, de la provincia de Mendoza, tenía hidroxiurea además, la mandó a Salta, a otra provincia, para que un nenito de 4 años que recién le estaba dando hidroxiurea, sus papás pudieran darle la medicación y estaba, la verdad, feliz el papá. Así que bueno, así es como nace. Este es el folleto que tenemos de la
Qué lindo.
Muy bonito. Sí.
con toda la explicación de la enfermedad. Y bueno, como yo digo, que agradezco a Dios y a mi hijo Franco, que son mis guías para llevar adelante este propósito, que es acompañar a los pacientes, a los padres, para que tengan esperanza de que sus hijos van a crecer y van a estar bien, transitando esta enfermedad. Y bueno, como les comentaba los otros días, que yo había encontrado también, que tuve la alegría de encontrar la paciente, creo que es la más grande que tuvimos acá en Argentina, en el Bolsón. Silvia también, Silvia del Toro, llegó a tener 65 años, 3 hijos, nietos, y una vida, la verdad, una vida, por supuesto, con altibajos, como ella decía, pero una linda vida, y la vivió a pleno, lo mejor que pudo, y bueno, ya partió, pero también partió en paz y bien, ¿no? Así que, bueno, es una alegría para mí poder compartir la experiencia de vida de mi hijo, la mía, y acompañar a los pacientes y a los padres en este tránsito de la enfermedad y difundir esta enfermedad que, como les dije, acá no se la conoce prácticamente. Y bueno, mi ilusión es poder llegar a que hayan más médicos que hablen de esta enfermedad, que se dé en la Facultad de Medicina, y que los laboratorios nos ayuden y que puedan donar la medicación que necesitan. Bueno, esos son los objetivos.
Y yo la admiro mucho porque a tener una crianza que ha fallecido con esta enfermedad es muy dolorosa, y la admiro porque usted cogió esa fuerza para poder darle una esperanza y una ayuda a las familias que no tienen por dónde buscar. Y lo digo por ejemplo porque mi prima falleció a la edad de 20, teníamos 2 años diferencia de edad, y después que mi prima falleció, a mi madrina se le apagó la luz. Y por eso digo que la admiro mucho, porque usted cogió fuerza y ha podido ayudar a personas como nosotras. Y mira, Verónica, un perfecto ejemplo de las 2 señoritas que están aquí, porque usted ha podido ser una base de información sobre la anemia en su país. Y con eso se lo paso a Verónica.
Gracias.
Sí.
Bueno, Verónica, mi nombre, 40 años. Hago así como una breve introducción. Yo me descubrí la enfermedad antes de cumplir el año. Empecé con los típicos dolores de manos y pies, que es como empieza. Me empiezan a hacer todos los estudios, me encuentran anémica, y bueno, el proceso de dar el diagnóstico. Mis papás, bueno, como cuenta Silvia, acá es sumamente desconocida la enfermedad. Yo a esta edad sigo teniendo problemas para que los médicos puedan seguir el ritmo de lo que es, de las consecuencias que trae. En mi caso, soy politransfundida. Este año la última vez que recibí transfusión fue en mayo, pero por los general me estaban transfundiendo cada 2 meses. He recibido muchísimas internaciones por crisis de dolor, porque en casa los remedios no me solucionan los dolores, entonces necesito que sea por endovenoso. Recibo morfina, tomo morfina diario, tengo muchísimas necrosis, pie, hombro, muñeca, rodilla, cadera, y solo estoy operada en la cadera izquierda. Sí, no sé cómo estoy parada, pero sí. Hasta el momento, sí. Hasta el momento solo me operé de la cadera izquierda, que mi primera necrosis fue a los 16 años. Fue sumamente traumático tener 16 años y que me pasase eso, porque no entendía nada, porque la información que hoy manejo en ese entonces no la manejaba, acá no se conocía. Claro. No estaba un clic como es ahora, que vas a internet y más o menos te pueden guiar. Soy heterocigota, que también es algo que me llama la atención, porque muchos hematólogos, yo he tenido muchos hematólogos en mi vida, me dicen que yo tengo hemoglobina S, que recibo de mi mamá, y hemoglobina D, que recibo de mi papá. He tenido hematólogos que me han dicho que no conocen la existencia de la hemoglobina D. Sin embargo, yo la tengo. Y que no podría, no tendría que ser tan feroz, o no sé qué palabra usar, disculpen si no pongo las palabras exactas, mi anemia, mi drepanocitosis, porque no es SS. Sin embargo, yo la padezco y mucho, de toda la vida. Sí. Bueno, en la actualidad hago muchas crisis, pero no me estoy internando desde el 2017 por crisis de dolor, y es un montonazo porque yo por año me internaba, no sé, mínimo de 3 a 4 veces por año por crisis de dolor, y estaba mucho tiempo, o sea, varios días, mucho tiempo, incluso un mes internada por los dolores que no cedían. Y ahora desde el 2017 que por crisis de dolor no recibo internación. Sí para transfundirme, pero bueno, ya es como, lo tomo de otro lugar, es más llevadero, si se quiere. En casa tomo morfina, no creo que ya lo dije, de manera diaria, también por las necrosis, porque también son dolorosas. Sí. Y, ¿qué más? Bueno, fui mamá hace 2 años y medio, que no pretendía hacerlo, no lo esperaba, se suponía que no podía hacerlo. Yo tomé hidroxilina durante muchos años, me la indicaron alrededor de mis 25, más 24, 25 años, fue la primera vez que yo conozco esa medicación, pero nunca surgió el efecto que esperado. No, bueno, mi organismo no lo tomó de esa manera, sí. No funcionó en mí. Entonces, pasaron muchos años, alrededor de entre 10 y 12 años, para que yo termino con una internación, con un hematocrito muy bajito, un hematocrito de 9, 3 de hemoglobina, y termino en terapia. Bueno, tuve problemas en ese momento en la vesícula, pero no pudieron operarme porque no tenía defensas, no tenía glóbulos, o sea, estaba bastante complicada. Bueno, salí a flote y los hematólogos que me veían en ese momento, yo me atendía en el hospital de clínicas acá, que es un hospital escuela, y venían hematólogos como varios, no uno solo, y concluyeron que la hidroxurea me había llevado a ese extremo, porque por la cantidad que estaba recibiendo. Me tomaba 4 comprimidos diarios de 500 miligramos, y era como bastante, era mucho. Entonces, después de ese momento, me dijeron que me hicieron análisis, perdón, no es que me dijeron, me hicieron análisis, y bueno, mi sistema, amén, de que es difícil ya un embarazo, un proceso de llevar un embarazo con nuestra enfermedad no es sencillo. Los análisis daban que mi sistema reproductor estaba, ¿cómo decirlo? No recuerdo la palabra que utilizaron, pero bueno, averiado, por decirlo de alguna manera, atrofiado. Ahí está, atrofiado. Y después de ese año, yo suspendí la hidroxurea. La médica no estaba muy de acuerdo, pero después de todo lo que pasé, que fue un año muy, muy feo para mi salud, no, o sea, me costó mucho levantarme, reponerme, la suspendí y 2 años después, 3 años después, disculpen, llegó mi hija y llegó sana. Yo ya le hice todos los estudios, la analicé por todos los costados. Ella recibe de mí la hemoglobina D, pero como Silvia, no manifiesta la enfermedad. Es portadora, entonces en el futuro tendrá que tener cuidado. Pero ella no tiene nada, no tiene nada. Es súper sana, muy feliz por eso. Y bueno, en sí así, bueno, yo la transito como puedo, porque con el tema de la maternidad y que no estás quieto, no es como antes que me tiraba en la cama y bueno, que pasase la crisis cuando quisiese, ahora es diferente, pero ayuda mucho el tema emocional, ayuda muchísimo, y yo antes por ahí no lo podía ver de esa manera. Me cambió mucho la forma de ver. Lo que me gustaría para este país, para donde nosotros vivimos, como decía Silvia, es que los médicos se interioricen, que sepan y que no nos juzguen, porque por lo menos yo, cada vez que tenía que recibir medicación endovenosa, morfina o opiáceos en general, me sentía juzgada. Muchas veces me sentí juzgada y no me la querían dar porque eran cantidades como muy elevadas o por lo que uno necesita, no están quizá acostumbrados, pero todo parte del desconocimiento. Entonces, eso es lo que nos falta acá para que los hematólogos y los médicos en general, cuando llegas a una guardia, te puedan atender como uno lo necesita, porque realmente los dolores son descomunales.
Ay, Dios. Le digo que contando su historia se nota que su hija para ti en este momento te da la fortaleza.
Totalmente.
Ahora siendo madre, teniendo una niña, no se puede quedar acostada. Si hay una crisis, hay que mejorarse porque tiene otra persona para quien cuidar.
Tal cual.
Y la diferencia cuando uno es madre y tienen hijos que son, gracias a Dios que no tienen la farsemia, pero con el rasgo sí, tú le das su educación para su futuro.
Exacto. Sí, esa es mi misión en la vida, es que ella sepa, aprenda, para que en su futuro no tenga ningún inconveniente y lo pueda atravesar bien.
Exacto. Exacto, muchas gracias. Y
no, gracias a ustedes.
Ahora, señora Tamírez.
Me llamo Tamírez, tengo 27 años, soy brasileña y vivo en la Argentina desde 2017. Fui diagnosticada a los 13 años. Durante la infancia pasaba por varias situaciones, pero no llegaba a un diagnóstico. Tenía múltiples infecciones, siempre estaba internada, pero los médicos no llegaban a un diagnóstico. Sí decía que tenía anemia y me daban hierro, así que tomaba mucho hierro durante la infancia. Pero bueno, hoy analizando tiempos atrás, o sea, yo siempre tenía los pies hinchados, las manos hinchadas, dolores, y mismo así nos llegaba un diagnóstico. Y recién a los 13 eh, recibí, o sea, hice un estudio y ahí me diagnosticaron, pero tampoco me dieron mucha información sobre el tema, a pesar de que en Brasil es muy común la enfermedad. No me dieron mucha información, yo nunca había escuchado hablar del tema, mi familia tampoco. Eh, entonces me dijeron que tenía que tomar ácido fólico, pero no me dieron ninguna orientación para enterarme qué significaba todo eso. Yo tuve que buscar por cuenta propia porque no vino ninguna explicación de la parte de, digamos, médica. Eh, Igual, mismo con el ácido fólico, me seguían dando hierro y hacía, o sea, seguía siempre con muchas infecciones, internaciones. En 2017 me mudé a la Argentina y, y ya en los primeros meses, cuando vino, o sea, el primer invierno en Bariloche, me sentí muy mal y busqué a una guardia, y en ese caso el médico clínico que me atendió, como que yo tenía que decir que tenía algo, ¿no? Que tenía drepanocytosis, y en el caso los médicos no sabían cómo, qué hacer, no sabía qué era. Y hasta la médica que me atendió en el momento, ella me dijo que tenía casi 40 años como médica y nunca había atendido a un paciente con drepanocytosis, y que creía que fuera otra cosa y que yo tenía vergüenza de decir. Así que me pedí un estudio de todo contra cosas como de HIV, de hepatitis, porque ella creía que fuera algo así y no la drepanocytosis. Eh, una vez ya haciendo, digamos, los resultados, ahí ella me pasó para una hematóloga, y la hematóloga sí ya me indicó para tomar hidroxurea, que hasta los 21 yo todavía no tomaba. Y bueno, empecé a mejorar un poco con el tema de hidroxurea, pero tenía dolores crónicos ya por la falta de tratamiento que tuve, ¿no? Durante todo el tiempo, porque no traté. eh, y ahí necesité empezar un tratamiento para el dolor. eh, y desde entonces manejo más o menos la misma medicación, solo voy cambiando las dosis cuando necesario. Eh, en el caso tomo pregabalina, 75, tomo media actualmente 2 por día, y bueno, el tafirol, paracetamol de 1 gramo, y morfina rebajada en 2% la tengo en casa en el caso de que empiece una crisis, empiece con la medicación en casa. Tuve épocas que llegaba a tomar, digamos, por lo menos durante un mes tomaba 20 días, pasaba tomando morfina. Y actualmente en los últimos, o sea, en el último mes, como que disminuí la cuestión de la morfina. eh, ya hubo veces de no tener, o sea, la morfina no hacer efecto, entonces tenía que ir al hospital, estar internada, o necesitar a veces estar internada por poco tiempo, pero para que me inyecten. Eh, Tuve otras complicaciones también con relación, digamos, a tantas infecciones, más, o sea, yo contraí COVID, entonces también era como una infección, entonces todo eso potencializó algunas crisis, problemas cardíacos, pero actualmente, digamos, vengo de un tiempo que vengo mejorando, que estoy más o menos estable, pero siempre tengo esta cuestión, ¿no? Que un momento estoy estable y de repente vuelve a empezar más crisis y muchas infecciones una tras de la otra, y después se me estabiliza de nuevo. Pero como que aprendí que a lo largo del tiempo que el autocuidado es una de las cosas más importantes que te evitan crisis, o sea, la hidratación, el no estar en, digamos, en temperaturas, cambios de temperaturas muy rápidos también. Y como yo vivo en Bariloche, que hace mucho frío, entonces siempre tengo que tener más abrigo que las otras personas, porque con cualquier cosa ya tengo crisis. Entonces tuve que aprender a vestirme, no guiar por las personas, básicamente.
Claro.
Y eso fue como que me ayudó bastante una vez que aprendí esto, porque yo a veces miraba a la gente, bueno, no tiene ropa de frío, y salía afuera y luego enseguida ya estaba con crisis de dolor o más, ya me enfermaba de otra cosa, y y así iba, no tenía resistencia como las otras personas. Una vez que aprendí esto, como que me facilitó bien la vida. Y así que nada, conocí el grupo creo que en 2018, porque yo me sentía un poco sola y justo estaba mirando por Facebook para ver si había más pacientes y ahí vi el grupo y justo era una campaña y me tomé y desde entonces cuando puedo participo. Pero yo creo que sería importante más que nada, o sea, que la Argentina tenga más conocimiento, que los médicos sepan más del tema. Por suerte en Bariloche, cuando yo llegué, pasó todo por esa situación, pero luego enseguida una médica se interesó y hizo una capacitación, digamos, para crisis de dolor en personas con falciforme y en ese momento no había otro paciente con ella. Yo era la única paciente de ella y mismo así ella quiso hacer una especialización en la área. Y eso para mí fue muy importante, como que me dio más fuerza y yo sé que cuando me pasa algo sé que puedo contar con ella, entonces también me da esa tranquilidad y uno tener una tranquilidad así como te pasa confianza y yo como que evita un crisis también, porque el emocional juega mucho en esta cuestión, ¿no? Entonces, al saber que puedo estar segura que si me pasa algo, hay alguien que me va a cuidar, que me va a ayudar, me evitan que yo tenga que ir al hospital. Y bueno, nada, yo creo que eso fue una de las cosas más importantes. Ojalá hubieran más médicos dispuestos a estudiar y a entender más sobre el tema, que infelizmente en Argentina no es el caso. En Brasil, a pesar de ser una enfermedad muy común, también muchos médicos, principalmente en la región sur, que es a donde yo nací y viví casi toda mi vida, también como que falta empatía de la parte médica, no es falta de conocimiento, ¿sí? De voluntad de atender a un paciente con drepanocytosis, que muchas veces uno llega al hospital y ellos piensan, bueno, una vez más, muchas veces hubo casos de que los médicos piensan que uno está ahí no porque tiene dolor, y sí porque ya es adicto a la medicación o porque está haciendo dramatizando y no es así, como que no creen el dolor del paciente. Y eso no solo, yo creo que pasa en todos lados, infelizmente es la realidad del sistema de salud de casi todos los países cuando se trata de la drepanocytosis. A pesar de ser una enfermedad muy común, digamos, no solo en Brasil, pero una de las enfermedades genéticas con más personas que padecen, infelizmente es muy poco conocida, muy poco atendida y muy poco respetada también, porque la gente piensa que todo es drama.
Es muy cierto lo que acabas de decir y también dijiste muchas cosas que la comunidad, escuchando lo que ustedes han dicho, y ahora vamos a ver de la señora Florencia, pero antes de introducirla es que lo importante que ustedes han dicho que conocer su cuerpo es muy importante. Yo pensaba que era aquí en los Estados Unidos que los doctores veían a los pacientes con la percepción de que son adictos. Yo pensaba que era algo que era más común aquí porque nunca lo he escuchado por personas que viven en las afueras. Pero cuando Verónica mencionó y la señora Silvia mencionó sobre tener los narcóticos desde una edad más joven, aunque yo vivía aquí, no sé si era por la crianza o familia, yo no me crié con los medicamentos fuertes, con los narcóticos. Pues yo sufrí mucho dolor hasta la edad de los 19. Pues después de tener 19 fue que me comenzaron a introducir los narcóticos para la enfermedad, pero a la misma vez me da conformidad saber que sí están tratando los dolores con los medicamentos que son para esta enfermedad, pero se nota que todavía el problema de conocer lo que es la anemia falciforme y entender para todos la historia son iguales. Y me alegro que estamos llegando a ver eso por cada persona. Y ahora le voy a introducir a la señora Florencia. Muchas gracias. que dije, vamos a tener a Colombia.
Con gusto. Es que estuve un poquito ocupada y venía corriendo. Ay, Dios mío, me comprometí. Bueno, pero lo logré, gracias a Dios.
Está bien, sí. Pues estamos
Sí, aquí está
preguntando su
Colombia.
nombre, de dónde eres, su relación a la anemia falciforme, y para que nos dé todito hemos dado en cuenta sobre nuestro historial con la enfermedad.
Bueno, mucho gusto. Mi nombre es Florencia María Ojeda Ospino. Soy colombiana, vivo en Barranquilla, la ciudad de Shakira. Soy pues oriunda de otra región que es La Guajira, en la parte más superior norte de Colombia. Vengo de allá y pues mi relación con la anemia falciforme, soy paciente, o sea, de positiva total, padre portador, madre portadora. Soy la menor de 7 hermanos, soy la séptima y la única con la enfermedad. Mis 5 hermanos, o sea, 4 hermanas y un hermano con rasgo y una hermana totalmente negativa, sin rasgo ni nada. Ninguna de ellas pues padeció nada, ni antes ni a la fecha. A mí me fue diagnosticada la condición a los 8 meses de nacida. Yo nací en La Guajira y pues nací bastante pálida, bastante amarilla, con mucha ictericia en los ojos. Y pues todo esto, entonces mi mamá pues consultaba regularmente al médico y no, que a veces dicen que a los bebés póngalos al sol, pero nunca se quitó. A los 8 meses pues me llevó a un pediatra fuera del pueblo donde vivía mi mamá, un pueblo pues donde había más especialidades médicas, por así decirlo. Y ahí pues el pediatra me mandó a hacer el diagnóstico a través del examen de la electroforesis de hemoglobina y me fue diagnosticada la condición de anemia de células falciformes, como pues le solemos llamar acá en Colombia, es más conocida como anemia de células falciformes que como drepanocitosis. Pues más ahora ya se está generando una mayor conocimiento sobre los nombres, porque pues tiene varios nombres, ciclemia, drepanocitosis, anemia de células falciformes, entonces como que ya se está generando en el común o en el gran mayoría de personas que podamos entender que la drepanocitosis o la anemia de células falciformes es lo mismo. Bueno, ¿qué les cuento? La niñez fue como la etapa para mí más difícil, fue la etapa más, digamos, de mayores riesgos, de mayores complicaciones. Esto lo cuento pues que me lo ha contado mi mamá. Tuve muchas complicaciones renales, de pronto, cardíacas, pero afortunadamente, no sé, pues yo soy muy creyente, no me dejaron muchas consecuencias, por así decirlo. Y no sé, ¿me están escuchando?
Sí, se está escuchando
¿Sí?
bien. Aunque
Ok,
el
perfecto.
video va un poquito más
Pero se está
lento, pero
escuchando.
su voz está entrando bien con el tiempo, sí.
Ok, perfecto. Y bueno, tuve muchas complicaciones en la niñez, como decía, pero afortunadamente eso no me dejó grandes secuelas. Actualmente no tengo ninguna complicación renal, ni cardíaca, ni pulmonar. Solo tengo un poco de ¿cómo es? Fibrosis hepática. Bueno, a mí de niña sí siempre me trataron con ácido fólico y la fortaleza o el complemento fue alimenticio más que todo. Es decir, mi mamá estuvo mucho más enfocada en ayudarme o fortalecerme a través de la alimentación que pues medicamentosamente. Creo que también fue una ventaja, pues porque pues de pronto eso no me complicó más de tomar tanto medicamento desde niña. Entonces empecé, cuando nos trasladamos hacia la ciudad donde vivo actualmente, Barranquilla, empecé con hematología un doctor pues muy excelente acá en Colombia y acá en la ciudad donde yo residí. Y pues a través de él entonces empecé otros tratamientos con medicaciones que él iba pues siempre cambiando. Más que todo a veces me ponía unas que otras vitaminas, algo para prevenirme pues las crisis de dolor, que era como lo más frecuente para mí, o han sido las complicaciones más frecuentes, las crisis de dolor. Afortunadamente nunca he estado en UCI, pues estuve en un riesgo altísimo cuando se me estirpó la vesícula por cálculos biliares de acumulación de bilirrubinas. Entonces la vesícula se me estirpó y tuve una complicación porque se me contaminaron los órganos. Tuve una cirugía donde la probabilidad de vida era 5%, pero bueno, esa probabilidad se cumplió porque aquí estoy. Y digamos que ha sido como una de las complicaciones más graves que he tenido. Y una vez, bueno, 2 ACV que me han dado, bueno, más de 2, me acaban de notificar hace como un mes que el neurólogo, el psiconeurólogo me vio y me dice que no solamente han sido 2, que han sido muchos y que tengo algo de daño en algún área del cerebro, no sé. Pero los ACVs no me dejaron secuelas, digamos, visiblemente físicas. Estuve en el tercero que tuve, en el tercero, bueno, el segundo para mí, pero fue el tercero porque el primero fue muy leve y no. El tercer ACV que me dio, sí me dejó una pequeña parálisis en el lado derecho, brazo y miembro inferior derecho. Y duré como un mes aproximadamente en recuperación terapéutica y se cumplió al 100% y pues hoy día no tengo ninguna secuela de eso. Pues acabo de darme cuenta que tengo la secuela, digamos, cerebral, pero tampoco parece ser que es una secuela muy o un daño muy grave. ¿Qué más? Bueno, empecé a tomar hidroxiuria aproximadamente como a los 30 años, 28 o 30 años. Yo tengo 51 años, pues no había dicho mi edad. Tengo 51 años y empecé a tomar hidroxiuria, que la conocí a través del médico como a los 30, haciendo pues el ensayo, por así llamarlo, a ver si era posible, porque como le escuché a la señora Verónica, no a todos los pacientes suele pues acertarnos, ¿cierto?, el medicamento. Hubo un primer ensayo, no fue como muy positivo, la verdad. Entonces él me la suspendió. Luego pues pasé a otro médico, otro hematólogo, y empezamos a ensayar nuevamente y pues sí ha sido, digamos, bastante acertado. Lo que han aplicado conmigo en frente a la hidroxiuria es no mantenerla de manera permanente, sino cuando hago crisis de dolor repetitivas, entonces hago un periodo de tomar el medicamento. Luego cuando entro como en un equilibrio o en una estabilidad, pues la suspendo por unos meses y luego si vuelven las crisis, pues entonces me la reinician y así. Como les comenté, las crisis más fuertes que he tenido han sido crisis de dolor horrorosas. O sea, para mí las crisis de dolor han sido la complicación mayoritariamente en mi vida y las que más recuerdo. Y bueno, para mi fortuna también conocí la hija de mi médico que estaba acá y pues ella armó un grupo. Yo me sentí como hasta los 25 años, yo me sentía la única con esta condición acá en este mundo y en este país, mejor dicho. Y con ella pues nos contactó a muchos pacientes que eran de su papá y que ella estaba recibiendo, y armamos una pequeña fundación de apoyo a los pacientes, de pacientes para pacientes. Ella fue un apoyo fundamental desde el 2017 hasta el 2021. estuvo siempre con nosotros, nos formó, yo digo, fuimos educados increíblemente por ella. A través de ella, pues, y de la fundación, pues, conocí a Nilda y a muchas otras fundaciones y muchas otras cadenas y muchas otras páginas y todo, y tuvimos conferencias y es un enriquecimiento maravilloso. Y acertadamente, como dicen Verónica Tamírez, bueno, la señora Silvia no la logré escuchar, pero el autoconocernos, el conocer la condición, el conocer los ires y venires, el saber nosotros qué es esto, cómo se maneja, cuáles son las cosas. Además de eso, identificar esas cosas en nuestro cuerpo para prevenir. Ella a veces nos preguntaba, ¿ustedes cómo saben que les va a dar una crisis? Yo decía, yo sí siento cuando me va a dar una crisis. Ella decía, ¿pero cómo? Yo digo, yo siento como un aura que me avisa, hay un dolor por aquí, hola. Pero ¿cómo es eso? Yo decía, pues, ¿cómo lo explico? ¿Cómo lo explicamos? Entonces ella decía, eso es bien importante. ¿Por qué? Porque si tú sientes como que, oye, yo siento unas sensaciones como que no son normales en mi cuerpo, es importante entonces entrar en reposo, la alimentación, el consumo de la hidratación, el no exponerte a temperaturas muy altas, frío, o muy extremas en calor, el ejercicio físico, no hacer tanto ejercicio físico o el estrés, como bien han dicho todas, de la parte emocional es fundamentalísimamente fundamental. Y bueno, con ella aprendimos, wow, así como dijo Tamírez, es tan importante tener una persona de apoyo. Pues desafortunadamente ella se tuvo que trasladar de ciudad, creo que ya hasta de país, y pues ya no estamos con ella, pero continuamos en el grupo, siempre que podemos apoyamos. Si alguien se siente mal, que me está dando esto, que han hecho ustedes, pues siempre recomendamos, pues antes que todo, consultar sus médicos primarios o su hematólogo, pero damos a veces sugerencias como caseras y todo eso. Mi manejo de dolor ha sido, pues yo casi todo manejo de dolor hasta cierto nivel. Yo tengo mi medición de dolor y digo, bueno, tengo dolor en 5, puedo manejarlo en casa a través de pastillas. Suelo tomar pues acetaminofén combinada con tramadol o con oxicodona, o sea, combinadas, no oxicodona sola, sino combinada con un poquillo de oxicodona con algo de acetaminofén o codeína. Es el tratamiento que mantengo cuando hago la nivelación de mi dolor. Cuando ya paso a un nivel mayor de dolor, pues tengo un servicio en casa de atención médica que me maneja contramal intravenoso, y si el nivel de dolor pues no es controlado a través de este medicamento de tramadol o tramal, entonces ya sí pues hay traslado, internación, y pues ya sería pasar a morfina. Han sido, gracias a Dios, muy pocas las oportunidades contadas, podría decir que unas 8 o 10 oportunidades en que he recibido morfina, y la última sí es la que más recuerdo porque fue este año, obviamente. Ahora en julio estuve 6 días continuos con dolor, y la morfina ya estaba llegando pues al tercer día, la morfina no había logrado aliviarme. Entonces me pasaron con medicina del dolor y cuidados paliativos. Entonces, pues la medicina del dolor y cuidados paliativos me complementó con medicación oral, y pues logré a través de la complementación medicamentosa recuperarme, y estuve 8 días internada, de los cuales fueron 6 con dolor, bueno, 5 con dolor, el sexto ya mejoró, el séptimo ya pues desapareció, y al octavo pues me dieron alta para seguir en casa. Actualmente estoy en manejo con mi internista, con mi hematólogo y con medicina del dolor y cuidados paliativos. También tengo pues manejo con psiquiatría actualmente, y neuropsicología y neurología, por la detección, como les dije, de los daños que fueron percibidos en algún área del cerebro. La psiquiatría porque estaba presentando trastorno del sueño, entonces pues me remitieron a psiquiatría para regularme esa parte del trastorno del sueño, y también por la medicación de medicina del dolor. La medicación requiere como un control de psiquiatría porque puede generar de alguna forma momentos o episodios de ansiedad o algo, la medicación del dolor que tengo permanente. El doctor me puso una medicación permanente cada 8 horas y pues la verdad me ha servido, no he sentido ni cosquillas desde julio, o sea, llevo 3 meses así como en la gloria de Dios, como dicen por ahí, porque no me ha dado crisis de dolor, no he sentido así como esa. Además también tengo fibromialgia, tengo artropatía falciforme, o sea, mis articulaciones me estaban doliendo horrible y la fibromialgia me complicaba la cuestión. Entonces la fibromialgia también genera pues como mucho decaimiento porque da mucha pesadez, da mucha fatiga muscular. Entonces todo eso el médico de dolor y cuidados paliativos pues lo está manejando con unos 3 medicamentos y la verdad me han caído geniales. Y creo me han ayudado mucho también para complementar el evitar las crisis de dolor de la anemia,
Sí.
de la drepanocytosis. Y bueno, esto es mi historia. No sé si tienen alguna pregunta.
No, sí, yo creo que toditas definitivamente cuando dicen que son guerreras y guerreros o somos, por lo que ustedes han contado. Y yo sé que van a haber personas que van a escuchar cada historial que hemos dado y va a haber un conocimiento a decir, sí, esto es lo que yo he sentido. Esto es lo que yo hago para tener mi tratamiento. Así es que yo me siento. Mi madre me hace, yo me veo abrigada un poquito más. Y por cada historial que nosotros hemos compartido aquí, pienso que le va a dejar saber a las personas que no están solos en el sufrimiento de lo que es esta enfermedad, porque es una enfermedad que, como digo, el que se está criando ahora tiene la red y puede ser buscar y ver qué ayuda y aprender, pero muchos de nosotros nunca teníamos esa información al principio. Y entonces, aunque yo escucho la historia de cada uno, sea algo en común, digo, sí, eso también lo hago yo. Ya he reconocido que tenemos la nutrición, que es importante.
Wow.
This is great.
It's Nilda. Now, I'm not on the Zoom, so I couldn't see the translation, but it was very, very involved. So what I'm going to do is I'm going to turn this over to you all. I understand that all of our speakers that you all had the pleasure of hearing their voice, Sylvia and Tamiris and Florencia, everybody that was on is now here backstage. So the first thing is just to see if there are any questions. And our tech team, please bring everything on. Please bring everyone on. We need to see if there are any questions. And so how wonderful. Hey, everyone. Nice to meet you. Nice to meet you. So what we're going to do is I'll turn this over. I'll stay on, but I'll turn this over to Nilda and Servio. I have the pleasure of going back and seeing it so I can actually read it in English because I didn't get a chance to do that. But we do want to see if there's any questions first for each of our panelists. And personally, from Cayenne Wellness Center, my name is Dr. Carolyn Rowley, the founder and executive director. I want to thank you, literally each individual. Jimenez, Sylvia, Veronica, and Florencia, thank you. Appreciate it. And I look forward to hearing your guys' story interpreted into English. Let's see if there's any questions so far. I know we did have something from Shari saying that the stories are amazing. And let's see if there are any questions that you all have. Okay, so there's a question for Nilda. So Nilda, if you want to read what the question is in the chat.
Yes. It says, so la pregunta es, en términos culturales, las familias que están envueltas están en sus procesos médicos. That is a question for the panelists, correct?
Okay.
Since I actually need you to interpret into English, what is the question?
Oh, okay. Yes. So it says in cultural terms, if the families that are currently, I guess, being, let me see.
I would say in cultural terms, how involved are families with their medical processes?
Yes.
Thank you, Sergio.
Yes, I kind of figured. So that's for each of you. So why don't we just start with Timeres, who appears on my screen. How involved was your family in the process? In your medical process?
Usted me oye, Tamires. Sergio, si tú le puedes hacer la pregunta. O a uno de ustedes, si puede.
Decime, no entendí la pregunta.
Can I start?
So you want to start, Nilda,
Yes.
with Sylvia?
So ella dice, en términos culturales, las familias que están envueltas están en su proceso médico.
Okay.
Sí, las personas que tenemos nosotros en el grupo, sí, están todas con su atención médica. Aquí, por suerte, dentro de todo en Argentina, tenemos buena atención médica, no en sí para lo que es la drepanocitosis, en el sentido de porque falta conocimiento en el área médica, pero sí tenemos atención en hospitales públicos, las familias tienen obras sociales o prepagas, como se dice acá, y en sí la atención médica en general en Argentina es buena, pero no en el caso, como repito, de la drepanocitosis o anemia falciforme, porque no conocen los médicos esta enfermedad, porque acá es una enfermedad poco frecuente o rara, como se le dice. Es muy baja la incidencia en la población. Entonces los médicos es como, a mí me pasó con mi hijo varias veces cuando iba a una guardia, el médico me decía, mire, es mi único paciente. Y de hecho, en pediatría también fue el único paciente, y cuando lo pasaron a adultos, a los 18 años, también el médico que lo tomó era su único paciente. Entonces, falta conocimiento acá sobre esta enfermedad. No escucho, no sé si están hablando, pero yo no escucho.
No, I was gonna ask Sergio. Sergio, are you good with translating what she just mentioned?
I'm sorry. I see Dr. Rowley.
I don't need it translated, dear, because it's being translated in Zoom.
Okay.
If you can just ask the same question to Florencia, have her answer the same question.
I can ask her, no problem. Florencia. Florencia, ¿usted me oye? Hola, Florencia.
Okay, you want to ask Veronica?
Hi. Hola. Sorry.
Hi, Veronica. Hola, ¿cómo estás?
Fine, estoy bien.
Muy bien, muy bien.
Me gustaría hablar inglés porque me gusta mucho, pero bueno, referente...
Lo que usted prefiere, sí, claro, puede hablar inglés. Bueno, lo que querían preguntar era En términos culturales, la familia, ¿cómo involucrada estaba su familia en los procesos médicos y en el tratamiento de su falsemia?
Bueno, bien como estaba nombrando Silvia, que es muy difícil que los médicos en general, de todas las especialidades, conozcan lo que es, como acá lo llamamos drepanocitosis, bueno, o actualmente es más común, se oye más la anemia falciforme. Pero bueno, yo al tener 40 años tengo como muy vivido esto y siempre fue llamado drepanocitosis. En términos cómo se implica la familia, yo tuve un fuerte apoyo de mis padres, que me ayudó mucho a salir adelante, porque en términos médicos fue muy difícil desde pediátrica para que se conociese lo que me estaba sucediendo. En cuanto me dieron el diagnóstico, hubo muchas formas diferentes de poder encararlo según los criterios médicos, porque acá, repito, sigue siendo desconocida, imagínense, hace tantos años atrás, y siempre fue muy básico, ácido fólico en un comienzo, bueno, mucha visita al médico, muchos turnos seguidos para controlar cómo iba el tema del hematocrito, muchas transfusiones, soy politransfundida, como ya dije en el video, y después en mi adolescencia cesó bastante el tema de la transfusión y el tema de los dolores, hasta los 16. Ahí empecé con las necrosis, que son hasta el día de hoy lo más difícil de llevar, porque no es directamente los reemplazos, ¿no?
Sí, claro.
Sí, directamente. Pero incluso pasar de pediátrica a adulto fue muy difícil que un médico me supiese llevar. Me resultó, viéndolo en retrospectiva, más fácil cuando fui pediátrica. Incluso en la actualidad es muy, muy difícil de que un médico comprenda el dolor que uno siente y cómo se siente en la diaria también, ¿no?
Sí. I'm sorry?
If you want to ask Tameras that question,
oh, yes, absolutely. Bueno, muchas gracias por su respuesta, Verónica, se lo agradezco mucho. Hola, Tamires, ¿cómo estás?
Hola, ¿todo bien?
Hola, muy bien, muy bien. Entonces le queríamos hacer la misma pregunta, ¿cómo involucrado estaba su familia en su proceso médico y en el tratamiento de su anemia falciforme?
A principio, mi familia, bueno, y durante, no sé si me escucha.
Sí, la escuchamos.
Durante la infancia, como dije, yo no recibí un tratamiento. Yo tenía muchas internaciones por diversas infecciones. Luego me daban hierro. Mi familia siempre, bueno, me acompañaba, digamos, con los médicos, pero no entendía qué era lo que pasaba, dado que yo no tenía un diagnóstico. Cuando completé 13 años, un pariente que estaba estudiando medicina había estudiado sobre el tema y aconsejó a mis padres que me llevara al médico y que me pidiera para hacer el electroforesis de hemoglobina. En el caso, mis padres me acompañaron y el médico en la ocasión no quería que yo hiciera el estudio, decía que era imposible, dado que mi papá no sabía que tenía drepanocitosis, o sea, que tenía los rasgos. Mi mamá no era una persona presente, entonces ellos no tenían idea. En el caso, básicamente obligado, el médico pidió el estudio y cuando llegaron los resultados, simplemente dijeron que yo tenía la drepanocitosis, pero no dio una orientación. Ellos siempre estuvieron presentes, me acompañaban, pero no entendían mucho, no había mucha información, dado que yo vivo en el sur de Brasil. Entonces, la población que padece drepanocitosis, la concentración mayor dentro de Brasil, está más al norte. En el sur es un poco más difícil, a pesar de que hay muchos casos, pero los médicos son más como no aceptan mucho, dado que ahí viene o sea, la mayoría de las personas son descendientes de alemanes y eso, Entonces ellos creen que por ser una enfermedad que viene de o sea, más afrodescendentes padecen en Brasil, ellos creen que es casi que imposible.
Sí, claro.
Pero ellos, o sea, mi papá siempre se dedicó mucho a la cuestión de mi alimentación, ¿no? A pesar de no saber, él pensaba que lo mejor sería que comiera cosas con hierro y entonces se dedicaba a eso. Pero siempre estuvo muy presente, siempre me acompañó en los tratamientos, todas las veces en las internaciones, hasta que yo me vine a la Argentina. Mi familia sigue en Brasil y yo estoy acá sola, así que acá en la Argentina me manejo básicamente sola y bueno, tengo apoyo, digamos, de amigos que durante las internaciones me asisten y es eso, básicamente.
Thank
Sí.
you.
Ya,
Thank you.
muchas gracias por su información.
De
Thank
nada.
So I'm going to turn this back. Thank you. Please let them know I'm very appreciative if you can.
La
And
doctora Rowley dice que ella está muy agradecida por todos ustedes en atender y por participar en este evento y por cooperar y darnos a nosotros su experiencia y sus historias.
thank you.
And
La
Dr.
agradecida soy
Rowley,
yo, doctora. Estamos muy agradecidos, muy lindo el evento, la verdad se está aprendiendo un montón y le agradezco también a Nilda, que amorosa, que me invitó a participar. Así que muy agradecidos a ustedes y está muy bueno. Hay gente del grupo nuestro que está escuchando y una doctora que es mamá de uno de los nenes que tiene también la anemia. Y está re contenta y emocionada, dice, de estar escuchando y que está aprendiendo un montón. Así que muchas gracias.
And
gracias, señora Silvia.
So that part you guys had to translate.
Yes.
Go ahead.
She is truly appreciative, and with the information that's being given, she had invited individuals from the group that she started in Argentina, and she has parents. She has also one of the parents that is a physician, and she's extremely grateful for the information that you have shared in your conference today, and very educative. And I know that she did ask a question earlier that we can, if you don't mind me asking for her. She had asked if at what age would it be possible for a patient to proceed to request a bone marrow transplant?
Okay, so that's a good question. And there are, for BMT, they are actually starting with children, and they seem to fare well. And they do it for if you have a match. And they've also worked on doing bone marrow transplant, which is, for gene therapy when you don't have to have a match. But with the match, and I won't say too much since you have to interpret. So children are eligible, and I think you have to find the right facility, and those facilities will actually share with you the age that they actually begin. And so, but they are starting with children. But each agency, and I'm saying medical center, what have you, they may start at a different age, but it is in pediatric that a person can participate. And it is a process, and it does take some time, and there's a lot of, informed consent, what have you, but you can start in pediatrics. I'll stop talking.
Okay.
And I'll
No, it's fine. Thank you. Doña Silvia, le pregunté a la señora sobre su pregunta que usted tenía de los trasplantes y ella dice que puede comenzar de una edad de niñez, pero tiene que chequear con las agencias que hay. Sobre el trasplante de gen, ahora mismo ella reconoce que es para más los adultos, adolescentes, pero sobre la médula y el trasplante de médula, hay que chequear con las agencias y ellos dejan saber el proceso y a la edad que pueda comenzar ese individuo.
Thank you. I'm going to have Hilda and Servio, the moderators, and I'm going to have you guys wrap up because we're going to move on to our next item on the agenda. Thank you so much, everyone. Gracias.
Gracias. Sí, gracias por compartir en el panel. Pienso que esta sesión va a ser muy informativa a las personas que van a ver este segmento, especialmente dando el historial en su país, que no lo son los países que estamos ahora aquí en los Estados Unidos, pero pueden ver cómo la enfermedad afecta en esta manera global.
Sylvia, did you want to say something?
No, not at this time. I had everything that I already said.
Thank you. So everyone, oh my goodness, I look forward to hearing the stories, seeing it translated into English. I can't wait. And so, but I've hoped that you all that are able to have heard it in Spanish, have been able to see it translated into English, have enjoyed the stories. So thank you all. Thank you for sharing. Thank you for sharing your story that comes from your heart. So that again, as they were all talking, I just said, you know what? This is my cell sister. You know, as an adult person with sickle cell disease, I'm sorry, but this is my cell sister. You guys are my cell sisters and my cell brothers because we are linked. And so, and mighty, we can do many things. So I'm appreciative of the stories. And so at this time, we're going to officially end this session on the Global Patient Panel and give us a moment to give us we'll start at 12:40, so give us about 4 minutes, and we're going to bring up next the one and only Dominique. It depends on the game, so it might be Dominique Trebek. It might be Dominique Harvey, depending upon the engagement that she's going to participate in. Give us about 3 minutes, and we're going to start our community engagement and have some fun. Thank you so much.
Hello, everyone. Can everyone hear me? How is everyone doing? Hola, ¿cómo está? I hope everyone is having an amazing day. This has been an absolutely amazing event so far, and I know the rest is going to be amazing as well. So we are going to be playing. I am going to be Dominique Goodson. No Harvey or no Trebek this time, just regular old Dominique Goodson as we do community engagement. And we are going to be playing categories, everyone. So for those who don't know what categories is, category is categories is a game that has categories. You choose the categories. You get a list of categories. There's going to be a name, a letter. I apologize. There's going to be a letter. F, D, S, P. You get a letter and you're going to get a certain amount of time. We are giving you guys 120 seconds, which is 2 minutes, to figure out 10 categories. And there's going to be different categories. So the letter could be something like F, and it would be name an animal as one of the categories. You have to name an animal that starts with F. And then another category would be name an instrument. You have to name a category with that instrument that starts with that letter. All right. Is everyone able to see my screen? I believe so, right? We're good. No? How about now? All right. Okay, so we are going to get started. We have 120 seconds. The letter is going to be S. So keep in mind, everyone, whatever the category is, it must start with an S. I have my handy dandy trusty people that are going to, my sidekick, Sharonda. She's going to let me know what everyone put in. Now, a few rules. When you're putting in the categories, there are 10 categories. If you can, put all the answers to the category and then hit enter. Do not do it one at a time. So whatever the categories are, write all of your answers out, separate them by commas, and then hit enter. And that's how you are entered into this. And of course, like with all of our community engagement, we are giving out amazing prizes at the end. So we are going to get started. So remember, put it inside the chat. I should also tell you guys that as well. Make sure you put your answers inside the chat. Get all the answers you can within that 120 seconds and then hit enter. Okay? So are you guys ready to start? Let's get started. All right. The letter is going to be S. All right. And the categories are movie titles, things at a circus, things that are Black, words ending in N, kinds of dances, flowers, reasons to quit your job. Oh, that's a good one. Celebrities, things in a souvenir shop, electronic gadgets. All right, remember all the categories have to be with an S. And so it's movie titles, things at a circus, things that are Black, words ending in N, kinds of dances, flowers, reasons to quit your job, celebrities, things in a souvenir shop, electronic gadgets. And everyone, please remember, put your answers inside of the chat. You will put your answers inside the chat, write all of the answers out, separate them by commas, and then put them inside of the chat. Once again, the letter is S. And the categories are movie titles, things at a circus, things that are Black, words ending in N, kinds of dances, reasons to quit your job, celebrities, things in a souvenir shop, electronic gadgets. All right, and time is up. Okay, so let's see. What do we have inside the chat? Please place your answers inside the chat. All right, Renee. Okay, I see Dr. Rowley. We'll give it one more minute. And let's see. Okay, so we have some people that said saw, seal, see, salsa, sin, sunflower. Sunflowers are one of my favorite flowers, actually. I love that answer. Sally Richardson, shore glass. Oh, shot glass. Gotcha. Shot glass. And we have Superman, skin, sun, sunflower, strike, Selena Gomez, Sleepless in Seattle. That is such a good movie. It is. All right, so it looks like Renee has the most answers in that category. So, Miss Renee, you have a point. So the way it's going to go is whoever has the most points at the end of this is the winner, by the way. All right, so let's go to another one. Here we go. The next category. The letter is I. All right. And the categories are things that make you smile, types of drinks, spices / herbs, things that have spots, items in a kitchen, musical instruments, dairy products, diet foods, things found at a bar, appliances. Once again, things that make you smile, types of drinks, spices / herbs, things that have spots, items in a kitchen, musical instruments, dairy products, diet foods, things found at a bar, appliances. And the letter is I. And the letter is I. Once again, please remember to put all of the categories, all of your answers in one, and then hit enter. Separate them by commas or a semicolon, whichever one you feel best about, and then hit enter. And you can put your answers inside the chat. Once again, the letter is I. The category is things that make you smile, types of drinks, spices / herbs, things that have spots, items in a kitchen, musical instruments, dairy products, diet foods, things found at a bar, appliances. 2 seconds, everyone. Submit your answers. All right, and time's it up. So, please submit your answers so that we can see, and then let's see what answers we got for the letter I. All right, let's see what we got for the letter I. All right, we have iodine. Oh, now was that for spices or herbs? And is iodine a spice or herb? It's a good question. All right, so Servio, we have infants, ice lattes, incense, ice cream scoop, and ice cream. Oh, things that make you smile, infants. That is so cute. See, I was thinking things that make me smile was ice cream. I know a lot of us was thinking the same thing. You know, you can't not smile when you say ice cream. Like, hey, do you want some ice cream? You're like, yeah, I want ice cream. Let's see, what else do we have inside the chat? Renee said, icy, igloo, ice, ice cream, Italian, and ignorance. All right. Who else? All right. Yes, ice cream did fit many descriptions. All right, and so it looks like Servio took that round. All right, so Servio has 1 point and Renee has 1 point. Okay, let's go to the next round. And our letter is T. Oh, this is going to be a good one. All right, the letter is T and the categories are things that have wills, reasons to take out a loan, farm animals, personality traits. Oh, that's going to be a good one. Names used in songs, bad habits, furniture, famous duos or trios. Oh, Dr. Riley, I know you got this one. Toys, reptiles or amphibians. And once again, the letter is T. And the categories are things that have wills, reasons to take out a loan. Oh, that's a good one. Farm animals, personality traits, names used in songs, bad habits, furniture, famous duos and trios, toys, reptiles/amphibians. Remember, everything has to start with the letter T. And put inside the chat, write all of your answers, separate them by commas, and then put them inside of the chat. We have 49 seconds to go. And once again, the categories are things that have wills, reasons to take out a loan, farm animals, personality traits, names used in songs, bad habits, furniture, famous duos or trios, toys, reptiles/amphibians. I'm gonna tell you guys why I laughed when we get to naming some of the answers, because I just thought of a really good bad habit for the letter T. 2 seconds, everyone. All right, everyone. Thank you guys for putting it in. We're going to give it a few more seconds. Let you guys put your answers inside the chat. Hit that enter button. You hit that enter button. All right, let's see. Okay, so I'm gonna tell you guys what I put for what I thought about for the letter T for bad habit. I thought toe biting. You know, some people do that. They like bite their toenails. It's weird. I think that's a bad habit. I don't know. What do you guys think? All right, let's see. Servio, we got tuition. That is a really good reason to take out a loan. Yeah, a lot of us did that. I did that. That's good. You should get like 4 points for that one alone, but that's a good one. So tuition, Taylor, toothpicking, turtle. All right. Dr. Riley, I don't know if the Supremes count. I don't know if we could do that one. All right. We got one from Nilda. Trucks, trip, turkey, tender, Tim, teeth grinding. Oh, yeah. Table, the Beatles, top, T-Rex. Now, see, I'm a little iffy if the band or the trio starts with the letter T. Like, it should start with, not the, it shouldn't start with the, if you guys know what I mean. I'm a little iffy on that. But I might have to give you guys that one. Since everyone, oh, wait, hold on. Nope. I can't give it to you because you know what? Renee just killed it. She said temptations. That's what I was thinking. I was waiting for somebody to come up with the temptations. Turtle, table, thumb sucking, transportation, tree frog. And it looks like Renee actually is taking this one as well. And yep, Renee has taken this one as well. So we have time enough for one more round. All right, here we go. And the letter is K. This is going to be a hard one, you guys. You got to put your thinking cap on this for this one. All right, here we go. Internet lingo. And you know what? That could even be an acronym. You know how they be playing LOLs and stuff? It could even be that. Animals, software, book titles. Ooh, I got a bunch. Computer game. Oh, computer programs. Things in a medicine cabinet. Diseases. World leaders / politicians. Gifts / presents. Items in a refrigerator. And the letter is K. You guys have 84 seconds. And once again, the categories are internet lingo, animals, software, book titles, computer programs, things in a medicine cabinet, diseases, world leaders / politicians, gifts / presents, items in a refrigerator. Don't forget, you could write the entire, put all the answers inside and then hit enter, separated by commas. Separate by commas. Okay? And we have 35 seconds. The letter is K. And the categories is internet lingo, animals, software, book titles, computer programs, things in a medicine cabinet, diseases, world leaders, politicians, gifts / presents, items in a refrigerator. We have 10 more seconds. Letter is K, everyone. Let's see what answers we get. This is going to be good. This one was a hard one. I don't know if I could come up with something for K. All right, let's see. Everyone hit that enter button. Let's see what answers we have come up with. Let's see. All right. All right, let's see. Okay, so we got K, short for okay, kangaroo, kite runner, Kanaka. All right, nice, Nilda. All right, Servio, K, short for okay, kangaroo, keynote. Is that an iPhone thing? It's an iPhone thing. I'm not an iPhone person. Kaplan study. Oh, that's a good one. That's actually a really good program, computer program, actually. Because I can't say that. It's an antivirus. Kaskitsky, kits, karate class. All right. And Dr. Riley, we got K-Bite, kangaroo, Kennedy's calamine lotion. Calamine lotion? I thought calamine lotion started with a C. Dr. Riley, are you reaching or am I just wrong? Kennedy, knitted Cam ketchup. Okay, so calamine lotion does start with a C. Dr. Riley, that was a little reach. I can't give you that point. I'm sorry. Okay, so let's see. Do we have anyone else with it? If not, it is looking like, oh, wait, we got one more person. Knuckle, kangaroo, kinase, Kennedy, knots, kidney stones, kidney disease, kindergarten blues, ketchup. All right. I was waiting for somebody to put ketchup. That was the one thing I was like, that's the one thing I think everybody got inside their own refrigerator, some ketchup, right? All right, and it looks like Renee has got this point as well. Renee is killing the game. And you know what? I believe that is all the time we have, if I am not mistaken. And so let's check it out. Let's tally up the score and let's see who's won. So this has been actually an amazing round. You guys did absolutely amazing. You guys came up with more answers than I thought I would possibly with Kay, but there was a lot out of all of those 10 categories. I just had catch up. I didn't know what else, anything else. I just had catch up, but you guys did absolutely amazing. And so the winner, we are all winners, first of all. You're all winners for being here and just winners in life, period. But the winner of the community engagement is Servio. I'm sorry. Servio said he forgot ketchup even existed. It's okay. I don't eat as much ketchup neither, but I do still have ketchup bottle. It may be a couple of years old, but it's still in my refrigerator. So let's announce the winner of the community engagement. And the winner is, drum roll, everyone, Renee. Woo! Congratulations, Renee. You are the winner of a $50 gift card. You are going to message Mary with your information so that she can get out your gift card. Thank you all so much for participating and being part of community engagement. This was so much fun. I hope you guys had fun. I had fun. Hi, Dr. Raleigh.
Hey.
Dr. Raleigh.
I know I'm reaching.
I was trying to give you some of them, but I was like, nah.
No.
I don't think calamine lotion start with a K.
No, it starts with the C. And
Yeah.
no, I was just playing because it's just fun.
Yeah.
But everyone, again, this is we like to break it up by just having some fun. And Dominique is great. She does our community engagement during our 3-day seminar. She does the community engagement for the consortium during World Sickle Cell Day and the other Warriors Convention and all that they're doing as well. So Dominique, thank you for taking time out of your Saturday to participate and do this with us. And of course, you're the hostess of the mostest, so I appreciate it. And Renee, you rocked. But it looks like Nilda and Servio, they were getting close.
They were.
So
Servio was right behind. If Servio would have got that catch up, Servio, it would have been a tie. We would have been going into death round.
You're funny. So Dominique, thank you.
Thank you, Dr. Raleigh, for having me. This is always fun. I love doing this. And thank you so much to everyone that's here. Thank you guys for showing up. And I hope you guys have fun.
Well, Servio said that he won last time. So
he did win last time.
So wonderful. So everyone, what we're going to do now is we're going to take an official 10-minute break. Our next up is information. You're going to love it. Dr. Austin and Pasante they're excellent. And so we have Sickle Cell Trait Unfolded beginning at 1:15. That is Pacific time, which is about 10 minutes from now. So enjoy the music and I'll be back. And we're going to keep it going. We hope you're, no matter where you're, actually put into the chat where you guys are viewing this and listening. And so I like to actually know, I know that we've had people on now from Brazil and Colombia, Argentina. Be nice to know where you're listening. But right now we're going to give you that full 10-minute break before we actually get started. So thank you for being with us and I'll be right back. All right, welcome back, and we hope that you enjoyed your break and were able to get some stretching in, some mindful breathing in, and some hydration. Soon, we're going to be joined by someone who's a powerhouse in sickle cell trait education, Dr. Tamia Austin, along with Dr. Pasante. However, I do want to just welcome you all. For those of you who might just be joining us, my name is Dr. Carolyn Rowley, founder and executive director at Cayenne Wellness Center, and this is our Voice, the second annual Hispanic Heritage Sickle Cell Disease Educational Seminar. And so we're pleased to be doing this. Last year we did this in conjunction with Dr. Andrew Campbell and Marlene Peters, Dr. Andrew Campbell of the Children's National Medical Center. And so we were pleased to have collaborated and partnered to do the first annual, our story. And this year it is Our Voice. It's been wonderful so far. The data was really interesting. And so we thank Jacqueline for having presented that. And of course, Dr. Keith Carollo for presenting the basic, which is always our foundation. We had a wonderful time with our global panel. Wow. Wow, people coming in from Argentina and Brazil and Colombia. So very much appreciate that. And can't forget our moderators, Nilda and Servio. You guys are doing wonderful. But I want to just make sure that everyone knows that Mary Alcacer, our program manager, is so awesome. So awesome. And so we depend upon her to pull all of this together and to help us make it happen. So thank you, Mary, who's always behind the scenes. She did join us for the intro, and she'll be coming back later as we talk about our open discussion. But up next, I'd like to bring on Dr. Austin and Pasante. Hey, there's my lady in orange. And so what I'm going to do, I'm going to turn this over. Thank you. Dr. Austin was with us last year as well. And so again, she's our go-to person who has the information, the latest information on trait. And it's important that you all know about this information. Take it away. Thank you. And I believe that there also is an intro. So allow the intro to start. Thank you.
Tamia Austin is a behavioral scientist, health educator and researcher and the executive director of the As One Foundation, an organization established with a mission to help empower youth to unlock and unleash their full potential through athletics, education and spiritual enrichment. Dr. Austin's nearly 20 years of dedicated work in the not-for-profit sector fuels her pursuit of health literacy for disadvantaged populations, especially young athletes of color. Her work focus and research interest areas include genetics, sickle cell anemia, sickle cell trait, and much more. Maisha Pesante MD is a board-certified family medicine physician. For over 20 years, she has practiced the healing arts, becoming a certified massage therapist and herbalist, prior to earning her doctorate of medicine at the University of Cincinnati. Dr. Maisha was a pioneer in the telemedicine arena, joining a prominent telemedicine company in 2016 and rolling out the telemedicine program at her clinic shortly thereafter. Her philosophy centers on creating patient compliance across a broad diversity of ethnicities and classes. Welcome to Educate, Sickle Cell Trait Unfolded, part of the second annual Hispanic Heritage Sickle Cell Disease Educational Seminar.
I'm assuming that both of you guys will do this together. And so you may want to bring on Dr. Basante as well. And I'm going to get off because this is the trait hour. So go right ahead.
Hi, everybody. I am, as the intro said, Dr. Tamia Austin, and I am presenting Sickle Cell Trait Unfolded, our voice here at the second annual Hispanic Heritage Sickle Cell Disease Symposium with Cayenne Wellness. Thank you so much for the opportunity. I have no financial disclosures. I hope that looks good to me. It looks a little wonky to you, to me actually, but I am the executive director of the As One Foundation, where our mission is to empower families globally delivering life-saving sickle cell education. Founded since 2007 by the gentleman on the screen, who actually took a horrible, tragic situation and turned it into a triumph. That is the As One Foundation. Our why is his identical twin brother, Devon Darling, who died of sickle cell trait exertion back in 2001, February 26, 2001 to be exact, while doing indoor mat drills, prolonged conditioning workout at Florida State University back in 2001. But Devon's spirit lives on through the work that we do here with the As One Foundation, and of course, each person that we're able to reach with this information. Why? Why does sickle cell trait matter? We're here to say that sickle cell trait, just as sickle cell disease, is a condition that affects people of various ethnicities, people of African, Asian, Indian, Latin, Italian, Irish, Mediterranean, Greek, and Turkish descent. It is the most common genetic disorder, and that's why sickle cell trait matters to the over 300 million people worldwide, 4 million people in the United States, and the majority of them that don't know. And we're going to tell you more about what we think about that. The other reasons why sickle cell trait matters is because the information that we have when we share family planning advice is vastly important, but somehow just doesn't register or is just not driven home enough. And that is the fact that two people living with sickle cell trait that procreate together and have offspring, their offspring, every time you roll the dice with each pregnancy, there's a 25% chance of birthing a child with sickle cell disease. And two sickle cell trait patients have a 50% chance of offspring being born with sickle cell trait with every pregnancy, each time you roll the dice. Another reason why it matters is that statistically, all offspring of sickle cell disease warriors, all natural offspring of sickle cell disease warriors, will be born with sickle cell trait at the least, every child. And the percentage of the way that we can know as we get into some of the complications that are associated with sickle cell trait, it is correlated to the amount of the abnormal sickle hemoglobin that is in the blood of the trait or the carrier. And the hemoglobin electrophoresis test is the test that is sensitive enough to not only tell you the genotype, but also the percentage. Any percentage of the abnormal hemoglobin above 30% is predictive of symptoms happening. So everyone is advised to get the electrophoresis test to know for sure. As we said, it is a genetics condition, not a skin color condition. And we advise everyone to find out their status and not play the principle of exclusion just because you are not Black. There are some myths associated with sickle cell trait. It's, the benign, the asymptomatic classification only affecting African Americans and nothing to worry about. We're gonna, clear that up by defining, number one, what benign means. Mild type, does not threaten health or life, not cancerous. That's pretty important. We'll talk about that. Asymptomatic, not causing, marked by, or presenting with signs or symptoms of infection, illness, or disease. This is how benign and asymptomatic are defined, but these are complications of sickle cell trait, which is classified as benign, often in the research: chronic fatigue, splenic infarction, invasive pneumococcal disease. And I'm so excited to be presenting here today with Dr. Pesante, because she will drive this home as far as the conditions and correlations go. Thromboembolism, blood clots, retinopathy, kidney injury, even kidney cancer, renal medullary carcinoma, also known as RMC, acute chest syndrome, avascular necrosis, exertional sickling, which we'll talk about a little more in detail, sudden death, and even COVID-19. I will not go deep into these, but I'll just give you brief descriptions. Chronic fatigue is by leaps and bounds the most common symptom of sickle cell trait. I've had a 48-year-old patient tell me that her mother had to apologize to her when she was advised to get the electrophoresis test and measure the percentage of the abnormal hemoglobin in her blood. And they were able to really understand that her sickle cells were the reason why she was always so tired and always, classified as lazy. And her mother called her a hypochondriac, but she came to apologize to her because there is a disease state that is active in her blood that no one had explained what that was, and it's chronic fatigue. Splenic infarction, this is something that trait warriors talk to us about regularly when they fly, but it can happen when there's any drop or elevation in your oxygen. Invasive pneumococcal disease, also known as pneumonia. Blood clots, definitely dangerous for any of us, but certainly those of us living with sickle cell trait. Retinopathy for sickle cell trait and our disease warriors. Annual eye exams are recommended as the treatment of this complication. The kidney connection, renal medullary carcinoma is the one that rises to the top because it is in fact a kidney cancer that is often diagnosed very late stage, 3 or 4, and fatal. There is good news though that there are, to my knowledge, 1 current clinical trial and 2 on the way. But we have a lot of work to be done in this area when it comes to getting, number 1, getting participation in the clinical trials, but also in the event that there is a diagnosis, getting that diagnosis in stage 1 or 2 so that the tumor can be removed and the cancer can be, reversed or overcome. And my position is all trait warriors need to have their kidneys examined on an annual basis, because by the time, in the case of kidney cancer, there is a mass, by the time there is blood in the urine, that's often too late. And then there's other kidney issues, hypoxia, hematuria, those things I'm sure Dr. Pesante will explain in detail, but these are listed in the research as complications associated with sickle cell trait. Acute chest syndrome, yes, acute chest syndrome. COVID-19 are mentioned together in several articles. Avascular necrosis, again, when you are a 40-year-old and you're still having growing pains and you have sickle cell trait, that's not growing pains. I am not a clinician, so I advise you to seek out Dr. Pesante or a sickle cell trait educated physician that can help you through, but not 40 years old. That's not growing pains. And exertional sickling. This is happening usually in the very beginning of a conditioning workout. The scenario commonly is after like a holiday break or the summer, and young athletes are coming back after a prolonged period of being off. And now it is the situation is to show where you are physically. What muscle did you lose? What muscle tone did you lose? What muscle memory did you lose? So go run for 45 minutes straight. Go conduct suicides. Run up this hill with no break, with no hydration, with no recovery. Because if one man fails, the whole team fails, and we all got to go back and do it again. And unfortunately, there have been multiple deaths that have occurred in this scenario where the athlete, it was the first day of conditioning workouts early, within the first hour of the conditioning workout, that there have been hospitalizations and unfortunately even death. This is the exact scenario that took Devon Darling from us back in 2001, and subsequent athletes since that time. Their parents did take legal action against the universities, and one of those parents actually also wanted to make sure that her son's memory would also be associated with change, and that is what resulted in the NCAA mandating not just Division I, but Divisions 2 and 3 also to test for sickle cell trait as a way to prevent these deaths and obviously prevent the universities from being sued. And even COVID-19 is a complication that all of us have been, inundated with the pandemic over these few years, but it has presented some respiratory issues, increased triggers of complications of oxygen demand, blood clotting, and even which is thromboembolism in sickle cell trait patients. I've listed 3 articles here, but there are several that associate sickle cell trait with COVID-19 complications or even long COVID. But as we said, today we're talking about the exertional sickling because it is the As One Foundation origin story. Our founder, Devon Darling, and his identical twin brother, they were born in Nassau, Bahamas. There was no newborn screening to take place there, so they did not find out that they even had the sickle cell trait until they were about to play football. It was literally days before they were to take the field at Florida State University. They did not receive this education. They did not know that sickle cell trait had complications associated with it, and one of them is exertion, and that they needed to practice proper hydration. And we'll talk about what proper hydration is. But what Devon experienced that day after a brief high-intensity workout, sometimes described as suicides or gassers, increased pain in the larger muscles. Devard describes seeing his brother in passing, they would like kind of dap each other on the hand as they were passing, going to the next workout. And he knew his brother was gassed. And he was a defensive player, so he was being tested to see how far he could go because they thought he was a defensive leader, so they needed to know the lengths that their leader would go. And they kept sending him over and over and over and over through the routines of the conditioning workouts, the mat drills as they call them. And he was experiencing cramping, struggling. He had collapsed, and he was coached up he was told, your body is amazing, Devon. You'll pass out before you die, but you don't worry about that because we have trainers here. We got people that are going to take care of you. And Devon passed out multiple times. He was being carried through the drills by his teammates who didn't want to go back and have to do all those drills again. And I believe they were on 61 of 63 drills. And he passed out. He was rolled out of that practice on a gurney. And one of his coaches even said, that's our first F today, because they were graded. And you don't make it through the mat drills, that's an F grade. And Devard lost his identical twin brother that day to death. And he is the inspiration for everything that we do here with the As One Foundation, because we certainly believe not only was Devon's death preventable, sickle cell trait deaths before and since. I will say that the NCAA mandate has been helpful, but we still have much more improvement needed. And education. This opportunity that we have here today is a part of that, reaching across ethnicities to let everyone know universal education. It is October. It is Sickle Cell Awareness Month amongst a whole lot of other, Breast Cancer Awareness Month, amongst a whole lot of other things to consider this month. But sickle cell trait warrants attention all year long. in every audience, in every ethnicity. And this education is helpful. It is key. So to reach people, especially when we don't have 45 minutes to sit with them, we deal with what we've discovered to be risk factors associated. And that is especially those that were associated with Devon's death. They are listed on his death certificate. Sickle cell trait, ironically, is listed as a secondary cause because at that time, sickle cell trait does not have a cause of death code. I am not aware that there is even one that exists today. So his death certificate says exhaustion and dehydration complicated by sickle cell trait. And those are basically the risk factors. Dehydration, elevation, which has to do with that splenic infarction that we were talking about, and exertion. So we don't introduce a problem without introducing a solution. So, and why this matters again is because sickle cell trait is in the research classified as the #1 killer of collegiate athletes, and those are predominantly African Americans. We know that sickle cell disease is a disparity state disease, and sickle cell trait is this disparity within the disparity, and that's just the facts. That's how we approach it. But we're doing something about it because these young men and women. Shernice Clark is one female collegiate athlete that we are aware of, but there have been others that have lost their lives very prematurely to this exertional sickling death. And unfortunately, this is a death that has not just been relegated to high school, collegiate athletes. These are high school athletes, young people, very young people, even a female basketball player. Pop Warner football player, 11 years old, that has been lost to sickle cell trait exertional deaths. I don't see the top of that slide, but somehow it's just skipped around a little bit, but I'm gonna just skip ahead because I wanna get to the, well, I'll go ahead and talk about where we have the conversations about sickle cell trait right now. And that is at diagnosis. That at diagnosis, if you're born in the United States after 1995, then you may know your sickle cell trait status. Again, as Devon and Devard, who were not born in the United States, but did go out to play NCAA sports, that's the next time that there was a conversation about sickle cell trait. And then unfortunately for most, it's either when two sickle cell trait parents learn that their child is born with sickle cell disease. And, some may consider that too late, some may not. But, a lot of people would consider, I wish I would have known more. And unfortunately, other times is at death when it's too late. But we think that there are other opportunities for conversations about sickle cell trait, certainly similar to what we're doing here. But we say family planning, genetic counseling, certainly at diagnosis, which we have, more sensitive testing, in-school testing and education, and I'm talking about in middle and high school, maybe even elementary school. Transition is big for sickle cell disease, but we need sickle cell trait to be included in that. Dating and sex education, NCAA sports, again, that's one. Universal education and awareness, like Sickle Cell Awareness Month, but to the 12th degree, like Breast Cancer Awareness Month, but to the 12th degree, as well as in the recruitment of sickle cell allies. Those allies are people that are unaffected by the abnormal hemoglobin in their blood, but they care enough to care just because they lend their voice, in collegiate terms, their name, image, and likeness to this cause, such as I have. I am a sickle cell ally. I was not born with abnormal hemoglobin in my blood, but my blood boils and burns for sickle cell trait literacy and for the increase of quality of life for our population. And here we go. When we talk about the risk factors, this is just an image of where we are hydrating our plants, hydrating our cars, giving our pets water. But in some cases, when there's a group of kids, and I took this picture working out, there was no water fountain, no water bottles, no water cooler. And I'm just here to tell you that proper hydration is drinking half your body weight in ounces of water a day. When in person, this is the time that I ask, okay, if you are 200 pounds and you didn't drink 100 ounces of water yesterday, I guarantee you are dehydrated today. So how many people had half their body weight in ounces of water yesterday? Or rather, how many people are dehydrated because they didn't? Most of the hands go up. And these are the protective factors that prevent those risk factors that we talked about, going from rest to intensity gradually. You go into the gym, you warm up. You get on that, elliptical, you go slow and slowly increase. You're on the field, you warm up. You don't just go and take off 45 miles an hour out the gate. You practice hydration. Good hydration is hydration before, during, and after physical activity, but it is also hydrating every day, half your body weight in ounces of water per day. And then you have to take recovery breaks. Those recovery breaks that were disallowed for Devon and so many others. Those protective factors, that was a mouthful, but here's the easiest way to say it. And I guarantee you can repeat this with your little one. Warm up, drink up, rest up. That's the message for all of us, but certainly for our warriors and trait warriors. Warm up, drink up, rest up. If Devon had that message, if his coaches who had kicked water out of that practice had that message, maybe he don't even need the As One Foundation today. Warm up, drink up, rest up. Gradually increase from rest to intensity, gradually. Proper hydration, hydrate before, during, and after, and half your body weight in ounces of water per day. And take recovery breaks. Take a knee, hands on your hips, hands above your head to increase oxygen in your lungs. Take breaks in your physical activity, and those are protection for our sickle cell trait warriors. We have a number of barriers to sickle cell trait literacy, but we don't have any of that to worry about today because we are getting it. But I just need to let you know that our doctors that are undereducated about sickle cell trait or may not treat our patients well, they are undereducated. They get the equivalent of 5 minutes in a whole medical school curriculum. And then, of course, there's things like stigma and guilt and the rare designation. And oh my gosh, I could spend another hour or two talking about rare, which in a lot of cases is dismissed as insignificant. Rare, Devon Darling was not insignificant. Chris Johnson, who died of renal medullary carcinoma, also considered a rare condition, was not insignificant. But we have, more opportunities, more increased testing in schools. We need surveillance. We need great data. I understand you just had a great data presentation. We need research. And of course, research, in order to do research, you got to have funding. And the possibility of introducing therapies for sickle cell trait complications, certainly on the horizon, and opportunities to, again, assist in the quality of life improvement of our warriors, our trait warriors. My final message to you is that anybody can be an ally because all of us have a genotype. Even if you have no sickle cell, you are classified as AA. You're an AA warrior, as we like to call it. So find out your genotype, but get to work. You can get to work without knowing because we would like you to join this fight as a sickle cell trait ally. We do have a parent's guide that you can download and take to your child's coach or trainer or band teacher or sorority fraternity advisor to let them understand what sickle cell trait is and what it means to a person living with sickle cell trait. And these are the ways that you can keep in touch with myself and the As One Foundation. And right now I'm super honored to pass the mic to Dr. Pasante. I see you. Hey, beautiful. I guess, Mr. Courtesy, will you bring Dr. Maisha on, or what do? I need to do something? There she is. Hey. You're muted.
Good afternoon, everyone. Can you hear me okay? Hola, buenos días, buenas tardes. No sé dónde está toda la gente. Oí más temprano que había gente de Argentina y no sé a dónde más oí, pero yo soy la doctora Pesante, la doctora Maisha me llaman, toda la gente. Y es que estoy aquí para presentarle sobre el tema, como se llama Sickle Cell Trait. And I am the author of an online course called Sickle Cell Trait Unfolded. The video should be up soon. Es que yo escribí un curso sobre Sickle Cell Trait o celos falciformes. No need to translate, choose one or the other. Okay, well, that's hard. I'm Puerto Rican, so I tend to speak Spanglish. Is there a translator if I speak in English, or is everyone that's on in Spanish? Ah, okay, I'll just do English then. It won't be confusing you. Hopefully I won't confuse myself because I tend to go back and forth. I'm the author of a more than 5-part course called Sickle Cell Trait Unfolded. I work with, let me go back to my original slide about who I am. I think you guys heard just a little bit about me, but you didn't hear my sickle cell credentials earlier. So the class I'm going to teach today mostly is called Disease or Disorder. And I am Maisha Pesante, MD. I'm the medical director at What's the Count on Sickle Cell Trait. And I am also the author of Sickle Cell Trait Unfolded on our website, Inscription. Inscription is the medical education company where we are trying to re-educate physicians, all kinds of medical personnel, and the community about sickle cell trait, and other topics as well will be there relevant to the community. This first lecture is disease or disorder. There are a couple points that I think Dr. Tamia kind of already covered. I am a board certified family medicine physician. I'm actively in practice. Recently being known as the trait doctor because I do take care of patients with sickle cell trait. The first thing we want to talk about today is whether or not it's a disease and how we know whether or not sickle cell trait is a disease and clarifying it along the spectrum of sickle cell hemoglobinopathies. We're going to talk a little bit about the spectrum very quickly. We're going to compare trait and disease, talk a little bit about the pathophysiology, also what crisis looks like. Dr. Tamia already did the Devon and Devard story, so I probably won't talk about that one as much. I will highlight one of my Latino patients that is suffering from sickle cell trait. So first of all, many diseases don't shorten your life, but they do impact the quality of your life. And so we have a lot of non-fatal diseases. And here's some: dermatitis, losing your teeth, being anxious. These are diseases, but they don't necessarily shorten your life, or over the population of people, they don't shorten your life. So then what are the sickle cell hemoglobinopathies? The sickle cell hemoglobinopathies are all of the diseases that can affect your red blood cells and have been considered some form of sickle cell, where your cells have the potential to sickle. Or they also can include the alpha and beta thalassemias, which also show a change in the shape of your red blood cells, and the amount of red blood cells that can be available can be a part of that. So very quickly, and this is more so for my medical people, going over the life cycle. This slide is just kind of going over the life cycle of the red blood cell. But what we want to understand from this is that your bone marrow is where your blood starts, and that's why some of the latest treatments have to do with stem cell transplants. You have the pluripotent stem cells that then differentiate or become more specific to become erythroblast, and then reticulocytes, and then mature red blood cells. So if any of you have been involved with a doctor telling you that the sickle cell trait is in your head, one of the things they're going to look at is your reticulocyte count. And the reason they look at that is because when your body is anemic, you're going to have, and anemia is when you don't have enough red blood cells, you're going to have an increased reticulocyte count. And so that may or may not be the case with trait, but that's why they're saying that to you. So once your red blood cells mature, let's see, I got stuck, there we go. Then you're going to see your body will then take 120 days, usually is the normal life cycle. They stay alive for your red blood cells. Then they mature and they die. And when they die, they get broken back down into their constituent parts. And those breaking down part of the cycle happens in your liver, your spleen, or in your bone marrow. And then in your liver or your spleen and in the system. And then the system then also sends that back to your bone marrow as well as your liver and your spleen to help make new red blood cells. And so each red blood cell is made up of 2 alpha chains, 2 beta chains, and what's called a heme ring. The little round circle in the middle of the squiggly lines there is your heme ring, and the center of it is where the iron is, and the iron is what holds your oxygen. And so that's why all those things will be factors when a doctor is trying to evaluate whether or not you really have a problem. And when they don't see problems with that specifically that's measurable in labs, they'll say you're not having a problem. So the spectrum of sickle cell hemoglobinopathy includes something that has a genetic defect and then has what's called a phenotypic expression, meaning we can see physical evidence of it in your life, or in your blood cells, or in your lab, or in your body, or in your symptoms. So what are the characteristics that we look for? When we talk about the sickle cell hemoglobinopathies, we look for changes in your red blood cells, where they can be stiffer, stickier, or shaped in an abnormal way. And so this slide is just kind of, if you understand if you've ever looked at a slide, you would be able to see here that these red blood cells are not all normal. Some of them are normal, some of them are shaped incorrectly, some of them are too pale. Also, when you have that happen, those red blood cells then cannot carry oxygen like they should. I need to go back a slide. And so they're also going to not be as soluble. So they're going to stick together when they shouldn't. And that means they can't carry oxygen as well. And they also, when they're stuck together like that, or they're shaped incorrectly, they can't get the oxygen where it needs to go. And what does that cause? That causes anemia, pain crisis, microinfarction, macroinfarction, bone infarction, organ failure, cancer, death, blood clots, a long list of problems. Exertional heat illness, which makes the news because it affects athletes. And so then what is sickle cell disease? And why do they tell you that nothing's wrong with you? In sickle cell disease, they look for the normal DNA, okay, which is GAG paired with CTC, will have a change. Where there was a T, there will now be an A on the CAC side. And what does that mean? That means that your proteins are going to be abnormal. You're going to have a glutamine to valine change. And that's what we're representing here. And that is a definition of sickle cell, that you have this genetic mutation at this point. Give me 1 second. I'm sorry. Okay. And what that leads to are all of the things we talked about, like the ulcers, which people know about when they have 2 copies of the S gene. Anemia is very well known, and a lot of the other diseases I mentioned earlier. What do we call sickle cell anemia? So let's get very specific here. Sickle cell anemia means that you have an anemia, which means you have red blood cells dying before you have able to replace them. You have fewer red blood cells in the circulation than you should have. And that's going to have certain signs and symptoms that we can identify. Okay, it's good. So that is sickle cell anemia. Let me see, I'm going the wrong way. Sorry. And that's going to have certain clinical signs and symptoms. And what's significant here is that the anemia is what is easily identifiable now. Way back in history, it wasn't, right? And so early on in the history of sickle cell, the same things that are happening to the trait community happen to the sickle cell anemia community, meaning they were thought to have just an iron deficiency anemia. If you brought your child who was suffering in for care, you would be accused of child abuse. You'd be accused of making it up. The child would be accused of just, pretending and being a hypochondriac. It's all in your head. Now, we do know, it is well known that sickle cell anemia, of course, causes a decrease in your what's called your H&H, which is the hemoglobin hematocrit, an increase in reticulocytosis, which is that retic I showed you earlier, increased LDH, decreased MCV, increased RDW. These are, things your doctor is going to look for and say, okay, yeah, you do have this genetic mutation, and then your red blood cells and your blood counts do show these changes. So yeah, you have sickle cell anemia. So we understand why you're having pain or any of the other problems that you may be having. Okay. You could also see an enlarged spleen or no spleen at all. Both can happen. And so this is just a picture of what an enlarged spleen will look like to your doctor on a CT scan when they take a picture of you. So then what is sickle cell trait? Sickle cell trait also has the same genetic mutation, except of course in disease you have 2 copies, or what's considered anemia. Sickle cell anemia, you have 2 copies of the abnormal gene. In sickle cell trait, you have 1 copy. So you have 1 normal, which you see on your left-hand side, and 1 abnormal, which you see on your right-hand side. However, we now have tons of evidence that sickle cell trait can also lead to the same things: acute or chronic pain crisis, pulmonary embolism, pregnancy complications, exertional heat illness, which can be fatal, bone infarction, organ failure, cancer, death, and of course, like Dr. Tamia said, COVID complications. What is the difference that you're going to have on labs, though? The problem for patients with sickle cell trait is when your doctor goes to look at what's wrong with you, you will not necessarily have an anemia. You will have a normal MCV, normal white blood count, whereas in sickle cell disease or anemia, you'll have an elevated white count most of the time. Your reticulocyte count will be normal. Your hemoglobin electrophoresis, however, will be abnormal. In sickle cell anemia, it's more abnormal, with greater than 90% showing sickle hemoglobin protein plating out on that hemoglobin electrophoresis, whereas in trait, it'll be a 60-40 split most of the time. In sickle cell anemia and in sickle cell trait, however, you will see an abnormal smear. So way back at that slide where I showed you a picture of the red blood cells on a plate that was purple and pink, both of those will be abnormal, whether you have trait or disease, which brings us to the question, is sickle cell trait a disease? So right now, we don't want to say that sickle cell trait is a disease because of stigma, because of people feeling maybe there's not enough evidence, because then instead of 100,000 to 300,000 patients, now we have 3 million to 5 million patients, which is a lot bigger patient load than we had before. However, let's talk about what a disease is. A disease has 2 components. It has an abnormal problem in the patient that could be something in the genes, something in the organs, and it has an expression of that. So what do we have in both? We have a disorder of structure, where the DNA has an abnormal structure. We have a disorder of function, where you see changes in how the patient is able to function. And then you see clinical signs and clinical symptoms. So the clinical signs in trait is really just going to be on the peripheral blood smear. You're not going to see it when you do your regular basic complete blood count that your doctor is able to do most of the time. However, the patient is going to have changes in how they're able to function, what they're able to do. How do we know? Well, this is a collection of many, many, many studies that show that when you have sickle cell trait, you have increased thickness of your blood and your cells are more rigid. And this can be even at baseline. If you compare patients that are completely normal, have 2 normal copies of both of the genes that code for their blood, they will have increased stiffness of their red blood cells when the patient has trait versus when they don't. And of course, when the patient has SS compared to when they don't, and the blood will be thicker in a patient with trait, even at baseline, than a patient that doesn't. And then if you exercise those patients, the patients with trait will have a greater increase in their thickness of their blood, and that will persist. So that's what you see on the bottom, where you see the time. So with exercise, excuse me, I do have a bit of a cold, so I'm kind of hoarse. So over time of exercise, even once you stop exercising, the patient with trait will continue to have thicker blood. When you stop exercising the patient with AA or normal blood genetics, that patient will go back to their baseline. And even with exercise, the thickness of their blood will decrease over time. So then what does that mean? That explains why a lot of patients who are athletes have died from sickle cell trait that we can basically prove. Most of this literature where we tell about trait and death is from the forensic pathologists, because they're able to see something they don't see in patients with AA, where they can see sickled hemoglobin all throughout the body or in the specific organ that failed a patient with trait, especially athletes. The reason we know about it in athletes is because we can't blame it on anything else. And so that's why, as of 2007, sickle cell trait was the leading cause of young African-American patients. They couldn't blame those deaths on anything else. And so they could very clearly see that the problem was trait. Now, what's another reason for that death? In patients that have AA, the more they exercise, the better their body tolerates exercise. That's why your doctors always tell you to exercise, exercise, exercise. In patients with trait, you get increased endothelial adhesion, meaning the blood cells will stick to the blood vessel walls at an increased rate. So at first, when that patient exercises, they'll do the normal thing, which is the adhesion decreases, right? But then all of a sudden, the adhesion dramatically increases. And then that's what happened to Devard that day. I always mix up Devard and Devon. That's what happened to the darling twin that day when he died. At first, he was handling it. And all the rest of the time in his football career, he was handling it. All of a sudden, he hit that point of too much and he wasn't able to handle it anymore. So the bottom line is that sickle cell trait does meet the definition of a disease in general and of sickle cell disease in particular. So what do we see? We see that there's a lot of overlap. Hemoglobin SS, which is what people traditionally call sickle cell disease, we know that it can be extremely severe. It's fatal, and there's increased morbidity, meaning you have a lot more health problems that can come from it. However, the same thing can happen in trait. You have increased mortality, as I explained to you, is the leading cause of death among athletes and young African Americans. As of 2007, and I'll tell you why that may have changed. You have increased illnesses among patients with trait, and in some of the later courses that you can sign up for, you'll be able to sign up for on our site. We'll get into some more of those details, and the severity can vary. And so some people with trait, they don't really feel any symptoms at all, whereas other people with trait, like we said, can die, and you have everything in between. So it's a spectrum of silent to fatal and mild to fatal if it's SS. In sickle cell trait, most of our data is more so qualitative. Same thing in sickle cell, it's more so qualitative. It's very hard to quantify because you can always find other things to blame these on in most patients. And in sickle cell trait, most of the research about death is also qualitative, whereas in disease, most of it is qualitative, but we do have good numbers as well to back that up. 1 second. I keep clicking off of the right screen. I apologize. All right, I think it'll let me go now. One of the presenters from whose research I pulled said that the etiology of death is frequently multifactorial and poorly defined. So in the beginning, sickle cell disease didn't make it onto the death certificates, which is what happens now with sickle cell trait. And that this is why, because there are many things contributing to the person's death. And so it can be very difficult to prove that the cause was trait or disease. So I want to talk a little bit about the pathophysiology of red cell disease. What's happening in both of these, in all of these disease processes, really, is that change from glutamine to valine is generating what we call a polymer when things stick together, and they shouldn't be doing so. And that polymerization inside of the hemoglobin inside of each red cell is what makes them stiffer and stickier, and in disease more than trait, take on that shape, which is what we're showing here. That's that you get the red blood cells then, which is a change shape, or the sticking together, or that sticking together, it damages your blood vessels. And that damage is most obvious in the kidneys of patients with sickle cell trait and in all of the patients in their spleens. It can be anywhere in the bone, in the eyes, any place where you have small blood vessels, you can have damage. And this is explaining to you why. Okay. Now, in sickle cell trait, you have more so membrane rigidity. So the covering or the outer membrane or the outer tissue of the red blood cell is more rigid. And that's gives you the increased thickness. And that's more noticeable in trait compared to disease. Whereas in disease, than the anemia. And in the anemia, you see the sickle cells more. But in either one, you're going to have adhesion, and you're going to have, which is when the cells stick to the vessel wall, which is going to make the cells, your vessels are going to be tightened. Blood can't get through. And so in trait compared to disease, part of why it's hard to get your illness realized is that the damage is happening at a very microscopic level. So you're having this pain, but it's not making that big ulcer like we see in disease. It's not making your spleen enlarge rapidly like we see in, when I say disease, I really mean anemia, in the anemia. So that is part of how come all of this is happening to you in trait, where you have symptoms and no one can see it because it's happening as microinfarction, small areas of death rather than bigger areas of death like happens in anemia. In sickle cell trait, your red blood cells live maybe about 90 days, so you don't get as much of the anemia as you do in sickle cell, SS, sickle cell anemia. But these are slides. This slide is showing you a slide from patients with sickle cell trait compared to a slide from patients with sickle cell SS. And you see that basically the blood looks the same. You just have more of the blood that's not as bad. Okay. Now, this is also comparing a slide of sickle cell trait with beta thalassemia to a patient with normal hemoglobin. And I think even to the untrained eye, you can see how oddly shaped those red blood cells. They're not nice and round. So this is why I explained to you that sickle cell trait is kind of halfway between normal and SS, which means you're still going to get sick. You just may not get as sick, and you may be able to compensate. Okay, so this was the case report. Instead of this case report, I'm going to talk to you about another case that I think is more relevant to the Latino community. I don't have that slide up. Give me 1 second to get that slide up. So in my clinic, I take care of, I end up taking care of a lot of the patients that have sickle cell trait, because a lot of times, let me put it like this. Patients who have sickle cell have a hard time getting care, meaning SS, that have the anemia, that they can measure, that they can see. They have a very difficult time getting care. And so that's even worse for patients who have trait. They have a really difficult time getting someone to take care of them. And so I end up taking care of those patients. I have a child who is 8 years old, and I just want to tell you her story. She's a Mexican patient of mine who has been sick since she was very little, probably around 2 or 3 years old. She started to have symptoms. So much so that her mother would carry around I think I can do it now. I can put this on this. Let me see me escape. I can put this on. Am I still sharing my slides? I'm almost done. After I finish this case, I'll be done. And am I still sharing my slides? How about now? Still no? Okay. I just want to pull this case up for you guys. Let's see. Oh, I see. I know what I have to do. Sorry about that. Okay. Okay. Am I sharing now? That's not what I wanted to do. Let me go back. I think I have to change. So from 2 years old, her mom noticed that she had symptoms. And by the age of 8, her mom would still, whenever they would go out, up to 8 years old, mom would always have a stroller with her whenever they would go anyplace. Because, can you allow my slides to be there instead of my face? There we go. All right. So from 2 years old, her mom to 8 years old, when I met her, her mom would still walk around with a stroller to keep her in because her daughter would have these drop attacks. So at any given time, blue, my patient would develop severe abdominal pain that would just make her scream, and she would just drop to her knees. Other times, she wouldn't develop the severe abdominal pain, but she would just be extremely, extremely weak. And mom tried to explain this to the school, because at school in PE, her teachers would make her ¿qué otro riesgo tienen las personas con el rasgo y que no tienen síntomas aparte de ejercicios? Okay, so aparte de ejercicio extremo como atleta. Okay, so I'm going to tell you that right now. This patient wasn't even an athlete. She's just a regular kid. So just a normal day. Anytime she might get dehydrated, anytime they go for a walk, seasons, it got to the point where mom couldn't even tell what would trigger her. She would just have drop attacks, severe abdominal pain, wake up in the middle of the night screaming that her legs were hurting, and her mom wouldn't be able to see any reason why except that she had sickle cell trait. At school, if it was a hot day, if the teachers didn't let her go get water when she needed to, if she had to do PE, with PE, she would get fatigue and weakness and not be able to run, and it would make her run anyway. When she would get sick at school, the teachers would say she was faking it and make her continue with all of her activities anyway, to the point where this young girl would vomit, and they would still say that she was faking it. And so by the time I met them, she had normal vitals the day that I met her, but her eyes looked jaundiced to me. They were definitely gray, not really yellow like you see in SS, but just kind of an overcast gray look to them. Everything else was pretty much normal. She didn't have too many symptoms. However, when I did her studies, I just noticed the grayness of her eyes. And so I checked a hemoglobin electrophoresis, which did come back and show that she had that pretty much that similar 60-40 split. And I also checked her for everything else like rheumatoid, lupus. She had none of those other problems. Her hemoglobin was 6 on the day that I met this little girl. I can't see the entire screen. No, it doesn't give you any kind of leukemia. The white blood cells are actually low. Yes, That white cells are low because of the sickle cell. It can go high, it can go low. And then okay, I'll answer your questions. I see your questions I asked. Let me finish the case very quickly. And so her hemoglobin was extremely low, so low that to me she needed a blood transfusion at this point. We normally transfuse a patient when they're at 6. Her other numbers were completely normal. However, her liver enzymes were very elevated. Her alk phos was through the roof. Her platelet count was also extremely low. And then we didn't get the UA that day. And then on her next visit, she was normal again. And so and this was a month later. So in that meantime, I frantically tried to get in touch with them and I couldn't. Basically, her mother was so fed up with not being listened to that when I was calling to tell her about the abnormal, she just basically ignored me because she didn't think I was actually going to help her. And so her differential diagnosis included anemia, autoimmune disease, or pretend. She was treated for 6 years. Her and her mother were treated like she was pretending. However, her symptoms were so severe, it was very hard to differentiate her condition from somebody with full-blown sickle cell. And she only had trait. She didn't have alpha thal or beta thal, only just the trait. And she would go back and forth between abnormal and normal hemoglobins the entire time I took care of her. So what was the treatment? Number one of the things I do for my patients is I will do a care plan. A care plan is something that your doctor has to write for you. You can't write it for yourself. And it's basically a message from your doctor to everyone else in the healthcare industry saying that you have problems from sickle cell or sickle cell trait and what works for you. And you also get a letter to your school. And that's something that I do for my patients, or that you can get a consultation with me and I will do for you. And I'm licensed in 20 different states. So I have a broad range of patients that I can help now. And so there's a letter that I will write to your school, because one of the first things you want to do is change the triggering factors, such as excessive heat, excessive cold, dehydration, not being able to use the bathroom when you need to, inadequate rest, bad diet, nutrition. All of these are your first step, is to change the triggers. Your second step is then medical intervention. And so what do you need? You potentially need IV fluids. You might need oxygen. You may need pain medication or IV pain medication, depending on how severe your symptoms are, whether or not it's starting to affect your organs, et cetera, et cetera. And so the other thing that has to happen is all of the schools and institutions need to implement the same protocols that the NCAA has implemented. And let me backtrack a little bit. The deaths among athletes went down from 89% to something like 11% from trait because they implemented protocols. And those protocols are that they keep oxygen and fluids available at the sidelines for patients, for athletes who have trait. And the same needs to be available to any of the patients, whether they're athletes or not. They also believe them when they say they don't feel well. They do frequent hydration. So if you have a student who's an athlete, or even if they're not an athlete, they need a letter to their school that this patient needs to be able to have a bottle of water with them at all times and be able to refill it at will, use the bathroom at will. A lot of schools limit bathroom and water drinking to between classes or lunchtime, because otherwise they have 30 students getting up every 5 minutes to go to the bathroom and they can't get through teaching. And so you have to have a letter to the school explaining your child's condition, or to the university or wherever you're, even your job, explaining that you need to have frequent bathroom breaks and frequent hydration. And then after that, if you do get sick, you need to be cared for properly. So, okay, so I think I'm answering these questions. So with the anemia, there's the same problems can happen in both. Everything up to death. You can have kidney failure, kidney disease. Now in trait, there's this very specific cancer that only happens in trait, that doesn't happen in disease as much. okay? In all of them, whether it's trait or disease, you can have some of the same problems. I'm gonna pull up. And I do teach about this on the site and in the classes that you can sign up for with us. So let me just, she's asking about treatment and I've got my protocols slide deck. Okay. Showing yet? Let's see. Okay. She's asking about treatment. I want to go to my treatment slide. Sorry, it's taking a second to load. So basically, these are some of the things we recommend for treatment as far as outpatient care. Let me go back. So I ask doctors to still get the labs even though they may come out normal for that one time that they don't come out normal. If you are in the outpatient setting, we have to get doctors, nurses, nurse practitioners, PAs, everybody to know and advocate for patients with trait just as much as they advocate for patients with full-blown sickle cell. They have to notice that the patient is having a pattern very similar to sickle cell. You have to check how severe it is, and you have to stratify your patient according to the risk. And then you have to realize that the labs may be completely normal. The patient may even look normal. But this is a disease where, especially with trait, you're going to have pain out of proportion to the exam and exam findings. But that doesn't mean that the pain isn't happening because it's happening on a microinfarction level. And I still recommend all the same blood panels that you would get in both, which are listed here. And then I did a review. The only thing that they'll be able to find when they look at is what we call a relative change, meaning your numbers changed in an abnormal way compared to what they normally are when you don't feel sick. So it's very important for your doctors to check you when you don't feel sick and compare that to when you do. And then once all that's been done, if you're in the outpatient setting, you have to know when you're dealing with an emergency. So if the patient can't breathe and says they can't breathe, even if their oxygen is normal, if their oxygen is abnormal, even a little bit, this absolutely has to be addressed. If they have a high fever, if they have any change in their vital signs, then in the outpatient setting, you need to get emergency care. Other than that, in the outpatient setting, there's a long list of things that I take care of and do for the patient beyond what you can do for yourself. That would be on a case-by-case basis. I do teach the patients about hydration, what food you need to eat and what you need to avoid. But in the emergency setting, you're going to get IV fluids, oxygen, and pain control. Pain control is just as important as the rest of it, even though we're very careful about abuse. Studies have come out that sickle cell patients have only about a 3% risk of a 2 to 3% risk of actually abusing the drugs that they're on. Most of them hate it. And they're actually far less in abuse than the regular population, to be honest. You're going to check all the vital signs and everything else. The most important thing is to really listen to your patient, to give them oxygen, to give them fluids. A lot of doctors are worried about some of the latest studies that say, you can damage the lungs if you oxygenate when it's not necessary. But your patients with trait and sickle cell really tend to need the oxygen because it's hard for their bodies to get oxygen where it needs to go. There are some medications on the horizon that are not quite approved yet, that people are looking at for using for trait as well. And Dari is also on the horizon. Voxelotor is on the horizon. Basically, making sure you supplement proteins can also be good. When it comes to anybody, and especially with athletes, you're going to teach them to take frequent breaks, to warm up, and to drink a lot of fluids.
Dr. Pasante, I'm going to interrupt because no, we're not actually, you're breaking up, even though we can see your slides. So what I'm going to ask you to do at this time is if you could take the slides off, and that may actually help. And then we're going to see if there's any questions. There we go. So you were speaking, but you were also choppy. And so our interpreters can only translate if they can hear, and you were choppy. And your screen, there you go. Okay, your screen's no longer for.
Sorry.
Oh, no, 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 no.
I was on the wrong internet and I didn't notice it. I didn't know I was breaking up. Did you try to tell me?
Yes, but it's okay, dear. So first of all, it's okay. First, it's my pleasure. It's my pleasure to have you on Cayenne Wellness Center's second annual Hispanic Heritage Sickle Cell Seminar. It's my pleasure to have you. What I can share is that we're going to be working together, okay? Because we have a sickle cell trait initiative out here in California that we will be implementing, and I can see how we can actually collaborate. What I want to be able to do, though, I am looking at time, and we are over time, and is to, it seems like Sylvia has been actually asking questions, but let me just see if there's anyone else that has a question. And then for sure, if you can put in this chat, or actually on your name that people can see, they can see your website. So I encourage everyone to please go to her website. It's easy to navigate, and you'll be also able to see her classes as well as contact her. So her website is there, and it is .co. It's not .com. It's .co. Just to let everyone know. And
They put .com, it'll still route.
Okay, great.
It'll still route.
.com. And so do we have at least one question before we wrap up this session? And then we'll go on to the next part of our program. And can you all believe it? We're already at 2:30 and we began at 9 o'clock. So we've had a full day. Let me see if there are any questions coming in from the Q&A, from the live stream, as well as from Zoom. And I'll wait for my tech team. But meanwhile, we're so happy that you have found your way into this deserving community, both the trait and the disease. So it looks like there aren't any questions. I appreciate you, Sylvia, for the questions that you, okay, there may be at least one, and then we'll wrap up and go into our next session.
I want to make sure I answered that one from her. It's not going to give you leukemia. It's not. It doesn't give you leukemia. It gives you a different type of cancer, like renal medullary carcinoma. That's what. I didn't know if I answered that.
Right. So so that we'll just let everyone know as well, since we're getting this translated both in English and Spanish.
Yeah.
So for trait, just so that everyone knows the facts, once you have trait, you always have trait, and trait does not turn into the disease. So when you're born either with trait from one of your parents, or you're born with the disease from both of your parents. And I think when Dr. Pasante is talking about complications, and Dr. Austin mentioned it as well, there are risk factors. And one of them that they're finding out through research is that you can have cancer of the kidneys, basically. That can happen. Doesn't happen often, but often enough that they've been able to find a correlation. But no, the trait nor the disease can turn into cancer. Now, don't get me wrong. Unfortunately, cancer is prevalent. And so, yes, particularly if cancer runs in your family, and you may have a predisposition, unfortunately, but just by mere fact of having this disease does not mean that it's going to turn into anything that's cancerous. So good question to be able to kind of tease.
Can I piggyback that? The one caveat I want to say is renal medullary carcinoma, one of the reasons it's been so deadly is that there's no surveillance. There's no surveillance protocol. And when you have trait, because of the repeated insult to the kidney tissue, because that's the place where you have the tiniest blood vessels in your body and the back of the eye. Because of that, you can get something called renal medullary carcinoma. So one of the things I do for my patients is I do frequent urinalysis. And if I see blood, I get an ultrasound. And if I'm not sure about that, I get a CT scan to make sure that because the sooner you catch it, the better. And the Chris Johnson Foundation, working with Dr. Mosul out of Texas, has a lot of great initiatives around renal medullary carcinoma, which pretty much only happens to patients with trait. But leukemia, which is blood cancer, does not come with disease, with anemia, or with trait.
Wonderful. Thank you. And then that is actually, I know that there's another question regarding treatment. I am looking at time though, and so we do need to kind of attempt to try to get back on so that we're not here too much later. And so, again, if you have questions, Dr. Pasante is very responsive, she and her team. So feel free to reach out. You have her website up. And again, I want to thank Dr. Austin, who did have to go on. This is also SCDA National Convention Week that began on Tuesday, ends today. And so it's been quite a week of education this week. Dr. Basante, thank you for your time. And at this time, what we're going to do is we are going to start right now with what we have going up. We're going to actually show the I am video in English at this time. And so we can show the I am video. And then after that, we'll show the video of reading is fundamental. So if we can show the I am video, that'd be great. Thank you.
Dear me, younger me, just like your hair defies gravity and your skin absorbs the sun rays, you are miraculous. You are powerful beyond measure and ignite change by simply being. You are already the thing you are striving for, the approval you are trying to obtain, the title you are trying to win. You are. Some people will only see you in phases. They will judge you by your quarters, halves, and crescents, but don't let that distract you. Even in all its phases, the moon is still whole, so never forget who you are. Your identity is cosmic, extraterrestrial, godlike, celestial, favored by nature, stellar and divine. You are. So, when they try to place false labels on you, misrepresent you, and tarnish your name, stand firm in your identity and tell them, I am.
I am.
Sickle cell disease is a group of inherited red blood cell disorders that affects hemoglobin, the protein that carries oxygen through the body. Normally, red blood cells are flexible, round, disc-shaped, and move easily through the blood vessels. If you have sickle cell disease, your red blood cells are shaped like sickles or crescent moons. These rigid, sticky cells can get stuck in small blood vessels, which can slow or block blood flow and oxygen to various parts of the body. The blocked blood flow through the body can lead to serious problems, including stroke, eye problems, infections, and episodes of pain called pain crises. September is National Sickle Cell Awareness Month, Approximately 100,000 persons in the United States live with sickle cell disease. June 19th is World Sickle Cell Day. Sickle cell disease continues to be a major global public health issue. It remains a major killer of infants and children in the developing world, particularly in sub-Saharan Africa and in India, where an estimated 50 to 90% of infants born with SCD will die before their 5th birthday. By 2050, the number of people with SCD is expected to increase by about 30% globally.
At this time, what we're going to do, thank you for watching our video. And so sickle cell, we are not our disease. And we are not any of these negative terms. And so at this time, what we're going to do is change up. And I'm very much into not only sickle cell gear, there's many t-shirts and what have you, but also books. And books are great, something that you can take with you, something that you can hand to someone to be able to share information. So I believe we do have a video. Reading is fundamental. And so if we can actually get that one queued up, that would actually be great. So that one will be shown shortly.
Cleverly Changing empowers moms, homeschoolers, and advocates for children with special needs. She is a mom of twin daughters, one of whom is living with sickle cell disease and type 1 diabetes. She is the 2020 Advocating for Another Wago Health winner and author of a sickle cell coloring book for kids. FeedSpot ranked the Cleverly Changing podcast number 3 on the top 20 homeschooling moms podcasts list. She's been featured on NPR, ABC7, BBC World Service Radio, and many podcasts. She is a writer, speaker, and podcast host. Her website discusses wellness, personal finance, and parenting. Welcome to Educate, Reading is Fundamental, part of the 2nd Annual Hispanic Heritage Sickle Cell Disease Educational Seminar.
All right, so that's the intro. And we will have the recording. Elder Cole is not able to be present with us. Again, there's so many things happening in the sickle cell community. And even myself, earlier, I was on the Women with Sickle Cell, Living with Sickle Cell Disease, part of the SCDA convention this morning at 8 a.m. Pacific time. So many of us are wearing more than one hat. But we will actually have the recording up shortly. So thank you for your patience and grace.
Hello, hello. Hola, everybody. I am so thrilled to have an opportunity to talk to you today. And let's talk about a subject that is near and dear to my heart. Hello, hello. Hola. I am super thrilled to have a conversation with you today about a subject that is near and dear to my heart. Without further ado, I'm going to go ahead, share my slide. I'm going to tell you a little bit about who I am, and we're going to jump into this conversation. So today we are talking about the topic health literacy. Reading is fundamental while parenting a child with sickle cell disease. I am Elle Cole, an author and caregiver. This is my family. I am the mother of 2. My husband and I have been married for 16 years, and we are the proud parents of twin daughters. Today, I'm going to talk to you about health literacy. What is health literacy? I'm going to pause a second and let you think about those words. The CDC defines health literacy, personal health literacy, as a person's ability to define what is health literacy. The CDC defines health literacy as the ability of a person or a caregiver to understand and use the information to make informed, sound decisions, gather information and services that they can use to better health for themselves or for others. And so let's break that down even further. To me, health literacy is understand what the doctor is telling us and being able to apply it with understanding, with that information, with a sound mind, and feeling comfortable partnering with your healthcare team. So how do you get started teaching your children about sickle cell? Sickle cell is a genetic disorder that we pass down. And so it is critically important that we start teaching our young ones at a young age what sickle cell is, how to understand it, so that as they care for themselves, they'll be able to ask questions to the doctor that can really help them become more compliant and help them.
All right. Thank you, everyone. And I'm sure we will, I guess, technical difficulties with the recording. So give us a moment. And again, as always, I'm hoping that you'll extend to us grace and patience while we get the recording back up and running. So thank you. Meanwhile, they'll let us know when the recording is up. I did want to just mention that after this, we will have another randomizer, and guess what you'll be receiving? If your name is pulled, you'll be receiving in Spanish. Well, you can actually determine. Elle Cole, 2 out of her 3 books are in Spanish, and then she has 3 books in English. So if you're the winner of the randomizer, you would get an opportunity to share with us if you would like the books in Spanish, or we're not going to do that right now, but we will determine, after the recording, you can determine if you would like the books in English and or in Spanish, and then we will actually mail that out to you. So that's going to be the great thing once we get the recording back up and running. Again, thank you for that. And I do believe in health literacy, particularly through books. I think it's a great way. And there are several now sickle cell warriors and caregivers that have actually written books. So besides Elle Cole, and I believe she's the one that has at least several behind her name. There's also Chanel, who wrote Clemmy. It's one of my favorites. It's a book about Walter Clement Noel. And you need to know his name. So, Walter Clement Noel is the first person that has been written about in medical article, the first person written about that with sickle cell disease, Walter Clement Noel. And that paper came out in 1910. Walter Clement Noel, a dental student from Grenada, who traveled to Chicago to go to school for 3 years. And during that time, during his schooling, he had leg ulcer and he had pain, and they didn't know. And they described it as an elongated cell of this intelligent Negro. And so, and that is the first paper, although we do know that sickle cell disease and trade has been around for hundreds of years, even prior to the Atlantic slave trade. So it's been around for some time. And so that's one of the books is Clemmy. Also, Tanya Gentry, Pee Wee Goes to School. And can't forget Janeka Leah, my friend Jen. And even we've had so many during our Authors Corner. Cayenne Wellness Center has an Authors Corner where we actually feature artists 3 times a year to talk about their book and that process. And then we're always giving away a book during that particular time. So at least after the recording, we'll be able to find out who's going to actually be able to get 2 of her books, and you can name what language that you would actually like that. So looking forward to that. We invite you actually to come to our Arthur's Corner. And again, one way of being able to just follow what we're doing is to go to our website and click to be part of, to get our email. And that way you can actually follow. We actually have a monthly e-newsletter that lets you know the up and coming seminars and webinars that we're doing. And then we also feature others in terms of what they're doing as well. So that's a good way of keeping abreast. Mary, our program manager, is wonderful, and she actually does a lot of our translations as well. So that's a good way of actually keeping up of when our next Author's Corner is. We do actually have one more, and it will actually feature it'll actually feature Elle Cole as well. So that'll be great. All right, and after we do the reading is fundamental in terms of health literacy, and we actually do our randomizer, our final session is just going to be an open session, and we want to hear from you all. We're very patient-centered here at Cayenne Wellness Center, which means that you all direct the information that we get people who are experts in the field and be able to present them. So you direct what we're going to be presenting. And so for next year, for our 3rd annual, we will take those suggestions and we will create a program just based upon your recommendations. So that would be a great opportunity during that time. And that will be our last session before we have our closing remarks from our wonderful moderators, from Mary and myself. So that is the agenda coming up. All righty. So at this point, we'll see if the video is ready to be continued as we continue reading as fundamental. I'm checking in with our tech team right now.
Hello, hello. Hola. I am super thrilled to have a conversation with you today about a subject that is near and dear to my heart. Without further ado, I'm going to go ahead, share my slide. I'm going to tell you a little bit about who I am, and we're going to jump into this conversation. So today we are talking about the topic health literacy. Reading is fundamental while parenting a child with sickle cell disease. I am Elle Cole, an author and caregiver. This is my family. I am the mother of 2. My husband and I have been married for 16 years, and we are the proud parents of twin daughters. Today, I'm going to talk to you about health literacy. What is health literacy? I'm going to pause a second and let you think about those words. What is health literacy? The CDC defines health literacy as the ability of a person or a caregiver to understand and use the information to make informed, sound decisions, gather information and services that they can use to better health for themselves or for others. And so let's break that down even further. To me, health literacy is understand what the doctor is telling us and being able to apply it with understanding, with that information, with a sound mind, and feeling comfortable partnering with your healthcare team. So how do you get started teaching your children about sickle cell? Sickle cell is a genetic disorder that we pass down. And so it is critically important that we start teaching our young ones at a young age what sickle cell is, how to understand it, so that as they care for themselves, they'll be able to ask questions to the doctor that can really help them become more compliant and help them have a better quality of life and better health services. I tell my daughter that she can live a life that is rewarding for her. She can do whatever her heart desires. And I encourage my daughter to learn what she loves, what makes her happy, what excites her. And it's really a journey about loving yourself and doing what you feel your purpose is. My name is Elle, and I'm the mother of twins. One of my twins has sickle cell SS, and the other has sickle cell trait. It can be a large diagnosis and something that may not be familiar with people, but you can start becoming an advocate immediately just by doing the research, getting to know the healthcare team, being comfortable with the doctors, finding out what to do if there is a problem. And I think for me, finding out who to call and when was very helpful. Learning signs of different things that can be a complication. Like some children with sickle cell can get acute chest. What does that look like? Ask your doctors that beforehand. Ask your doctor what are signs of a stroke, even a silent stroke, because that's something that affects children with sickle cell, and it can affect adults too. As my daughter has gotten older, she has started to ask questions about different things. I know that as she grows, one day she's gonna have to take the lead. And so I have to start preparing her even while she's young. And even before they have complications, you can kind of plant different seeds and use certain terminologies that they can have a better understanding, like blood, the word cells. Those things are simple, but I think as they grow, you can build on those concepts. No, I didn't want to overwhelm her with different things, but one of the troubles that she had was getting the lab work and getting the having people draw blood. For a kid, nobody wants to sit there and have someone draw blood. But what I did, I would let her listen to music, and I would be right there. When she was very little, I would hold her. And so now she's an old pro at doing her lab work, and she sits there like a champ. A matter of fact, now when I go, I think of her and how she champions her own care. And so when I have to get something done, I think about how strong she is. And so it's been a journey, and as she grows, I'll continue to build on those different lessons that I started to teach her at a very young age, because kids can start having complications very young. So just like the video mentioned, I started teaching my child while she was young. And it really started with me telling her about different terms and also just using certain things. There are 5 different ways I started to teach my child about sickle cell disease. So I'm going to share with you 5 ways that you can teach your child about sickle cell disease. The 5 ways are books, dialogue, appointments, toys, and role play. So when my daughter was 5 years old, she had her very first pain crisis. And it was from that particular experience that I wrote my first children's book, a sickle cell coloring book for kids and ABCs for sickle cell. It was after that experience that I realized I needed to really talk to her about what was happening in her body and how she was feeling, so that she would have the words to express what was happening to her. So books help build children's vocabulary. They help them look at different pictures, look at the words, and see how it relates to their own lives. And so it is important for us as parents to read books with diverse characters, because representation matters. When our children read books, they visualize themselves being a part of the story. And so making sure that the books also have kids that they can relate to is important. I know when I created ABCs for sickle cell disease, I wanted it to really show that sickle cell is diverse. It affects a diverse population, not only African Americans, not only Hispanics, but all different types of people. And so that's why I made sure that my books showed a wide variety of ethnicities. So I also wanted to point out on the page what information was there, just to make sure that she was following along. So like on a page with the doctor, so I have this is an illustration. Let's see. I don't know if you can see it. Okay, so you can kind of see it, not really. But on the different pages, I would say, hey, do you know which word is cells? Point to the word cells. Do you know, which illustration do you like the best? Can you relate to this picture? When you're in crisis, does it make your stomach hurt, your back hurt, your foot hurt, your arm hurt? Just pointing different things out so that they would have a better understanding of how to communicate problems or different things that you may need to be aware of as a parent. And you can use books to really help kind of partner with them in learning how to share things with you. And so it's really about kind of opening up the conversation to be able to dialogue with your child so that they can talk to you about what they're experiencing on the inside. So it's very important to use words that children know and understand. So simplify it. Sometimes when we go to the doctor, we know that the doctor is using jargon and information that we don't understand. And that kind of causes us to have a barrier or a wall where we're no longer listening to them. That same thing happens to little children as well. So if we simplify the terms, help them define different words, they will have a better understanding so that they'll know not just what you're talking and communicating to them, but also what the doctor is saying when they go to different appointments. So don't just tell children, you want to show them. I mentioned earlier that you can use books to show them with the different illustrations, but you can also use other techniques as well, like two that we're about to talk about, like toys and role playing. Those really help to not just tell, but also show. Ask questions so that you can confirm to make sure the child understands what you're talking about, but you also want to understand what they're talking about. Children are whole people. They may be small, but they are full humans. And so we can talk to them to really begin to understand what they're experiencing. And this is important to know what's happening on the inside, because you're not only responsible for what's going on physically with your child, but while they're little, we also need to be in tune to what's happening emotionally and mentally as well. And by tapping into the conversation and dialogue and making it comfortable for your children to come to you and tell you what's happening, make sure you believe them and ask questions to gain a better understanding if there's something that you're kind of fuzzy about and may not be sure of. Ask questions to get a better understanding. Now, during appointments, we want to not just take in information, but we want to partner with the healthcare team. And so one way that I try to really partner with my daughter's healthcare team is by taking notebooks. I had a notebook for me and a notebook for her where I would write down questions or different notes that the doctor was telling us. I'm a person who learns by doing. I'm a kinesthetic learner. And so by writing down, it helped me remember what the doctor was saying, what types of things I needed to look out for. And so for my child, I would tell her when she was young, before she could write things out, to draw pictures, draw how she's feeling, how, what she thinks the doctor is saying. But this really helps integrate them in the process so that it's not just an experience for the adult, but it's something that the child is taking part in and participating in as well. Once your child is able to read and write, encourage them to write down questions to ask their doctor. Point out things on the page to make sure that they are following along. Again, when you are looking at the notebook, go over, if your kid drew pictures, ask them, hey, what is this a picture of? Because as we're parenting a child with a chronic illness, we have to be on this journey for a lifetime. Our kids do grow up, but we will always be their parent. We will always care about how they're feeling. And so we make that connection and that relationship. We start building that relationship with them while they are young. So I've mentioned that you can use toys to convey different messages, to teach new experiences. Let's say there's a new medication and your child is afraid to take it. What do? You can teach them through play. So you can use puzzles, stuffed animals, games, or other toys to encourage your child. So when my daughter was very small, she had to take penicillin twice a day, and it was a bit of a chore. So what I did, I would give a little to her, pretend like I was giving it to her stuffed animal or her doll. And, if the doll liked it, she liked it. So we use that sort of concept to really reinforce what I needed her to do. One of the games that I grew up playing that my children also enjoyed was the game Operation. By giving children the words to express what is happening, they will learn how to better communicate their needs when they are sick and don't feel well. So, the game of Operation is that game where you see a person laying down on a hospital bed. And sometimes our children has to go to the hospital. Sometimes they may have surgery and different things. And so playing Operation, it teaches them the different body parts, just like when they were really small, we pointed to our eyes and said eyes, or pointed to our nose and said nose. So by using the game, I was able to teach her other body parts and really talk to her about how doctors are, educated to help care for her and make sure that she has the best care possible. And so you can use, these are just some of the examples that we used in our family, but there are other examples that I'm sure you all have as well. And, it would be helpful while you're listening, just put into the chat some of the things that you use to help your child as they grow, as they learn. Like, are you using toys? If so, put some of those different messages in the chat right now so that other parents can gain ideas, because the examples that I use may not be perfect for your child, but there may be an example that you're sharing that would work great. So we have to kind of share what's working for us in teaching our children so that we can all use different techniques to really get that message across. So it is just by using toys, it is proof that you can meet your children on their level to unlock how they feel. Role play. As you teach your child, encourage them to teach that same lesson to their doll or stuffed animal. And so one of the things that you can do after you go to a doctor's appointment, you can actually have your kid kind of reenact, what did you learn? Tell that to your stuffed animal or your doll or your action figure. And you can learn what they understood. And if there is something that isn't quite right, this is an opportunity for you to go in and kind of shed light and really break down that information so they can understand something that they may not have understood earlier. But by getting them to teach their stuffed animal or toy, you are able to see what they really understood, and you can help them have a better outlook about their health. Use imagination to help them overcome challenges that may arise. You can also practice. I mentioned in the video that my daughter, one of the biggest hurdles that she faced in her care was getting lab work. And she had to go every 3 months. And at first she used to scream and cry. And I said, we have to make this better. So we started to practice at home. I'm going to hold her. I'm going to let you listen to music. I may hum a tune. Like if you sing, you may, sing a little song to your child. I'm not a singer, so I just, took earphones so that my child could listen to music to just kind of ease their worries while they're getting things done. And so those are just some of the lessons that I used to help my child when she was very young. Now she's 14 years old, and the doctors ask her questions. And so afterwards, while we're driving home, I ask her, did you have any extra questions that you may not have asked? And, I just keep those in mind so I could send it in her portal if it was a question I couldn't answer, and let her doctor know, because I think it's very important that we get our children involved in their health now. There's no switch that is unlocked when our children go to college and are forced to care for themselves. They have to really start those lessons while they're young. By preparing your child while he or she is young, you'll help ensure that your child has the best foundation that will last them a lifetime. So some of the books that I've created, these are the two that are in Spanish. And I have 3 that are also in English, but the one on the right is a coloring book. And the first one is, they're really pretty much the same book, but the first one is a storybook. So for your younger children that aren't coloring yet, this is a book that you can read to them. And it just goes through different words that doctors may use and really gives them a picture and an understanding of how sickle cell affects the body. So I also want to invite you, if you enjoyed this presentation and information that I shared today, I want to invite you to the virtual second annual Sickle Cell Caregiver Summit that I have coming up. This year, our theme is Trust Your Instincts, Caring, Connecting, and Creating. And it's going to be November 4th through 6th. I am the lead coordinator. I partnered with the Sickle Cell Community Consortium to do the Caregiver Summit. So I would love for you all to join me and learn different lessons, but also have fun. There will be games, there will be just a full family experience for the siblings as well, because sickle cell is a family disease that affects the entire family, not just the patient themselves. So registration is open. Go to scdcaregivers.org to register. And if you need a scholarship, you can contact me. My contact information is right here on the screen. contact@cleverlychanging.com. Definitely connect with me. I am on Instagram at Cleverly Changing, YouTube, Facebook, and Pinterest as well. And if you're interested in my books, on the screen you can see my 3 books in English, and you can go to sicklecellbooks.com. I also have a podcast that I produce in partnership with the Sickle Cell Community Consortium. And that podcast is the Vitamin SC3 podcast. This is our first season, and we've had really excellent conversations. In fact, there is a conversation with Dr. Rowley, and that was on the mental health segment where she's sharing. So I invite you to tune into that episode and listen in. So I hope that you all have enjoyed this session. If you have questions, I am available. Again, you can email your questions to contact@cleverlychanging.com. I would love for you to connect with me, and I look forward to seeing you at the Caregiver Summit. All right, bye for now.
All right. That was a wonderful, wonderful recording of Elle Cole, who is phenomenal. I think she's a phenomenal caregiver and was given a gift of writing. And this is their second annual Caregiver Summit, so that's wonderful. We're going to take the opportunity right now to see, to do our randomizer and see who's going to get free books. So let's see. Round and round she goes, and it looks like it's going to land on. All right, let's see. We're pretty. Okay. And it looks like Renee Kirby is also, she also won these categories. So, okay, you rock, Renee. All right, so thank you. All right, so this is our last session. We're going to turn this over, and if I can be joined with Mary and our moderators. First, though, there are several questions, and I like to make sure that we get the questions answered. However, they are in Spanish. And so I'm going to have Mary translate those, and if I'm able to answer, I will. And if I am not able to answer, we will actually, Sylvia, give us your contact info, and I'll make sure that Mary emails you the answer. So I think there were a couple. There were several during Dr. Pasante, which I think Dr. Pasante answered, but I'd like to know what the last 2 or 3, and then we're going to get into your guys' open discussion. So let's get the questions asked and answered.
Thank you, Dr. Holly. Hello, everyone. So once again, my name is Mary Alcocer, and I'm the program manager at Cayenne Wellness Center. So I'll go over the last couple of questions that we got from Sylvia, and let me go and translate those for you. So I am translating the one that says, se recomienda tomar aspirineta o ácido acetilsalicílico para prevenir las trombosis y en personas que tienen el rasgo, no la enfermedad. So in this case, I will be asking Nilda to translate this question because I think she is more leaned towards the wording and she will translate it in a better and more accurate way. Nilda, I think you're muted.
And Dr. Raleigh is muted.
Oh, I'm not sure what happened to Nilda. Servio, can you actually?
Yeah, you can help us out here. Yeah.
Okay, yes, I'll be more than happy to translate that. The question goes, is it recommended to take aspirinate or acetylsalicylic acid to prevent thrombosis in people who have the trait, not the disease?
Unfortunately, I'm not able to answer that question, so we will table that and forward it to somebody that can answer that question. Next question.
Can you hear me now?
Yes.
Okay, earlier I didn't have the option of the button, so I didn't know what occurred. I'm sorry.
That's okay. So next is a comment, not a question, and she says, I noticed that patients and parents of patients with depressocitosis want to know a bit or enough information about the disease, but they refer to avoid its possible consequences. I think it is a defense mechanism of the brain, a way of denying the disease and living as if they didn't have it, perhaps for fear of what could have happened. In part, I think it is understandable, but denying the disease is not good and will not give them a better quality of life. So that was a comment. Dr. Raleigh, I don't know if you'll like to
I think
say
all of
anything.
us can. That's excellent. Let me just share it. I'm going to tie it into newborn screening, to be honest with you. So for a while, before newborn screening, and the bottom line is in 2006 in the United States, it is now in all states. But before that, people with sickle cell disease, they didn't know until they actually had their first episode, which for some could have been age 2. I think Elle Cole said her daughter was a little bit older. The bottom line is it's important to know because with research, we now know that prophylactic penicillin given when they're young up until age 5 is so important. And so you may want to have your head in the sand, but it's for your protection and it's to be life-saving to know so that you can actually take care. It is not a death sentence. It does not prevent you from doing what you want to do because you still have your brain. And so it can take you anywhere and everywhere. And so I understand, though, about stigma. And so I want to turn this over to Nilda and Suryo because maybe maybe culturally, there may be some stigma as well in terms of identifying whether you have the trait and or the disease. I could only imagine because everyone still thinks that it's a Black disease. And if you're not Black, oh my gosh, what does that mean? So do you have Black in you? I mean, it can lead to so many different things. Also, too, for parents who are not even aware, oftentimes getting trait and or disease has broken up families because the dad or the mom may say, I don't have that in my family, and not realizing that in order to have the disease, you need both. And so I can understand with stigma why you may want to put your head in the sand, but to be honest with you, it is not smart at all. It is not wise to not know. And so I'm going to turn this over to Nilda and Servio.
Yes, and I can speak from experience. I do have one of the parents that you described. So for my father, it is as if I didn't receive sickle cell from him. And in his family, no one has mentioned if they have trait. So because in paternally, no one has had the illness, for them is as if it doesn't run in their family. However, in the maternal side, it is my mother is only female of 10. Her daughter has the illness. And then I had a cousin, one of her brothers also had a daughter with the illness. And she passed away. But in my mother's family, we are educated on sickle cell and we're very aware of the trait and knowing your trait. But it is this maternal paternal discussion that always occurs. And I believe Miss Sylvia is true to where she says, I believe it could be cultural, as we still live times that we do not speak what happens in the home. So that is still occurring, I believe, in today. So to have sickle cell, to say you have it, it's a difficult conversation. I was at a conference once and someone had asked, how do you reach out to the Latino population? And they were having difficulties doing outreach. And I said, for some reason, the conversation of having the illness doesn't stir conversation. But when you speak of curing an individual with the illness, that is when the conversation becomes, I don't want to say more important, but that is when a person starts becoming more involved. And do I donate blood? Or it's like, oh, I can give you the blood. If you're probably, I could give you the marrow. So that is when the conversation becomes a topic. But while the individual has the illness and is in the hospital, sometimes it's either we do have a lot of support in the family, but many times it's the family. It is usually the family is large. Sorry, the family is large enough as it is at times, but when it comes to community, it's different. It's different for the outreach. I'm not sure if it's the same for Serbia.
Serbia?
Yes, I can agree on a lot on the part of the both parents having the sickle cell trait and not knowing that they had the sickle cell trait or being aware. Hence, I have sickle cell anemia, because this has to go with, screening as far as parents are concerned. They don't, it's not that it's something that is very enforced or something that is, reminded of people, to keep in mind before before you make the decision to have kids, before you get pregnant. You and your spouse should go ahead and test if you have sickle cell anemia. Other things are tested before pregnancy. But sickle cell anemia, I haven't seen that anything like that has been normalized. Um, I'm not gonna lie. I myself, there was just one time that I was guilty of sort of being surprised that somebody had sickle cell anemia. I was at the ER because I wasn't feeling very well, and there was this nurse that he was getting my vitals, and then eventually, when he put the oxygen sensor, he asked me, "Do you have sickle cell anemia?" And I was like, "Yeah, I do. How do you know?" And then he said, "Oh, because I have it." And I was surprised because he was Asian, like I mentioned previously, and he did not have any signs of jaundice or anything like that. Give me 1 second. And he didn't show any jaundice or anything like that, so I was extremely surprised. But yeah, that's the only thing that I can, that I can relate to when it comes to that.
Mm-hmm.
I'm sorry, is my camera coming in and out?
Yes.
No,
You see again.
just once.
So, Mary, is there another
Okay,
question,
thank you.
Sylvia, or have we
Yeah, there's one other comment. It says, it would be good if the next time there was a psychologist who can talk about the emotional part and the tools, a good tools to face life with this disease. Thank you. And that's from Sylvia as well.
Well, definitely, if you're still on, we will add a mental health portion to our third annual. So consider it done. Didn't I say that we're patient-centered? Okay. And so we will definitely add the mental health portion, not a problem. All right, so I'm going to officially turn this over to Mary, Nelda, and Servio. You all are going to lead the open discussion, and it's just that, an open discussion. I'm going to actually fade into the green room, and I'll be listening, and then I'll come back in as you're all about to wrap up. So this is officially the open discussion for all of you all who are streaming, listening to us on Facebook, Twitter, Zoom, and it's an open discussion about what you might want to hear. So Sylvia mentioned mental health, whatever you were thinking, if you want to share something. And I think that we are able to hear you from Zoom as well. So I'm going to fade out, and you all have a good time.
Thank you, Dr. Ali. So I will be leading this portion in both English and Spanish. And the reason why is because we have many people in the room who speak Spanish, and I will love them to be able to express themselves fully. So I'll start with saying que empiezo a hablar en español ahora. Bueno, este día está siendo muy, muy hermoso, está siendo maravilloso desde mi punto de vista. Espero que todos los que nos están viendo y nos están escuchando estén disfrutando de cada momento del día. Tocamos varios temas, se han tocado muchos temas importantes, entre ellos el rasgo, entre ellos cómo ser padre de alguien que tiene rasgo o tiene la enfermedad de células falciformes. Y bueno, más que nada el tema del día de hoy es nuevamente nuestra voz como hispanos, nuestra voz como latinos, que cómo es escuchada, especialmente en esta comunidad que aún nos hace muchísima falta que tenga la visibilidad, la equidad y el empoderamiento para tener todas las herramientas y adquirir los servicios de salud, la educación, la abogacía suficiente para que esta comunidad crezca y sea mucho más fuerte. Me gustaría escuchar, obviamente, Nilda de Servio y posteriormente cualquier persona que quiera participar de Zoom, su opinión con respecto a los países provenientes de los que ellos son, ¿no? Es decir, ¿qué creen que sea lo que ha pasado en los países hispanos o qué creen que le hace falta a estos países para empoderar más a la comunidad que sufre de la enfermedad de células falciformes? Y empezamos, si quieres, Nilda, adelante.
Sí, está bien. Yo pienso que el problema de la enfermedad de nosotros es que todavía, aunque seamos del Caribe, de Sudamérica, todavía se dice que una enfermedad que va a ser de raza negra, ¿verdad? No van a incluir que somos todos con taínos, caribeños, el caribeño, la sangre corre, el rasgo puede ser de cualquier país. Y ahí es que yo pienso que historialmente hay que cambiar la conversación de dónde está esta enfermedad. No se debe de poner de una raza. Hay que entender quién es el latino. Y por ahí entender que todos tenemos probabilidades de tener este rasgo. Y yo pienso que ahí es que está el dilema con nosotros. Yo he encontrado que yo he viajado y cada vez que viajo cojo la oportunidad de conocer personas con la anemia falciforme y donde voy ha sido la misma conversación. Si uno va a Brasil, y yo he ido a Brasil y conocido personas, si yo tengo la anemia falciforme, es todavía una enfermedad que es rara, como dicen, una enfermedad huérfana, y hay un grito de personas que tienen esta enfermedad y lo que necesitan es decir por qué es que los médicos no están ignorando. Y está ocurriendo en nuestro país, aquí en los Estados Unidos, y sigue en los países también hispanos, y hay que cambiar esa conversación porque hay que ya, aunque la historia es importante, ahora hay que introducir que ya somos multicultural. Y ahí es que tiene que cambiar la conversación para subir la conciencia sobre la enfermedad de nosotros y poder tener los tratamientos para nuestra enfermedad y el sufrimiento.
Gracias, Nilda. Sergio. You're muted.
Sorry. Yo creo que los países latinoamericanos lo que a ellos le hacen falta son el desarrollo educativo y el desarrollo tecnológico para que la población pueda ser más educada y tengan procesos innovativos que puedan ayudar para detectar la enfermedad de una edad temprana, no solamente de los hijos, pero también de los padres. Y esa falta de tecnología y de innovación y de educación también, porque el gobierno ayuda mucho en esos departamentos. Cuando el gobierno considera que hay algo que el pueblo tiene que saber o tiene que estar informado en eso, todos los gobiernos de todos los países encuentran una forma para anunciar y para que la población esté informado en cualquier asunto que el gobierno considere importante. Entonces, yo considero que eso es falta de muchos gobiernos que no tienen prioridades acerca de el bienestar de la población cuando se viene a diferentes condiciones que no tengan un porcentaje tan alto o no tenga tanta publicidad como otras condiciones. Y entonces yo considero que eso es algo que se puede desarrollar y que se pueda mejorar.
Muchas gracias. Antes de continuar, me gustaría saber si alguien en Zoom le gustaría comentar algo. Con mucho gusto levanten su mano y nuestro equipo de Tech que va a ser quien va a brindar, los va a brindar para que puedan participar. Voy a dar un minuto a ver si alguien quiere levantar la mano y participar. Ok, we'll continue. Vamos a continuar. Otro creo que tema importante y creo que Cole lo mencionó un poco, que fue el tema de su perspectiva como madre, ¿no? Creo que es algo muy, muy importante y me gustaría escuchar a cualquier persona que obviamente sea padre de alguien de algún guerrero que tenga la falciformes o el rasgo de ambas, pero me gustaría escuchar también cuál es la opinión de Servio, de Nilda, que han visto por parte de sus padres. O sea, cuál ha sido el principal obstáculo en poder ayudarlos a ustedes, en escucharlos, y cuáles son los consejos que le dan a nuestra comunidad para ustedes como hijos o al sufrir enfermedad, darles ese apoyo moral mutuo, ¿no? En el cual no solamente son los padres hacia los hijos, sino es una ayuda mutua. Y a veces creo que se puede dar el miedo a expresar ciertas cosas. ¿Qué tipo de consejos se pueden dar mutuamente? En este caso, cualquier padre que esté ahí, que quiera participar, y me gusta escuchar la perspectiva de Servio y Nilda al mismo tiempo. Muchas gracias.
¿Quiere ir yo?
Sí, adelante, Nilda.
¿Sí? Sí, en mi familia, gracias a Dios, yo he tenido un apoyo de madre y mi familia entera es un apoyo grande que yo he tenido. Mi mamá siempre ha sido una persona que desde que nací con la enfermedad le he leído mucho. Ella, si yo hubiera podido estar en un globo de cristal, lo hubiera estado. Ella, con todo que yo hacía, era no salir sin el abrigo. Son cosas que uno tiene que tener cuidado, porque cuando uno es padre, uno nota que con esta enfermedad, si la temperatura cambia, y ahí es de una vez que empiezan los dolores, son muy atentos a asegurar que uno no está saliendo sin el abrigo, bebiendo mucha agua. Los padres, como dicen, que son de helicóptero, que están arriba de los hijos, así era mi madre. Era una persona que pienso que cuando uno tiene una crianza con esta enfermedad da mucho miedo y quieren saber cómo tratar, cómo manejar, cómo cuidar, cómo evitar y buscan por todas partes en cómo ayudar su hijo, su hija en ese sufrimiento. Pienso que a veces es dañido porque en esta enfermedad nosotros pasamos por mucho dolor y lo que hay es la depresión. Y también hay veces que uno no quiere ser honesto y decir que la depresión existe, especialmente cuando uno está yendo con unas etapas que son altas y bajas en lo que es la enfermedad y lo que es viviendo una vida y tener lo que es la normalidad para esa persona. Hay una comparación de que yo puedo ser esto o no puedo ser esto. Y a veces hay personas que le cogen miedo para tratar. Y mi mamá era una persona así, que aunque yo llegué a hacer muchas cosas en mi vida, era con un miedo que hasta cuando llegué a una edad adulta, yo hice muchas cosas que no pude hacer en la juventud. Pero también siempre los padres saben y habían cosas que yo hacía y me recordaba, yo tenía que escuchar a mi mamá porque ella estaba en lo cierto. Tú sabes, si salgo, juego, estoy mucho de noche, estoy bailando, no estoy bebiendo agua, caigo enferma y me lo habían dicho. Entonces, a veces uno tiene como un contra de positivo y negativo y hay que tener cuidado en cómo manejar, porque puede ser algo que puede afectar a la persona que se está criando con esta enfermedad, a dejar que no haga y no supere. Y después también hay las personas que hacen demasiado y la enfermedad entonces te recuerda que tú tienes que coger las cosas un poquito más lenta. Esa ha sido mi experiencia.
Fabián?
That is a good question. I think the biggest, I think my dad, my father, he did a very good job as far as finding as many doctors as possible and informing himself and educating himself and trying to educate myself as far as taking care of myself when I was very young at an early age. And I think the biggest challenge was, the most difficult part of the whole treatment with sickle cell anemia, managing it, was just whenever I wasn't very how do I the word I'm looking, very diligent, or I kept I would say focused or consistent with taking care of my health. So whenever I did something like not sleeping enough hours, or not eating enough food, or not drinking enough water, or exercise too much, or pretend like I was a kid without sickle cell anemia, like I pretend like I was just like my peers, that was probably the most difficult part. Of course, I didn't do it on purpose, but it's just things that happen that you just don't think about at an early age, and then eventually you start adapting to the change and to the consequence. So with that being said, the other part of the question, I'm sorry, what was the other part of the question?
The challenge with the parents both ways, as you being the kid, their son, and the parents kind of encountering. What do you think are the biggest challenges that you saw they encounter throughout that period of dealing, of course, with you and being trying to live your life as you just mentioned, as the rest of your peers, but what are those challenges that you saw throughout that time, and how do you connect with them in a proper way?
Right. As far as the relationship between my parent to child, I would say that would be the biggest challenge. And the other part of the question, now I remember, was what type of advice would I give to parents or to children? Well, clearly, to children that have sickle cell anemia, I would most definitely tell them to always listen to your parents, even though it doesn't sound like it's a fun thing, or it doesn't sound like, they're being nice or what have you. They know, because they've taken the time and they've spoken to people that know what they're talking about, professionals that have been studying and working their entire life, and they know just as much as the doctors, or they know as much as what they need to know. And as far as the parents are concerned, I would always encourage parents to always listen to their kids, and always listen to their kids. And whenever, your kid does say something, as small as it can be, just monitor it closely. And, because any small thing could become a huge problem afterward.
Thank you so much. And I think en este momento creo que Silvia Lucero quiere participar, entonces si nuestro equipo de tech nos puede ayudar para escucharla.
¿Me escuchan? Ay, no.
Escuchamos,
¿Hola?
gracias.
¿Sí?
Así es.
Ok, no, como no aparece mi nombre, no sabía si me escuchaban. Bueno, no, la verdad es que no entendí lo que dijo Servio, me hubiera gustado haberlo escuchado, pero bueno, haciendo alusión a lo que decía Nilda, la pregunta mía, viste, es hasta dónde, o cómo uno como madre, yo ya perdí a mi hijo por esta enfermedad, pero me remonto a la época que yo lo tenía a Frankie, cómo un padre o una madre puede encontrar el equilibrio entre cuidar al hijo y no sofocarlo, ¿no? Yo a mi hijo también le decía, abrigate, salí con el abrigo, que ojo que la lluvia, que ya cuando se puso adolescente, y ojo que no vuelvas tarde porque te va a hacer mal trasnochar, tenés que descansar bien. El tema del alcohol, que los chicos ya a esa edad, bueno, hacen fiestitas, de hecho mi hijo acá hacía baile, fiestas, y bueno, y alcohol, la verdad es que corría el alcohol. No en demasía, nunca hubo ningún problema, por supuesto, pero la hematóloga le decía a Franco, no tenés que tomar alcohol porque es contraproducente. Entonces, uno se pregunta como padre, ¿hasta dónde vos lo cuidás a tu hijo, le das información, y hasta dónde el hijo ya tiene el libre albedrío de elegir cómo vivir su vida, ¿no? Franco nos decía, déjenme, yo voy a vivir como si no tuviera la enfermedad. Y de hecho así la vivía él. Por supuesto tenía sus recaídas, sus internaciones, pero cuando él se recuperaba, hacía su vida normal. El colegio, bueno, después facultad, pero bueno, y uno como padre con el corazón, como decimos acá en Argentina, con el corazón en la boca, ¿no? O sea, con ese miedo de que le pase algo. Entonces, bueno, a eso me refería yo, hasta dónde uno puede, digamos, a mí me interesa toda la información, pero yo, por ejemplo, trato de filtrar cosas con la gente de mi grupo porque yo entiendo que los padres tienen un miedo terrible a que les pasen cosas graves, a que se mueran sus hijos. Esta es la realidad, a que se mueran. Entonces, uno dice, ¿hasta dónde, no? Dar información y hasta dónde no. Yo ahí hice un comentario que una vez a mi hijo la hematóloga le dijo, todavía era la hematóloga de pediatría, le dijo, pero Frankie tendría 17 años, a los 18 pasó adulto. Un día me dice, mire mamá, le voy a decir todo lo que esta enfermedad puede traer como consecuencia a su hijo. Entonces yo le dije, de ninguna manera, usted a mi hijo no le va a dar esa información, porque en realidad usted no sabe si mi hijo va a tener todas esas consecuencias. Pues usted lo está limitando y va a tener miedo de vivir, miedo de salir, miedo. Entonces me dijo, bueno, está bien, acepto su propuesta, pero si él me llega a preguntar, yo no voy a mentir, yo le voy a decir la verdad. Bueno, y una vez en el colegio, cuando Franco pasó de la primaria al secundario, con esto del ejercicio físico, que los chicos no pueden extenuarse, bueno, llevé un certificado y el colegio entró, la directora entró en un pánico, que tenía miedo que le pasara algo a Franco, y entonces lo derivó a régimen de proyecto, que se llama. O sea, nada de actividad física y ellos rinden el reglamento de cada deporte. Mi hijo, lo mal que se puso emocionalmente. Me dijo, mamá, ¿cómo me mandan ahí? Es horrible, soy el único, para colmo el único chico que estaba haciendo eso. Entonces, bueno, fui al colegio, bueno, hice un poco de lío, llegó hasta la parte, digamos, de educación privada de acá, de la nación, el caso, y bueno, en definitiva terminaron hablando con la directora y le dijeron, no, si el chico llega a un certificado, que haga actividad física y que el chico lo regule. Se habla con el profesor para que sepa que el chico tiene esta enfermedad y tiene sus limitaciones, pero que el chico lo regule solo, que tome líquido, bueno, todo lo que el médico había expresado. Y bueno, ahí por suerte mi hijo pudo hacer una vida normal, digamos, ¿no? Porque estaba totalmente angustiado. Entonces, a eso iba cuando yo proponía esto de un psicólogo, una psicóloga, ¿no? De estas herramientas, porque uno dice, ¿hasta dónde? ¿Hasta dónde un papá o una mamá los cuida? Pero también hay que darles un poquito de alas para que vuelen y que sean libres y puedan vivir una vida normal, dentro de las posibilidades, por supuesto, de cada chico, y yo sé que hay casos que son más complicados que otros, eso desde ya. Pero bueno, darle un poco la alegría al chico de vivir, ¿no? Entonces, a eso iba, y que los padres aprendan a manejar el miedo, que es lógico que se tenga. Bueno, eso quería comentar. Gracias por darme espacio.
Muchas gracias, Silvia. De verdad que, pues claro, es importante escucharte y obviamente tus consejos van a aplicar para mucha gente, van a darles una mejor idea de cómo pueden ayudar a sus hijos y especialmente algo que hiciste, que fue escuchar a tu hijo. Muchas gracias, de verdad. Well, I'm gonna now speak in English, and what I would like us to do now is I would like to hear from you all, and if you can just write in the chat if you are in the Zoom, and I would like to hear from Nilda and Servio as well. But now I would like to brainstorm on what are the topics that you like to hear from for next year. One of those was addressed by Sylvia, and she was asking us to address mental health next year. So we have it written now, and for sure next year in our third annual Hispanic Heritage Educational Seminar, for sure we will be addressing mental health. But I would like to hear from you both. What are your thoughts and what kind of topics that you think would be great to address next year? Sergio, thank you.
One of the most interesting topics that is very, very important that I have never heard discussing in any educational seminar as far as sickle cell anemia is concerned would be the topic of comorbidities. I think that is a very important topic that needs to be discussed, because the issue with comorbidities is that people only believe that sickle cell anemia is a singular condition. And from what I've seen thus far is that sickle cell anemia affects you and the next person differently. In addition, I've noticed that sickle cell anemia not only does it affect people, it's a blood disorder. I've also noticed that people that actually have the sickle cell disease, I've noticed that those people have comorbidities. For instance, I I myself, I have dilated cardiomyopathy. That's something that was never diagnosed until I was like 20, 21 years old. And that was a comorbidity. Recently, I did another seminar that I moderated with somebody else, and that co-moderator that I had, she had sickle cell anemia, but she also had a completely different comorbidity, which was a brain issue that she was prone to having strokes, and I think she had like 2 or 3 strokes in her life, and she was taking a medication to prevent that from happening. In addition, one of the strokes that she had, it took away her speech, and she had to go through therapy so she can work on getting her speech back, and eventually she did get her speech back. So comorbidities is something that is a big topic that should be discussed in great detail on the next seminar.
So much. Thank you so much. Nelda?
So I have to agree like 1000% with Sergio, because I am, what he is speaking of is personal to me, as I know many persons in the sickle cell community. We speak of sickle cell, maybe at times we can relate with a vascular necrosis, but then I've counted the complications, just added my 26th symptomatic complication. I take like 15 medications because I have solely 2 organs that do not have a complication from sickle cell. But everything else, I have a complication, and within each organ, I have like 5 symptomatic complications within that organ that requires a medication. So it is very true what he is speaking of, because we do solely focus, yes, sickle cell, but sickle cell affects, we also have to remember we're also human body, and that human body, aside from having the damage from the illness, it's also having the damage from just being human overall. And it is true to where we do not speak at times of the damage of the infarctions, the memory, the sleep. Why do we not sleep? Why is it that majority of us are known to be awake at night? So I would love to see, aside from comorbidity, is also sleep studies. There has to be a reason why you can be in a hospital and know who is the sickle cell patient, because majority of us are all awake at night in the middle of the night, and we all have our trays with our meals throughout the day, simply because we're resting in the daytime. And there has not been a link to understand those sleep studies. Depression is another topic that is not truly we are speaking of mental health and awareness. However, we're not speaking of the depression that occurs from the post recovery of a sickle cell crisis, that at times can become more difficult than the crisis itself. And it has to do with the resetting of your body coming away from all the medications that was received in a medical setting, and then going at home to a individual that maybe does not have the medication to tear off the medication, or the individual that is cut off from the medication as a whole and then is suffering withdrawals that are linked to what a individual is going through in rehab, and they have to understand those cycles of those withdrawals. So there's several topics that cover within the realm of sickle cell that need to be discussed in more detail, not just the surface, but sorry, that the audio, I'm not sure if the audio was interrupted.
No, you're good.
Okay. Yes, I said a lot. I'm sorry. Apologize.
Not at all. Thank you, Nilda. You're always great. Thank you so much. And I think I will turn it to Dr. Ali. Thank you for joining us, Dr. Ali.
Yes. So, everyone, hey, we began at 9. Guess what? It's almost 4 o'clock. And so I want to stay on with my program manager and the moderators and just say first, thank you, thank you, thank you. We did it again. And Servio, you were part of the first one. Thank you for being part of the second one, and we hope that you'll want to moderate again for the third one. So thank you
Thank
again.
you. Thank you,
No,
Dr. Ryan.
you're you're wonderful, and I hope Mary and I both hope as well that this is something that you'll want to do as well, is assist us with the planning for the third annual. So we thank you both for participating. We truly could not have done this without you, and I think you know that, but we could not have. This was a very full agenda, and we hope that we presented something for everyone. And so now we have some ideas, and so Mary and I will take this and then put together our team and then have everybody participate. So thank you. Thank you to our attendees for coming in from everywhere. So even though it's only going on 4 o'clock in Pacific time, we know that it's going on 7 o'clock Eastern time and add a few more hours in the UK, about 10 o'clock. So depending upon where you are, we thank you for spending your Saturday with us. So thank you. And I do want to thank Mary. Seriously, Mary, Cayenne Wellness Center is blessed. I know that you're blessing us with your skill set, your knowledge, your passion, and your enthusiasm. So thank you so much for putting this together. And of course, we want to thank our tech team, OMI, who kind of seem to always be there for us in terms of managing, this tech world. Yes, we're still in Zoom, but we're also in another platform as well. So it takes some finesse. So thanks, Curtis and Pat and Dominique. And all of our speakers. Our speakers, Jacqueline from Sickle Cell Disease, SCDC, Dr. Keith Carello, my brother, and my friend. We thank the Global Patient Panel with Nilda and her mom, Sylvia, Timetas, Florencia, and Veronica. We thank Elle Cole and Dr. Austin and Basante. So it's going to be a very rich third annual. And so we're going to do this again. So in terms of the closing remarks, I think you guys know that it was about time. And that's one thing that I can say about Cayenne Wellness Center. We've been thinking about this for a while. So just let you know, we didn't just pop up and say, let's do it. Everything that we do is strategically planned, and we know that there needed to be something. And so we delved into it, and with your support, and if you want us to do this again, we will. We know that there needs to be something for those who speak Spanish where English is not their first language, and they need to get the same information. They need to find out about the basics. That's why we always do Sickle Cell 101. Just need to know the basics. And of course, we're going to delve into some of these other topics. And so we do this because we realize that with health literacy, a lot of people still do not put it in Spanish. And so everything that is done, whether it has to do with modifying therapies or even gene therapies, or which they call curative therapies, needs to be in Spanish if you want the world to participate. And the world is just not the US, and the world is just not those who are English speaking. So we hope that we've done our due diligence by presenting to you a very rich agenda that was translated in both English and Spanish. And let us know how we've done. Let us know if that actually worked with you, because we're also open for improvement. And so, Mary, I'm actually going to let you take us out. But before you do, let's hear from Nilda, Servio, and then Mary, you're going to do the closing. So, Nilda, as a co-moderator, we want you to have some final remarks, followed by Servio and then Mary.
Yes, thank you. I wanted to say thank you for reaching out to me. Mary, you have done an exceptional job. Dr. Rowley, from the instance that we met each other at doing different works and councils together, it has been a pleasure. It's like you have mentioned, this is a true need. I feel that although we are an existing community, we are not communicating as we should to support one another. Our blood sisters and blood brothers, like I say, every time I meet someone with sickle cell, I say we're related. It is an honor to have done this. This is the first time I have moderated, so I thank you for the opportunity. And it has been a learning, but such an achievement, especially knowing that there are others that have been connected from whether Caribbean, South America, it is, you have reached globally. And while the session has gone throughout the day, I have received comments on thank you for the information in regards to the physician, because although there were therapies and treatments that may not be available to them, it is still a sign of hope. And I think that that is important, especially I always tell my mom, I feel content that I've reached the age that I have, and I want things to be better for the younger generation. And I believe that right now we're living in a time of inclusion and representation, and it is including everyone that needs to be heard. So I thank you. And again, you are changing, even if it's just one person, it is one person additional that either if they know something for their own health or for a family member, it is an enrichment that they've received with your information today. Thank you.
I just want to say, thank you to Cayenne Wellness and for Dr. Ali always keeping me in mind and having me participate in these events. It was a huge learning experience, especially the first presentation as far as like the medical review of it. It was a huge learning experience. That presentation had so much insight, and I hope all the people that were part of this event, they were able to get some information from it, and they were able to learn from everything that has been said and everything that has been presented. With that being said, I am looking forward to the next one, and again, thank you everybody for attending and for hosting this event and for having us in, and to have a great weekend.
Thank you, Sergio. But well, so it is time, and Cayenne Wellness Center is more than happy to officially conclude our second annual Hispanic Heritage Educational Seminar. We'll see you next year. Hopefully, you had an amazing time. You'll learn a lot, and of course, we'll see you next year. So, bye-bye, everyone. Thank you.
I wanted to mention, Mary, that this is being recorded. And this will be available.
Yes.
It will be available. And Mary is really good at sharing when the recordings are up on our website. So thank you. Go ahead. Now you can say goodbye.
Now we say goodbye. Thank you, everyone. Bye-bye. See you next year.
Adios.
Bye, everyone. Take care.
Bye-bye.